I gave you the momentum and so actually reach the meeting. Even I would like to stay that. But very long, very nice. Thank you. Happy to see you.
Thank you, ma'am. I request everyone to complete the field test now, which is posted in the TME WhatsApp group.
Yes. J. Yes. J. Yes.
It is the time for a scientific session now. Knowledge shared is knowledge multiple. The first topic for today will be AMR Breaking the Silence by our Assistant Professor of Microbiology, Dr. A. Madhumati ma'am. I request Professor Dr. Teresh Mary ma'am, Department of Microbiology, Bharat Medical College and Hospital, and Dr. S. Ravikumar sir, Associate Professor of Microbiology, JKMC, to chair this session. First of all, I congratulate Dr. Tyagarajan Ravindra, Professor and HOD of Microbiology, and the dynamic team behind you for organizing this wonderful CME. And I also thank sir and the team for giving me the opportunity to chair the session. So it's my privilege and pleasure to introduce the great speaker, Dr. Madhumati. And she is an encyclopedia of AMR. So she is the right person to talk about this. She is qualified undergraduation from Thuthukudi Medical College, and she did her MD at Madras Medical College. Currently, she is working as Senior Assistant Professor of Microbiology at GKMC, and her total experience is about 19 years. She has so many publications, national and international, to her credit, and she's a guide for ICMR SPS and also a PG guide. And she is very thorough in AMR. So whatever the doubts we have, we used to ask her, and she used to update each and every year the AMR CLSA guidelines. So over to Madhu.
A very good morning to one and all. Thank you, ma'am, for that wonderful introduction of me, and I hope I stand to that. This session is actually an answer to the question on why we chose this theme on our roadmap to antimicrobial stewardship. You will get to know the answers. It's just a prelude for our upcoming interesting sessions for the day. And I will be updating in the next 30 minutes on what is happening in the field of antimicrobial resistance. So without any further intro, we will go to our session. So my objectives for the session are: what is AMR, what is the global and Indian scenario, the prevalent molecular mechanisms behind the current trend, the diagnostic dilemmas, the therapeutic challenges which we face in AMR, the challenges in its containment, and what is our roadmap to the action against AMR, the prelude for our CME for the day. So coming to AMR, when I looked into the definition of antimicrobial resistance, I couldn't get a clear-cut definition. This is what the WHO says. Antimicrobial resistance occurs when bacteria, virus, parasites no longer respond to antimicrobial medicines. It is a natural process, but we accelerate it with our overuse and misuse of antibiotics. There's nothing wrong with bacteria adapting itself to overcome what is dangerous to it. But what is giving us some concern is the accelerated rate at which AMR is on the spread. So why is it a concern? As we all know, antimicrobials are the cornerstone of modern medicine. And these drug-resistant pathogens are threatening our ability to treat the common infections, an enteric fever, antibiotic-associated colitis, a simple skin and soft tissue infection, our post-burn wound infection. All of those are going to be very difficult to treat. And we have a large number of immunosuppressed population thanks to advance in modern medicine. But these patients who have escaped those non-communicable diseases are going to succumb to infectious diseases if you don't have a good antimicrobial agent. And it is a problem across the globe and all income levels. So we had a golden era from the 1930s to 1960s when antibiotics were the end. Nothing can stop us. But then in the 1990s, the resistance started to creep in, and that is when, but we were not concerned so much. We looked up at 2010 when we started reporting extensively drug-resistant mycobacterium, pan-drug-resistant Acinetobacter and Pseudomonas. Now, 2020 has also reported Streptococcus-resistant Pseudomonas and Acinetobacter. So as you can all see in this timeline, every decade following the introduction of an antibiotic, the bacteria becomes intelligent and starts producing resistant mechanisms. We discovered the penicillin in 1930s, and in 1940s the bug developed resistance. We had imipenem somewhere between the 1980 and 1990, and imipenem resistance crept in 2000. That shows how fast the bacteria is adapting and where we stand. So we all know the contributing factors for AMR: lack of access to clear sanitation, poor infection control practices, and poor accessibility to diagnostics and affordable vaccination, lack of awareness, and lack of enforcement. So coming to why do we call AMR a silent pandemic? WHO has not declared officially AMR as a silent pandemic, but it has recognized and describes it as silent pandemic. Why is it silent? This is a slow-moving health crisis about which we don't have much of a concern because it is not dramatic, just like what we had now, COVID. We had a lockdown, everybody was wearing masks and N95 masks. Even our patients were wearing coming in. But none of us are bothered about the antimicrobial resistance, which is actually a worse pandemic with a very high mortality. So now coming to where do we stand? I will be discussing in the next couple of slides the global scenario and the Indian scenario, and majority of my data are from these two standard summary reports released in 2025 by the ICMR and the WHO. So the GLASS is the global antimicrobial surveillance system introduced by the WHO in 2015, and it extended to include even the antimicrobial use in 2020. And it has reported over 23 million bacteriologically confirmed infections, estimating resistance to 22 antibiotics. There are 4 types of surveillances under the GLASS system: the bloodstream infection, the GIT, urinary tract, and the urogenital gonococcal infection. So now what is alarming in this slide is the one in dark blue shows a more than 30% rise in the AMR trend. And you can see the most commonly occurring infection, the urinary tract infection, is showing a very high increasing trend in the antimicrobial resistance, especially in our area of Southeast Asian region. Even in the other infections like the bloodstream, the GIT and the GIT, there is an increasing trend in antimicrobial resistance. But what is alarming is the rate in the urinary tract transmission. And these are the 9 high priority pathogens which the WHO is concentrating on: the 3rd generation cephalosporin resistant E. coli, the CRVs, the 3rd generation cephalosporin resistant Klebsiella, carbapenem resistant Klebsiella, the crab, MRSA, fluoroquine resistant non-typhoidal Salmonella, Shigella, and Neisseria gonorrhoeae. Now, these are some information which I could gather on the prevalence of drug resistance. What you have in the first circle is the global percentage of AMR, and what is there is the Southeast Asian region. As you can see in our area, E. coli isolated from urinary tract infection is showing a more than 60% resistance to the 3rd generation cephalosporin, and the resistance to carbapenem in E. coli is also creeping in around 20%. You can also see the fluorophylum resistance is pretty high, around 60%, showing us the commonly treated UTI in the OPD settings will no longer be treatments in OPD settings, but will shift to IP settings. Klebsiella pneumonia, you already know, is a notorious pathogen, and it also has a very high predilection resistance pattern for the 3rd generation cephalosporin, and the resistance to carbapenem is even higher when you compare it with E. coli. Coming to the drug resistance pattern of Salmonella isolated from the GIT, our blood, butter, and jug ceftriaxone has not reached that much of a resistance pattern. But what is alarming here is the fluoroquinolone resistance. And in Shigella also you can see a very high percentage of fluoroquinolone resistance. Coming to bloodstream infections, our top culprit always is Acinetone when we go to the intensive care settings. You can see those orange bars have crossed the 50% mark. Right? So be it aminoglycoside, carbapenem, both of them are having a very high resistance due to Acinetobacter. Coming to E. coli, these bloodstream infections are usually representatives from the intensive care unit. So we will be having a pretty high predilection of antimicrobial resistance. The 3rd generation cephalosporins here also have a more than 60% resistance. Coming to the resistance pattern in Klebsiella pneumoniae, similar to our Acinetobacter, with a very high resistance against 3rd generation cephalosporins, carbapenems, and fluoroquinolones. Strep pneumonia we always think is very safe. All GPCs are safer to treat other than MRSA. You can see that even strep pneumonia is going to show a resistance to the beta-lactam antibiotics and the potrimoxis. So that was the global data. Now when we localize it to the Indian data, which is based upon the ICMR's AMRSN, it collects data among 6 key pathogenic groups, and it also provides an insight into the molecular pattern available by doing a whole genomic sequencing. So this is what is the trend of E. coli isolated from bloodstream. You can see in Indian scenario a dip in the susceptibility pattern to aminoglycosides, imipenem, and meropenem. And it is already low for ceftazidime and ciprofloxacin. And this is the pattern in urinary tract infection. And again, you see a dip, the susceptibility pattern for the last 5 years for imipenem and meropenem, piperacillin azobactam with the aminoglycosides still holding the fort for us. Coming to the resistant pattern of Klebsiella pneumoniae, the susceptibility itself starts with only 60%, showing that more than 40% of our isolates are going to be resistant to meropenem, imipenem, and aminoglycosides. The same picture is also there for the urinary tract isolates of Klebsiella pneumoniae. This is the susceptibility trend of Pseudomonas aeruginosa, where only colistin holds the foot there, with amikacin, ceftazidime, and with imipenem, meropenem reaching only a 70% susceptibility, reporting a 30% resistance. This is what is there for Acinetobacter, with this minocycline not available in many of our limited resource settings, which is holding the foot there, with more than 80% reporting resistance to meropenem, ceftazidime, amikacin. This is for Stewardship multifilla. You can all see these are rarely isolated bugs and they have a very good susceptibility pattern. Somewhere around 70 to 80%. Salmonella typhi, our good old ciprofloxacin is no longer going to be useful, but ceftriaxone, azithromycin still hold the fort there. The same stands for Salmonella paratyphi A also. Now, we were discussing about the global scenario and the Indian scenario, but what is becoming more important is knowing the molecular mechanism behind it. We never worry about, as a microbiologist, we always satisfy ourselves with reporting whether it is sensitive or resistant to the particular antibiotic. But in this era of AMR, the word molecular mechanism is going to be of much diagnostic significance and therapeutic importance. So my report on the AMR prediction is going to be based on these two summaries. And why do you need to understand the molecular mechanism? The therapeutic option differs. No longer carbapenem resistant colistin, carbapenem resistant ceftazidime avibactam, carbapenem resistant azithromycin. Have to know the molecular mechanism behind the resistance to detect or to decide on what antibiotic you're going to use for your patient. These are some guidelines available in the ICMR which tells you what antibiotics to be prescribed for which type of molecular mechanism. So now coming to E. coli, studies show that E. coli shows if it is going to be a carbapenem resistant E. coli, it is more of a metallo-beta-lactamase resistant. You can see a very high bar for the NDM, the IMP, and the WIMP, which are metallo-beta-lactams, and they have, if the E. coli is a carbapenem resistant E. coli, it is going to harbor these genes. Now, can anyone tell me what is your antibiotic of choice if it is going to be a metallo-beta-lactamase? Are we safe in giving ceftazidime avibactam alone, or do you need a combination of ceftazidime avibactam with azithromycin? It is going to be a combination. So to decide your antibiotic, you need to know the molecular mechanism behind it. But the picture is different for the other Enterobacteriaceae which we commonly isolate, which is Klebsiella pneumoniae. Here you have an increased predilection for the OXA48. For OXA48, the treatment with ceftazidime avibactam alone is enough. If needed, you can add azithromycin. It is good. And the second commonest molecular mechanism which Klebsiella pneumoniae exhibits is a combination of OXA48 and MDM. Coming to the molecular characterization of carbapenem resistant, there again it is going to be NDM, the commonest presentation. And what is even more worrying is there are more combinations also available where NDM along with an ESBL gene is seen. This is our Acinetobacter. Acinetobacter also produces a lot of co-producers where you have both the genes. Acinetobacter more commonly produces an OXA23 type, not a metallo-beta-lactamase type. But what is difficult there to handle or treat is there is an increased percentage of co-production of both NDM and OXA23 in Acinetobacter, making it a very big therapeutic challenge to the treating physicians. And this is something new, PV3 inserts. The PV3 is a site, penicillin binding protein site, where most of our beta-lactam antibiotics go and act on. And that is the hold where your antibiotics like azithromycin, ceftazidime, ceftriaxone, piperacillin, and cefiderocol go and bind. But what is happening now, thank God, is only seen, has been reported in E. coli is there is an insert in the amino acid sequence, the YK or the YK insert, which makes the binding of these antibiotics to the cell wall of the bacteria difficult. And so, patients harboring these PB3 inserts cannot be treated with cefiderocol, azithromycin, ceftazidime, avibactam combinations also, making it the use of fetal actives nil in case of reported TB3 inserts. There's also another variant called the CMY42 variant, which can also produce resistance to azithromycin, avibactam. Not much has changed in the gram-positive pathogen, enterococci. It is the VAN-A gene commonly reported, but there's one other novel plasmid which can co-carry vancomycin and linezolid resistant, again making it a therapeutic challenge for enterococci. Staphylococci, it is the sequencing has revealed multiple mutations in the VRASR gene, and there is some phenotypic resistance of linezolid documented. We couldn't find out the molecular mechanism, but if you do distribution on MIC, linezolid resistance has been reported. So with that, we know the molecular mechanisms, we know how to treat, but still there are a lot of diagnostic dilemmas and therapeutic options. Earlier, reporting AST was as easy as this. You just hold the plate, note down the zone of inhibition, you report it. Sensitive, resistant. No longer reporting AST is that simple. This is an amalgamation of all the methodologies we have for reporting antimicrobial resistance. We started with the good old Pipoios distribution, then we had the key strip, then we had the agar dilution, broth macro dilution, broth micro dilution, then automated methods walked it. We had the white tip, the gene expert, the Maldindorf. Then you had biofire, which could detect the mechanism of gene resistance. And what we have last is the Pontoc next generation sequencing machine, which can give you the sequence. With so much of methodologies available to us, still we have a lot of unanswered questions. Is conventional method good enough in a resource limited setting like mine, where going in for a biofire panel or a gene expert is going to be expensive? Is conventional method good? Do I need an automated method for AST MIC? But even that has its own drawbacks. Some pathogens cannot be reported in an automated MIC method. Should I use a CLSI guideline or a new class guideline? Should I use the newer version of CLSI? I can only do a gentamicin distribution or an amikacin distribution, but certain recommendations no longer have amikacin, no longer have gentamicin, no longer report goods. Can I go back to the older CLSI for that particular breakpoint? Which platform of PCR to use? I have a real-time PCR, but what is now available is CPNAP, but it is not cost-effective to me. Can I do a point of care testing? Is it affordable for me? Can I do a biofire panel in my institute? Am I missing out if I don't do a whole genomic sequencing or a next generation sequencing for this patient? Cost effectiveness is always a question in our setting. There's one important thing which we always have when we report a drug resistant bug. Is it a colonizer or a pathogen? Should I report it? We always end it with a disclaimer, kindly call it clinically. That is the biggest clinical dilemma which we will face when you report a drug resistant pathogen. We have a lot of investigations available, but this is my favorite slide. The concept of one size fits all is no longer available. You have to update your investigative modalities, your laboratories, because you cannot use a particular platform or a particular test to detect the mechanism or the AST of all bugs available. Evolve yourself, update yourself so that you can hold good the fort of giving good antibiotic prescription to the clinicians. So coming to the limitations which we face, now that we know our diagnostic dilemmas, we have a lot of methodologies. We detect the bug, we detect the resistant mechanism, we give your antibiotic of choice. But still there are a lot of limitations when you're going for the therapeutic option. Limited availability of effective antibiotics. These reserve antibiotics are usually toxic, and you may need repeated treatments because they are not available to standard therapy. And a combination of therapy is always needed, but you don't know what combination to give. For this patient, it is all tailor-made or custom-made. They're more expensive with a limited access. And the last one is even more alarming, emergence of resistance to even these drugs. So in the next 4 or 5 slides, I will show you some available antibiotics as therapeutic options, but each of them have their own toxicity, have their own limitations. For carbapenem-resistant Acinetobacter, we have ampicillin, sulbactam, tigecycline, minocycline, cefiderocol, sulbactam, darlobactam. Few of these antibiotics are not even available in the Indian center. We also have the eravacycline available, and each of them have their own longer duration of therapeutic administration you can have. The patient should be affordable, antibiotics should be available. Coming to carbapenem resistant, the first line for drug resistant carbapenem resistant enterobacterials are cefiderocol, ceftazidime avibacter. We have acetonam avibacter now available in the Indian market, meropenem barbobacter. The other recommendations in guideline are fosfomycin. Fosfomycin you always have a query whether to use it only for UTI or for other infections also. Polymyxin, aminoglycosides, tipicycline, avacycline, and see these are some of the newer drugs in pipeline, not yet in India. Maybe we will have them, but still we don't know their therapeutic efficacy. Coming to drug resistant, so difficult to treat Pseudomonas aeruginosa, there's only one green line there, which is cefiderocol. Other than that, it is a combination of any of these antibiotics which is going to be effective. So coming to the challenges with the containment of AMR, now we don't have so much about AMR. Still, you have a lot of knowledge on AMR, but still you cannot contain antimicrobial resistance. Why? Because the challenges are complex challenges. You have a lot of factors in that. The microbial factor, the antimicrobial agents which you decide. The bacteria develops new resistant pattern as and when you develop newer antibiotics, and the pipeline has dried up. Pharma companies are no longer interested in investing on newer antibiotics because the antimicrobial agents are developing a resistance pattern rapidly to those antibiotics. No alternatives to antibiotics, lack of vaccines available against communicable diseases. Human factor, increased high-risk population, you overuse and misuse broad-spectrum antibiotics. We don't have good infection control practice. There's an overuse and misuse of antibiotic. Poor human sanitation. And there are also a lot of diagnostic surveillances. I will not go through many of them. I've already told you with the diagnostic dilemmas. We don't have an adequate laboratory infrastructure. We don't have a good quantum care testing and insufficient standard of care for genomic typing. And it is an one health approach when it comes to antimicrobial resistance. So these are the other two factors which we don't have, but there are studies showing that now the resistance of colistin or the use of colistin in the livestock industry has come down following a lot of regulations, which is good for us. And finally, the funds to fight AMR are not that appropriate given the magnitude of the problem. So these are the challenges which we face in our AMR journey in the prevention aspect, the access aspect, the diagnostic and the therapeutic aspect. So coming to the topic, the theme of our CME, this is what made us decide we wanted a roadmap to have an action against antimicrobial resistance. And surprisingly, when I put this topic at the Google popped up these two things for me. WHO already has a roadmap. It is a roadmap given for the regional area of Southeast Asian region from the year 2025 to 2030. And in May 2026, the WHO has updated the Global Action Plan on the antimicrobial resistance. And this is the approach which the WHO gives, or the action plan which the WHO gives for AMR. And that is our ICMR guideline, which tells us the guidelines for a good AMSP. So this is what it's called PCA, a people-centered approach. The people-centered approach has two foundation steps. The two in gray are the foundation steps, which is effective governance with surveillance. Without this, you cannot have or you cannot contain AMR. And the others are the four pillars, the pillars of prevention, the access to good diagnostic services, accurate diagnosis, and appropriate quality of treatment. You can notice there are 13 implementation steps available. It is up to us to implement all these 13 steps. These are all open access, available readily. So I'm not going in detail about each of these implementations or these pillars. But in broad, this is what the WHO talks to us on the roadmap to AMSP. This was what I was talking to you about. The WHO updated its global action plan for the year 2026 to 2036. It gives us 6 strategic objectives, more or less the same, to bring about some changes across all sectors for all stakeholders, strengthen your surveillance system and laboratory network, intensify infection control practices, ensure equitable access, bring about some results and innovations in the field of AMR, strengthen governance, sustain financing and accountability. So now that the government and the authorities has given us a guideline, which is up to us to implement, review, all programs have pitfalls. You have to review them, validate, monitor, and update. You're going to do a good control of your antimicrobial resistance. And to conclude, AMR threatens modern medicine. you and I as a stakeholder have a role. Awareness programs like these will what is going to change into programs or change into implementable actions. Be responsible when you use your antimicrobials because these life-saving medicines are for future generations also. Antimicrobial resistance is not a future threat, it's happening now. Thank you, one and all.
Thank you, ma'am, for this enlightening session. Now I request Dr. Teresmeri ma'am and Dr. Ravi Kumar sir to felicitate Dr. A. Madhumati ma'am.
Thanks to Dr. Madhumati Madam for talk on antimicrobial resistance, and Madam has covered almost all the points regarding the AMR, like it's a silent pandemic, then glass, WHO glass, then the trends and establishment of this AMR, and Madam has identified the molecular mechanisms of bacteria for the combination of the therapy, which really very important for tackling this AMR resistance. And Madam was talking about this combination of therapy and the molecules, all the important mechanisms. And as Madam said, it has the important point in control this AMR is to monitor and evaluate and implement and the implementation of these programs. That's much needed for control of this AMR resistance. Now I need to Tasmani Madam for.
Thank you, Madhu. It was a wonderful presentation and it was a holistic approach. So I want to ask you one thing. Is there a role of AI in tackling AMR?
AI has two roles in tackling AMR. One is proper diagnostic sessions. The other is we have now apps available where you can put up your results, which will intimate the clinician that this is the trend of antimicrobial resistance that is to this patient. And also give it for the institution. And there are a lot of platforms which have started incorporating AI in microbiology, automation in total also. Not much I know about it, but AI will definitely give us a good support, not a competition, actually, a good support in tackling AMR.
Thank you. And you have highlighted so many new concepts like penicillin bag if notice free, etc. Thank you on them.
Thank you, ma'am.
Thank you, Madam.
Thank you, sir. Thank you, ma'am. Now I request Dr. Ananthakrishnan sir to felicitate the chairpersons, Professor Dr. Teresmeri ma'am and Dr. S. Ravi Kumar sir. Thank you, sir. Thank you, ma'am. Now let's move on to the second topic of the day, which will be on the first line of defense infection control practices by Dr. Subha ma'am, consultant microbiologist and infection control officer, Rela Institute and Medical Center. Now I request Professor Dr. Usha Krishnan ma'am, Department of Microbiology, Madras Medical College, and Dr. B. Ravichandran sir, Associate Professor of Microbiology, GKMC, to chair this session.
Happy and privileged to introduce Dr. Shubha, she is a consultant microbiologist now at Rela Institute. And she has finished her MD and Kasturiba Medical College and DNB and certified professional infection control professional madam. She has experience in various diagnostic laboratories, NRL, and she was assistant professor between 2010 to 18 at SRM Medical College, and she has been a very and resource person regarding topics, the current relevant topics of infection control. Over to you, ma'am. We are very eager to hear from you.
Thank you, ma'am. Thank you for the kind introductions. Esteemed chairpersons and respected colleagues and friends. Very happy to be here. All the more in a very important topic of the era on antimicrobial resistance. And a little detour on the entire day is this infection control topic. But I would not say the detour when it looks on the program. It is the first topic and rightly placed as the first line of defense when it comes to beating antimicrobial resistance. So coming to the topic, so infection control practices is a volume, is an encyclopedia of many things to mention. I only pointed out few things which is relevant straight away to the stewardship practices, antimicrobial stewardship practices. I'll be happy to take questions if there's anything late that I've missed out. Why we have to talk about infection control and antimicrobial stewardship? Straight away, this one beautiful slide, as the name comes, as the butterfly effect tells it all. What is this butterfly effect? The antimicrobial stewardship program can implement it alone as such as a say de-escalation therapy or a prescription auditing or giving the right drug, right choice. When compared to all of this individual antimicrobial stewardship approach, the rate at which reduction that can be implemented is only 17%. But when it is combined with interventions like anti-hygiene, it is clinically proven that it is 66% reduction in antimicrobial resistance. Such is the huge impact what infection control practice in an ideal sense can do to antimicrobial resistance in the long run today. And this is well proven close to a decade back itself in one of the esteemed Lancet journals about this butterfly effect. So having known the significance that it is so important, we'll see what is actual role. So the actual role when we tell CDC would define telling it is the right antibiotic, right patient, right time, right dose, and right. Where has infection control got in this stewardship practice? It has got in two important places. That is the way we handle the patient. So the right patient, every patient is the right patient for us to deal and implement our effective infection control practice and at all times. There is no one particular time that we have to deal. So this classic role is by preventing infection, and if infection has already occurred, we make sure that it doesn't spread across other patients. So it is at the level of breaking the chain of infection. And this is this one very beautiful position paper which supports this topic entirely, and I've taken many points which is evidence based from this journal itself. So this talks both about stewardship through the leveraging of infection control practice. So we know this beautiful triad, and which is why we are all here microbiologists on microbes, the host, and the chain. And we know what all goes to cause infection. This is just a completion slide, and it can be through the fomites, the practices, as simple as cleaning and disinfection practices, and to people, staff, visitors, and to another patient. And we know the classic elements of standard precautions. So is it all about infection control or is it more? This we know 80% of infections today at hospital anywhere is through hand hygiene. But are we done with just doing it right or is it more? It is more with appropriateness at every level that is part of this standard precautions. And we only say that safe injection practices. What exactly is safe injection practices? Many times the techniques which is involved in giving a medication might be just the fact that sterile precautions has to be followed. How is never told. How many of us really do we look at our own infection control nurses or rather other nurses doing the right thing? Suppose scrub the hub technique. Are we very clear in educating to our people that you need to do it for 15 seconds and make sure that you use the alcohol, swab to do that and allow it to dry for 15 seconds before we go in for administering the medication. This little nuances is all what goes into each of this line. So each of this can be a textbook in itself, we all know. So, and sterile instruments. We have a protocol and we all do our job as doctors and nurses what is meant. But if there is a little breach of any of the instrumentation, it can go a long way. Cleaning and disinfection. Can we say sodium hypochlorite for everything? May not be. There are special pathogens just inviting big time asking, I'm not going to be okay with sodium hypochlorite, and then you will have to think about hydrogen peroxide. So here are the challenges, which is something. This is the same topic as standard precautions, but it's not all. Standard is basically we say that it is for all patients, all specimen and sharps. But then transmission-based precautions does the job right. Especially the fact that we are talking about Candida auris, where hydrogen peroxide is the disinfectant of choice. It comes under contact precautions to be adhered. And where all of this disinfectants guidelines come from? The Environmental Protection Agency (CDC) has defined it to some extent Candida auris can be taken care by sodium hypochlorite, but the efficacy level must not be without hydrogen peroxide. So this fact, wherever possible, we try to implement. In a setup of ICU where there are vulnerable patients who are compromised due to various reasons. Let's make sure that right things go to the right patient in the strict sense. There is no compromise on that. So we know the various transmission-based precautions and the definitions of why each one fit into them. So I'm not going to elaborate them. Let's remember about droplet airborne. We know very well is the difference in the size of the particle. So this another beautiful slide which says everything about this transmission-based precautions with respect to the nuances involved in the various masking and handling of patients and equipment meant for those patients and the pathogens in question. The reason I put this is suppose contact precautions, we have Clostridium difficile. It's very easy to say that yes, I did the hand rub with the proper steps. So what more? We are dealing with a patient of Clostridium difficile. It's not going to heal with a hand rub. Hand rub is not going to work on the spores of Clostridium difficile. And that's where it is important to go for a hand wash. So this little nuances can go a long way. You have done the right technique. You made sure that you did what is necessary to the patient, but you didn't use the right procedure to do the hand hygiene. As simple as that, and then you go to the next patient and it disseminates. And we are talking about something as severe as Clostridium difficile, Clostridioides difficile in the new residents. So same goes with organisms under droplet and airborne. Let's also understand that the environment in which these patients are treated is also critical. We are talking about airborne infection. Let's make sure all the varicella patients as well as tuberculosis patients are under negative pressure. The least that we can do is 12 air changes per hour, where the flow of air is what is to be concentrated. So this is important such that the adjacent ward or the adjacent patient does not get infection from this patient. So these are the environmental precautions. I'm not going to elaborate on the chief, we all know. And CDC, I'm just projecting for us to know where we stand when it comes to infection control. We all talk the various elements of CDC for antimicrobial stewardship. Where does infection control come here? It is at the level of action, where implementing interventions in the right way and subsequently surveillance, tracking of the infections and making sure that the dissemination of this distant bugs doesn't happen. Reporting it at the earliest, which comes from the microbiologist, and educating the staff on ground of the pathogen in question and how to deal with it. So this is another beautiful slide. It's not very clear. Pardon me for that. It is an integrated stewardship model which talks about antimicrobial, infection control, and diagnostic stewardship. Where we have the entire day for antimicrobials. Diagnostics, I would not touch. The previous speaker has beautifully told about the availability of all the relevant diagnostics that can go a huge way when it comes to rapid diagnostics. So here I am for the infection control integrated with others. This is called the AID model, a paper from 2020. It is the antimicrobial infection control diagnostic. It's a stewardship synergistic model. So what does this say? It goes to say that let's be clear on that. Any antimicrobial stewardship team, may it be WHO or each of our institutes, is never complete without the infection control professional, without the stewardship team. What do they do? Or what they can do even more. It is the same position paper which says with action of what we already have in what we do, we can influence and facilitate a nursing role to initiate antibiotic timeout. How many of our nurses are aware of the fact that at 48 to 72 hours, we can take the help of a culture report to see that it is de-escalated or escalated. They would not do the prescription, but they bring it to the immediate clinician's notice. So it is indirectly the medical reconciliation happens within the time specified. Surveillance from us and provide appropriate feedback after the medical reconciliation is over. Education. So the perspective from the same the who had proposed this in the position paper says only 18% know very clearly what is the infection control role when it comes to stewardship practices. And most respondents have told that they spend 5 to 10 hours in stewardship activity without very clear of what exactly contributes to stewardship activity from the infection perspective, infection preventionist perspective. So for this, all of this have to do in our own setup. We need to clearly identify, define, quantify, and recognize. I might cite few examples from our own practice that we do and we intend to do as well. And this is from another, the same position paper. So this paper has also analyzed to see from the various experts and the registered nurses to their knowledge what they had found. It was from this perception leaders who had told this registered nurses antimicrobial stewardship perspective, knowledge, engagement, and education. When analyzed, it was found that only 11%, according to them, knew what their role in stewardship was, or rather, it was very defined to some extent, was only 11%. Let's look at the percentages, which is alarmingly low, where we can critically use in each of us area. So, when a patient has a positive culture, does the bedside registered nurse distinguish between infection and colonization? Anybody would be allowed to say that is an MDR, but an MDR could be a colonizer. Is that nurse equipped enough to know? They strongly agree only 11% may be equipped enough. I understand that these are the articles or position papers from the West, but we deal with these infections more than anybody. So it's time that we adapt and make effective use of our personnel, capacitate them to make sure our stewardship practice goes in line with or rather on par with any other country of the West. So again, they also agree only 21% where the bedside registered nurses know how to interpret microbiology. Obviously, the correct report comes from us. So that here the interpretation is when it comes to colonization and infection. An MDR infection is there are no pustules and no organisms in the sphere. So then MDR Klebsiella like the possibility of a colonizer. If this little alert, this little education is told to a nurse, they can go a long way. Otherwise, each of our busy practice, there are chances that this MDR Klebsiella, otherwise a colonizer, could be treated with ceftazidime antibacter, which could have been avoided. Irrespective of the cost of the antibiotic, we know what are the ill effects that would have on the patient. So this is the analysis from the same position paper. Besides, if they had looked at infection preventions, which means those who are trained, who have the knowledge of infection prevention and potentially microbiologists, where do they stand? So their education and training to the bedside nurses have been in person. So to a large extent, it's same with us also. We really don't train most of the nurses to that extent of picking up and escalating. So when a patient has a positive culture, infection preventionists can distinguish colonizer and contamination. Yes, most of the microbiologists will be able to do, and it stands at 89. So the infection preventionists know how to interpret microbiological reports, obviously. So it's 100%. So let's look at these two. But how many of us are in the action bedside all the time? So this is all the various questions that you have to counter. Now coming to the same synergistic activity table that this question paper says. Besides what needs to be done, surveillance is another important huge role. Many a time we would have heard that it is a very passive role and thus put to the patient. It's not like that. So it is the most essential first step in identifying priority areas of managing antimicrobial use. Let's microbiologists understand that how many times we look at the plate from a patient, blood culture coming Serratia marcescens. We know that this is otherwise the case of, say, infective endocarditis, admitted in an ICU for the last 1 week, and now there is Serratia marcescens. It is clear on the face to say that there is two set of bottles being Serratia marcescens. It's outrightly a hospital acquired infection. Don't you think we take a minute time to say there's something wrong there? Okay, that's surveillance. Here the surveillance was just the culture that we saw in the morning reporting. So it is very important step. I would immediately alert, just make sure that if there's disinfection practices around is fine. Okay, just see if there is a change in the staff that was being handling. This is the new staff, and there is an immediate curtail of that intervention in no time. That's surveillance. Tracking of patients who are found by routine culture. I did see in that ICU there was this one particular VRA, and in the next day it's the same pattern, same susceptibility pattern. This also will try to give to a microbiologist who's looking into the culture clearance. Yes, there are chances that this could be infection. Is it the same person who's going around for rounds? But it will be across floors. You know, all this is done only by surveillance. And then it is this person that would say that no, that MRSA is different from this. There are chances that that could be colonized even without looking at the patient. It's just the reports, just the sample. And that is possible only through surveillance. So most of them are measured with say per 100 admissions or per 1,000 patient days based on the how the hospital would wish to capture. Minimum what most of us do would be looking at MRSA, VRE and Clostridioides difficile. This will also indirectly reflect on the prevalence of antimicrobial prescription practice and how it is yielding or changing with respect to the practice in the that particular situation or hospital. This is another beautiful steps that we have to look at, where when a patient is getting admitted itself from say another long-term care patient, a potentially infectious patient can be picked up at the level of admission, where either they would have records to say that there was an MRSA with the patient in the previous hospital records, wherein you might have to put the patient on isolation at the time of admission itself, or plan for outlines, monitoring and tracking. Now the patient is doing good, but then you might have to follow this patient because it's a patient of special need. And then there is a system to notify. We know that that patient is come with I just told about infective endocarditis, and now I've got a Serratia marcescens, which itself is a notification to that particular ICU chief. They have to be computer alerts. This is going to go a long way. Otherwise, it's going to be difficult for us if we are handling single cultures. So it might be difficult if we are handling many cultures and many units. So on that case, say the computer alerts is the only way to go. Otherwise, that particular ICU might be the busiest of all ICU, and he or she could not be taking all the calls. So the least is they would get a computer alert of 6 alert, all of this would say that they are MDRs. They would take immediate isolation measures. It could be of any kind. We would get from the same unit an undiagnosed tuberculosis picked up by CP9 just this morning. And that afternoon, we would have got a flu from another patient. And that evening, we would be releasing another MDR. We had clearly, say, one droplet to attend, one airborne to attend, and contact. And imagine if the head gets an alert of 6 SMSs at one go, that saves time, and he or she would immediately reallocate sources and manpower to see that they are isolated in the best possible way. Otherwise, the next patient is going to pick up this new bug. So that's how the surveillance tracking reporting happens, and rapid response is the need of the hour for such surveillances. So recognizing of the presence of MDR in any facility is the sole responsibility of lab or the prescribers. What do you think? It's not. It has to be a hospital momentum. Everyone should be aware of what MDR is and how they have to handle. Okay. If just the immediate treating team doing the job will not do any go. So what we have to do is, these are few thoughts that came up in many of our discussions. We can also label the patient case files. You don't have to put a red dot. Red dot will bring in scare, will actually do harm in a wrong term. Put a green leaf, okay, a green leaf sticker. Green leaf sticker can be told as a vulnerable patient who needs more care. A simple green leaf telling a patient to be in contact isolation will go a long way. Patient is not going to be panicked. The attender who's holding the file is not going to panic. But all in the logistics, someone who receives the patient, even the staff who's handling and taking the patient to the ward, all of them are aware that this patient needs due care, and that person should make sure that when they are going to another patient, go in a separate PPE and not the same. So this goes a long way in how we deal with bigger issues. So there are categories to say how contact precautions have to be dealt in acute care as well as in chronic. How many of us would agree a Clostridial difficile infection patient who would be otherwise there's no diarrhea now, colonized maybe, but how early do I have to remove the contact isolation precautions in such a patient? This is a very difficult question. The rate at which you will have to implement in this particular patient also depends on the setting the patient is in and the immediate kind of patient who's already there. So when it comes to duration, this is one paper which will tell you that you might have to go for 1 to 3 surveillances. For it to become negative, you have to remove the contact isolation precautions. How often you have to do? There are umpteen, responsible answers which would say you'll have to do weekly, you'll have to do bi-weekly, and nothing gives a certain answer. So we have to tailor it depending upon the kind of facility and kind of patients that we are handling. So if it is goes to long-term care patient, definitely a patient-centered approach. Discontinue when no longer needed. The patient is not on antibiotics, which itself says the patient doesn't have any active infection or not a immunocompromised individual, no drains, no fever. Stop the contact precautions. Other than this, you think that particular resident is not very good in the hand hygiene practices, make sure that they go and gown before they enter. So we have to tailor all of this for our patient. Even the other way is not requiring so much of precautions patient, but you're not sure about your junior resident, make sure that you step up the requirement. So these are the various modalities that we have to approach. While all of this is put as a line, both standard and transmission based precautions, there should be a synergistic activity for all this. And there are various elements how we implement the synergistic activity. Training has to be not just to the immediate treating group, even to the ancillary staff. As soon as we hire, make sure there is induction training. Within the first 15 days, the patient the staff is put into the hospital, and annually. Many a times I forget. Yeah, when I joined, they had told me, but I'm not sure whether I'll have to do wear this color, that color. All of this is there. So let's make sure that our staff are trained every annually as a re-training procedure and evaluate the competency. Just the fact that he or she has a very good degree doesn't mean everything is understood. Many of us would have lost insight on the nuances required if we don't use it for long. So we agree that. So let's make sure that the personnel are assessed for competency every now and then, and audits are important. Until unless someone is seeing us, I think by default in human nature, we may not do it the way it's supposed to be. So every now and then, we make sure our team goes around. Frequency of audit has been defined by the team, and the process also told, and appropriate feedback. Not just that no, your team is not doing well doesn't suffice. What can be done should also be told to the unit in question. While there are various guidelines, again, a Western literature with respect to the requirement of MRSA, and not go into the details, we should know what guidelines are meant for control of any particular MDRO. What is my institute's basic requirement? Do I deal with many of this? So to what extent I'll have to go in order to deal with this? So we have to tailor to our hospital needs, and that's the elaboration here. So that's about very important aspect. I just completed. We just are halfway through. Care bundle approach. The reason I felt and inserted into this topic is many times we think because the person is in the hospital, it is bound that they should get a hospital acquired infection. It's not. It happens by default, and where we can correct ourselves is part of this segment. Earlier, there were 30-30 rule where we used to say 30% of prescriptions are unnecessary. Now the numbers have gone up. It's 50% are inappropriate prescriptions, and resistance across the world globally is 2.8 millions and deaths are 35. And these are all again Western data. It could be more here across. So stewardship is not just a policy, it's a team sport where we all have to come together, that we'll have to try and protect, preserve this drugs for the system. So this combination of infection control and stewardship, we know it can cause harm, and if we do any infection control breaches, we are going to have a big fee to pay for it. So what are those? I have few case scenarios that I just elaborate now. So every time, bottom line, any hospital acquired infection is we who have introduced, and it is because of us that the patient is subjected to a broad spectrum antibiotic. So that is a downstream protocol, but we should start thinking about the upstream protocol, which is where the infection control will reduce the volume and severity of infection, bringing a connection. So HAI should never be just a quality metrics, it is a resistance amplifier. I have 2 hospital acquired infection, which only means I have 10 more which is not picked up. It is just an amplification number and not a quality number. It doesn't say last month it was 4, this month it brought 2. You have 10 other which is not picked up. So that is definitely a resistance amplifier. So stewardship is a system. It is not just right drug decision. We can't just say we have got Oxa 48, so ceftazidime is the right drug of choice. So right drug. It's not just that. There are core practices. Did I make sure that the patient has the due contact precautions such that it doesn't go to the other patient? First, in the first place, why this bug came at all? This was a patient who had come for dialysis. These are the questions that we have to answer. So that is where we have to go by evidence-based protocols, just elaborated, consistent delivery. Make sure this happens continuously, indirectly every day. Maintenance protocols, we insert a central line. Are we sure that every day we have looked into the bundle? So that is where it's important. So why are we talking about a bundle? It is of no use if it is implemented only 1 or 2. It has to be done together. Only then we can improve on the patient safety. So evidence-based bundles together will cross, and it's important for all healthcare settings. So already elaborated where contaminated devices can do more harm, and that again will be the first difference. So complete set of these bundles has to be done in order to outperform synergism. and close the gaps that might otherwise be open. So this is for the interest of postgraduates where we, just to recollect, bundle is a set of 3 to 5 evidence-based practices which when put together will give the needed outcome. It's all or none. If a bundle has 5 and if all 5 elements are not put, it's of no use. That's why it's meant by all or none complaints and up to 30% reduction in any infection due to that particular device can be prevented only with a bundle care, and frontline nurses, clinicians and pharmacists play a role. This might be interesting to all of us where pharmacist is mentioned in the Western literature. Let's have somebody to watch us, to look at our prescriptions to say whether it is right. Let us have that one other person to see the device requirement is still there for that patient in question. So this is a busy slide. I'm not going to read everything. So this has to be done for every patient, every time. And let's understand, if we have done 80% of what is required for a bundle, do we mean the patient is 80% safe? We have left 20% unsafe, but that will cause the 100% loss. So we should make sure a workflow adaptation happens and understand why it happens. And we should have standardized data tools and we should be ready to get them. And we have to give a feedback to our clinical team. So this is the same thing and put in the from the references for us to take as a nutshell points. So scenario 1, here's a 58-year-old patient in the ICU who requires a new CPC. So the resident forgets to wear a sterile gown and skips the chlorexidine skin treatment. So is it okay? See, otherwise this resident is someone who's very dedicated, who's very patient oriented, want to do the job properly, very good in technique. If only that resident comes, he will put it in one go. He will not go for a second trip. That good is that resident's technique. So, but do you think it's okay? Sterile gown, no problem. He's very good in his technique. So sterile gown not required. Chlorexidine preference is okay, not required. He just gave one shot. So is it okay? It's not, because the doctor is quite efficient, but beyond us are our bugs. And that is where we have to look into our Class C bundle care. And for this central line to be infection free, we think this is all good. Let's make sure they might be, because this particular resident has missed to give a skin prep, extra luminal contamination will happen in no time. And one of the commonest reason, and now we are talking about central line, infection happens in same day. So skipping this, just because the central line was necessary for the patient's hemodynamic monitoring and for infusions, someone who really deserves. But we have given something more. The skin flora has got into the system and causing infection because the patient is also on immunosuppressant. And then we brought a new infection, which is may or may not get cleared. So that's where resistance starts. In order to take care of the same cons, now that the con susceptibility is also done, we are using resources, and vancomycin has started to deal with it. So where are we heading? We are inducing resistance. Selective pressure will be brought in that particular patient. So this is about breach, and just to recreate the fact of where all contamination can happen in a central line. We know about extraluminal and intraluminal. I just in this particular case there is a breach in the extraluminal spread. It could come from the fluids, but very rare. I just mentioned about Serratia marcescens. In that case, your microbiologist will tell you if everything else is fine, then can we just look into any new fluids brought into the system? If they go into a check, these are the input that our microbiologist can tell you. So this is all what huge impact microbiologists can tell depending upon the time to positivity that the lead culture has reached and the amount of growth when it comes to bronchoalveolar damage can also tell whether it is definitely a colonization or infection. Scenario 2, a nurse prepares an administers IV fluid but fails to disinfect the central line, the hub, with alcohol swab before connecting the syringe. So you know that I'm only pointing at mistakes, so obviously this is not correct. So hub contamination is something that the nurse should be aware of. Otherwise, a very dedicated nurse, she sees to it, all her eyes are on the patient. She's quite quite sensitive to the needs of the patient. But if she doesn't know the technique of proper stuff the hub, we are losing the battle again. So line infections comes in no time, and we break the antimicrobial regimen flora around the location. So we have to tell her that you will have to deal with the hub similarly like how we squeeze a orange. That should be your amount of technique that you put on the hub, and make sure you do it for 15 seconds and allow it to dry for 15 seconds before you either go for an infusion or if you want to draw. And then she would have done a good job. But we have to be beside her to do this. So this is important. Educating our staff is important. They just being good at duty doesn't help. Also, when we do a flushing, say after any total parenteral nutrition is over, we make sure our people does a proper flushing, and with this with 10 ml syringe, pause, push pause technique, such that there is no colonization that would develop subsequently. So these are very, very important in a maintenance of a central line. So this nuances is important, and we make sure our ICU nurses are aware of it. They could be this one nurse who's too young, just entered, amidst 9 other very good nurses, and that particular day nobody else were on duty, and she had to deal with it. But can we deal with such a staff at the cost of a patient's life? So we have a lot of questions to answer here. So the IV medication administration importance. So make sure we audit when the hub disinfection happens, when they are complaint, review the line necessity very often. Sometimes it may not be needed, but just the fact that our clinical team might be so busy that they forgot to tell, no, we could remove this. It would be going for another 3 days. So this is something that is quite important. So another two aspects here I would wanted to mention is there is this in order to maintain all of these requirements, Pronavast is an intensivist way back in 2006, 2 decades back, is when he had devised checklists. And Pronavast is an intensivist who told that having followed the checklist, we would go ahead with near elimination protocols when it comes to infection. So this is his paper. I think this was in 2009. Very beautiful paper, which says about implementation science. All of us know how we have to do this, and or rather, that is knowledge. And many of us are bothered about results. Okay, fine. The patient is come, surgery is over, he's getting discharged. But how is he handled is something that we have to ask as a question. And that is what is known as implementation science. He says way back in 2009 itself that we pay a lot of attention and our resources go towards managing things. But in how it is done, none of us concentrate. And one such element is nothing but training and looking at the checklist. If there is a checklist, a cognition is given a little way off. I'm talking today is because I have a PowerPoint. I know what things are there, so I'm able to tell points and relevant to it. Otherwise, 45 minutes at a stretch, if I have to do, I have to do another 2 days work to think about, okay, after this point I have to do. So this is what a checklist could do. Today, my checklist is a PowerPoint. We make sure we give a bundle care checklist to all our ICU devices. So this is one of a checklist. Just to, even at the level of insertion, we should know who had inserted, what was the indication for insertion, why was that site preferred over the other, where femoral vein we all know is more notorious for getting prone to infection. So there might be an indication why that was preferred. So all of this is essential if we have to look back and give better help. And this is the maintenance bundle checklist, where minimum of the 3 shift ICU nurses will ensure that the device has been inspected and given the due care when needed. For central line, otherwise we would say when there is no oozing, transparent residue, 7 days, no need to touch. So we have to make sure that the oozing was looked at all. So that should be part of a checklist so that we don't lose the big picture. So it is important to integrate the infectious disease consultant along with the pharmacist to get into this stopping of Staphylococcus aureus bacteremia, which is all because of the labs that can happen. So bring them into the system. And real-time pharmacists will go a long way, as I just mentioned. This is a sum up of the previous slide. So why it matters? We are talking so much about CLABSI. We know what if it is missed, that doubles the mortality than anything else. Plus, 65% of high performing ICUs only if a full bundle care is performed well, that we would have patients coming out well. So this is very, very important. So that's the reason we took this case. I'll go ahead with a couple of other things very quickly. I'll not stop for explanation. Please feel free to stop and ask if there's any questions on this. There was this urinary catheter. In order to ensure a closed drainage system, all that was taken care, necessity of the catheter was in question, but it was maintained for 6 days. There was ascending bacteria and prolonged unnecessary catheterization has brought this clotting. So what could have solved this? A prompt device removal, where we would have just had to see whether it is needed at all. That was not looked into. So it is important that we remove if it is not needed. Escalation is important, and breaking that chain of unnecessary resistant pressure is very, very important. So among your rounds, other than what treatment went in, whether that device is needed should be a mandatory question. So yeah, this is another short case where again it was not looked after removing the catheter following the surgery. So let's understand the number of days. This catheter days itself is a modifiable risk factor, and it reduces or rather increases by 5% with every other day. This is also proven from studies. What we could do is, we know that a nurse is doing very well. We can enable the nurses after ensuring that they are capable of doing this, competent enough, giving instruction to see that that particular day, if this such and such a thing is done, then the device can be removed. So these are all nurse-driven protocols, underweight less, but we can go for such protocols for efficient patient management. So stop catheter days is very, very important. So quickly for a VAE case, a patient on mechanical ventilation does not receive routine oral hygiene with chlorhexidine. All we are bothered about is, okay, whether that patient's question won't heal, whether we are only bothered about that particular medication is staggered, de-escalated. Did we ever give a look, or did any of our rounds have whether oral hygiene was done for the patient that morning? Okay, I will bet you that 9 out of 10 of us will say that would not be part of a question, but it's very, very important to look at. And the reason is that colonization will only go into an aspiration pneumonia. So that's important. And how you would do your kind of patients, you can decide. Preferably, the literature would say every shift once. It may not be practically possible, at least once a day. That's the practical frequency. And make sure the head end of the bed is elevated between 30 to 45. Any patient on 10, because the patient is not comfortable, will only have aspiration pneumonia subsequently, because I'm terming it as VAP. So our VAP bundle is quite important. We make sure that subclotting pressure is maintained between 20 to 30 so that there is no aspiration happens. And when all this is taken care, I think we can still manage an ICU patient without carbapenems. We'll not let them develop a HAP. We'll not let them get an MDRO. MDRO and ICU breaken off. So yeah, this is just a picture to show you the 30 to 45 degree and oral hygiene is very, very important. And what we are using is also not the routine chlorhexidine. Here it's a quite diluted one, diluted percentage. So daily sedification important. And let's look at the subclotic secretions are taken care. So this is other quick case of surgical procedure where it was the surgical antimicrobial procedure, prophylaxis was given 3 hours before the surgery. No, that alone I'm very proper. I have given antibiotic 3 hours before the surgery. So don't ask me that I have not done my job. You have done your job, but you have not done your job properly. Ideal recommendations is anywhere between 60 to 120 is the time from the time the incision is planned should be the surgical antimicrobial prophylaxis. The basic reason is only when the enough amount of concentration of the drug will be available at the site of surgery. Otherwise, this is going to be prone for SSI. So this is important. So that critical window of 60 to 20 minutes has to be defined and monitored by our team in order to make sure that it is done within the recommended time. So this time prophylaxis, maintain aseptic technique throughout, de-escalate and stop. It should not go on beyond 24 hours. It has to be actually one dose. If it is a prolonged surgery, we can redose. Or if it has to be continued because there was blood loss, maximum 24 hours, not beyond that. So these are all the various steps which is important for us to check. Again, go by checklist, appropriate governance, timing and agent selection is important. Just because you want to give a SAP, meropenem might not be the drug of choice because that has nothing to do with the surgery in question. So let's know what we are dealing with so that we don't increase the selective pressure. Audit again. So this, who tells us this? In 2030, American Society of Health System Pharmacists first told about the SAP with lot of evidence to tell about the timings. So with that in the background, suppose you think you have a patient who have a open abdominal or sternal wounds. Do you think antibiotics can be continued beyond 24 hours? You have a justification. See, there is a wound there, and then there are so much drains. You should be flexible here. What do you think? No, it's not like that. Again, there is evidence for this. There's enough evidence that there is no benefit of continuing an antibiotic in such a case where actually SAP was started and it is continuing for another 2 days just because there is a wound. It doesn't make any effect. And this comes from a meta-analysis itself. And this is from 52 randomized control trials which say there is no benefit of continuing antibiotics for more than 24 hours post-operatively. And this all the more will increase other NDRs only. Besides, the fact that the bacterial colonization will increase over time is only contributed in the study, but not with the increase in time. So you can increase only if you suspect an infection. So that's the take home. So last, it's all about the team sport. One man cannot do all the job. It's the entire team who have to get equipped, go by protocols, and be compliant to the protocols. Last is vaccination. I'm not going to elaborate. The moment you take a vaccination, the whole reason is we want to prevent an infection. So that's the take home here. I just put a case to tell about Streptococcus pneumonia in a community acquired setup, which means although it might not be a mandatory vaccine, but it is a vaccine, optional vaccine, especially the elderly, but not any of us would have given to our immediate elders at home. But let's understand that the cost of treating a community acquired infection with such an organism is more than the vaccine itself. So that's the whole take home. Otherwise, considering the number of days that the patient might be in the ICU and the antibiotics to treat that particular infection. So this is a quick slide to tell about the advisory committee on immunization practices. Very well are set up as well. It's just that not everything is there on a national immunization program where it would be as a optional. We can pivot as mandatory for our own patients, kit and kit as well. So that is where you see Streptococcus pneumoniae vaccination is mandatory for anybody greater than 65. So this is just the various infection that will be caused by these organisms. So I just put a rough picture to understand. It's about 2,000 rupees vaccination against the cost that would go with dealing a community acquired pneumonia. Just a rough cost, just to understand. So how do we summarize? Infection control alongside is mandatory for appropriate stewardship practices. So stewardship practice alone with right drug, right route will not do all the jobs. So let's first prevent, let's come to the patient, follow all of those synergistic activity with the CDC core elements. Let's identify, define, quantify and recognize roles for our team so that it's implemented in the way that it's supposed to be. So thank you all for your patient listening and for this opportunity. It was a delight to be here amidst very august audience. Thank you, ma'am.
Thank you, ma'am, for this highly informative session. Now I request Professor Usha Krishnan, ma'am, and Dr. B. Ravichandran, sir, to felicitate Dr. Subha.
Good morning, ma'am. Nice presentation. So I have some simple doubts. In a setup of human resources constraint, which is the best method to handle in audit?
Audits.
Audit.
But I would still say in-person direct and hygiene audit would be the best, but we might have to capacitate more number of people to do it. Let's say all our institutes, we would have 2 or 3 infection control nurses, and that would not be sufficient for any institute. We have to capacitate link nurses. Say we have close to 16 link nurses across all wards, all ICUs. The head of the head nurse or the immediate junior capacity them to do this job across wards. The one in the surgical unit should do the audit across the medical unit and vice versa. This numbers we can increase in an hospital. Still, direct audit is the best audit, where we can give immediate feedback and correct also. Many times just observing, okay, they are not counting, they are 60% counting, they are not achieving anything. So anytime direct and hygiene is the best. We just have to evolve.
And next question is, I have gone through many books now, but I didn't get anything authenticated for the speed management. Whether it is area more than 10 centimeter or it is volume more than 10 mm, it is 1% sodium item or it is a 5%. That's it.
Okay. Most of our guidelines which comes through evidence-based practices, both on the volume as well as the percentage that has to go into it. We are talking about spill management with respect to bloodborne viruses, for which 1% sodium chloride is more than enough when it comes to concentration. But when it comes to the volume that we are handling, there might be a dilution if the volume is more. So there is a rough estimate that it has to be seen that it is absorbed with the material which is soaked with 1% hydro. So it's only a rough estimation, but there is no clear cut demarcation. This much has to go into that.
Is there any time for minus
Time is
immediate
minimum 20 minutes.
even for minor spill?
Yes, sir. Yes, because we are dealing with the virus in question. Is why we do this. So here, irrespective of minor or major, time is 20 minutes. So that is the context.
Then what is the antibiotic of choice for surgical prophylaxis?
Okay.
Sometimes we clinicians are using, surgeons are using some traps.
It's cephalosporin which is proven because they are only aiming at the skin flora in question. And essentially, skin contaminated is what we are dealing. We are not going to talk about 30 cases where prophylaxis would not be there, therapeutic antibiotics would be there. So here, it is cephalosporin which will take care of the skin flora in question. It might vary with respect to the kind of surgery. Suppose it is below abdomen, so cephalosporin sulfactant, depending upon the flora that we are going to deal with, and might come into the area of incision.
It's very often do shaving is good or bad, but most of them are not doing clipping of as
Now it's very well proven with both WHO and CDC that shaving is not recommended. It's just a clipping protocol. Because the amount of pore that we would introduce, which will actually decrease the colonization and reduce. So shaving is not at all recommended. It's just a clipping. Thank you. May not even be required if we know what kind of surgeries that we are doing. Sometimes it is very far away from the locations. Like it's not required at all. So crucial discussions.
Thank you, ma'am. It was very elaborate and also concisely presented on the topic. There were very new prospects I have updated that, like the stewardship synergistic model, insisting the nursing role in antibiotic stewardship. I remember also reading about the Pronova's checklist manifesto that he empowered the nurses in stopping the doctors from the central line insertion when any of this is missed out, any of the points missed out. So we have to, like you said, empower the people in doing the audit We have to include our team also, educate our team also. It was very well brought out in the presentation, ma'am. Thank you so much. Thank you.
Another question. Two questions.
Yeah.
What's the time period to change the N95 mask? Is there any time period you want to change after 4 hours of service?
There are lot of studies which says anywhere between 4, another one says 6. Directly they are trying to tell about the shift and the amount of exposure or the amount of work that they do also. So with one of the Lenzi method analysis that goes from the SARS-CoV to exposures, they say 6 hours. So it can be changed depending upon the type of work they do and the comfort also. And 4 to 6 is what few studies have.
People that Canada hydrogen peroxide is.
Yes, sir.
So in our settings, if there is Canada epidemic of the recent cases, can we disinfect the area with this hydrogen peroxide?
Yes, sir. So, now hydrogen peroxide is available both as wipes also now and as well as solutions. So depending upon what device that we want to be in and around the patient with Candida, it is highly recommended that we'll have to use only this disinfectant. So at least to a great extent that this is going to be fungicidal efficacy compared to that of sodium hypochlorite or Horus, because otherwise Horus is very notorious for its dissemination across people and it comes through us. So at least the least we can do is clean the environment in the recommended way and for the practices which is essential for stopping this.
Thank you, sir.
We have one question from our online participant. Can CCTV feed or recording be used for handwriting audit? And is there an issue on patient's privacy when we do such calls? Yeah, actually, there are issues picked up for patient's privacy. We can put in areas which is not meant to be patient-centered areas. We can put it in the lobbies where the nurse finishes her procedures and then comes as the scrub. So only that area we can focus. We really don't have to focus on immediate patient bedside. That is there, but when it comes to CCTV, the person is also conscious that there is a CCTV. So every time the person would put it very well, but it might not be a true picture. But when we do it in a direct way, and I enabling another nurse who's otherwise not known with this particular group, we get the true picture. So the educational reach is much faster. So the only way to get this forward is educate how many ever possible nurses itself or hand hygiene audit. And the moment they are educated, is that they realize, okay, fine, so I'm doing it wrong. Because otherwise they do the 5 steps, 5 moments of hand hygiene. And then only when they know the odd influences that there is a clubbing in between these two. That I don't have to repeat. So it is only the second one that is taken into the audit. So my level of understanding of what I have to do in an action hand hygiene also will be better when I become an auditor. So it's a very good protocol to make all the nurses auditors across students. So their compliance with the routine.
Ma'am, and Dr. B. Ravichander sir to felicitate Dr. Subha ma'am.
I remember that.
Thank you, sir, and thank you, ma'am. I request Dr. Kalta Raj, ma'am, Assistant Professor of Microbiology, Government Kilpatrick Medical College, to felicitate the chairperson, Professor Dr. Usha Krishnan, ma'am, and Dr. B. Ravichandran, sir. Thank you, madam. Thank you, sir. We take an immense pleasure in welcoming Dr. Subanti ma'am, retired Associate Professor of GKMC, and Dr. Rajashekaran sir, Associate Professor of Stanley Medical College. We shall all have a short 15 minutes tea break and refreshment. Thank you.
Hi, ma'am. Nice to have you. I will listen. Actually, was to be. It's not our break. Let us go. No, we are not.
I request the Professor and HOD of Pediatrics, GKMC, Dr. Stalin Sir, and Associate Professor of Microbiology, Government Stanley Medical College, Dr. Rajasekharan Shah, to chair this session.
Very good morning to one and all. At the outset, I would like to thank our beloved Professor and HOD Ravindra sir for giving me this opportunity. The next speaker is Madam Vidya Lakshmi Devarajan. So, who is a Senior Infectious Disease Consultant, Dr. Rela Institute of Medical Sciences. She completed her MBBS from Rajiv Gandhi University in the year 2003 and FNB Internal Medicine in the year 2009 and FNB Infectious Disease and Fellowship in Infectious Disease and SCE Royal College UK. And she is having 14 years of experience as a infectious disease physician, and she presented 60 posters in national and international conferences. She has 34 publications, and also she did 7 text book chapters, and also she was awarded Times of India Excellence in Infectious Disease in the year 2022, and she is also a reviewer of multiple journals and also editorial board on JCIDS, executive member CIDS, secretary CIDS PG Education Subcommittee, course director ID Fellowship, Dr. Ella Hospital and Medical Center, Award of Excellence, Women Doctors in IMA Tamil Nadu 2025. Welcome, madam. Over to Dr. Vidya Lakshmi Devarajan.
get started. So it's going to be syndromic stewardship of key strategy today. Disclosures related to this talk, I do not have any. So we look at antibiotic use. I think the desire to ingest medicine is actually a principal feature which distinguishes man from the animal. So why I would tell you this is just think this is really a thought, you have given that. It's a very wise thought. If you feed a dog meat wrapped with pill, it clearly chew the meat, spit the pill. But that's not how it is when it comes to human beings. Human beings, if you look, I'm sure all of you have patients in your outpatient for a viral infection asking you for medications. And you will have a lot of people telling you, no, this antibiotic worked very well. So despite what the culture is, despite what it is, I think it's safe to complete therapy in this. So basically, we are waging a war in this setting, unlike what it is. When you look at the dog, it's different. They do not want pills. Okay. So just a small peek into history, the pre-penicillin era, you saw, we heard about gruesome preterm wound infections, young lives lost because of infections. You've had a flu pandemic, you've had countless life lost due to meningitis, pneumonias, puerperial sepsis, strep, sore throat, etc. Just imagine if these great minds still existed and they lived longer. Mozart died due to streptococcal infection. Ramanujam due to TB, John Keats due to TB. So just imagine if they all lived longer. It all happened because some infections like this didn't get treated. Then, luckily for the mankind, there was serendipitous discovery of penicillin. So it just decided to manifest itself to mankind. And this is how a child looked on arrival to the hospital. And imagine after treatment with penicillin, the entire picture changed. So this is what penicillin did. So in fact, penicillin increased the chance of survival from 10 to 90% with patients with pneumonia and bacteremia and blood. So this graph is something that's interesting and I put it up in quite a few forums. So antibiotics caused US deaths to decline by 220 per 1 lakh in 15 years. But if you look at all other medical technologies, it just reduced death by 20 per 1 lakh over the next 45 years. So we really know what antibiotics are and how much we'll all have to work to preserve them. But yes, the prophecy then said there is danger that the ignorant man will easily underdose himself and expose the microbes to non-lethal quantities of the drug and make them resistant. And this is what is actually happening. So this is a report by a famous economist, Jim O'Neill, and he says that attributable to AMR every year in 2050 it's going to be 20 million. And if you do not tackle AMR, rising AMR can definitely have a devastating impact. Which means to say, by 2050, the death toll could be staggering 1 person every 3 seconds. To get some report like this from a famous economist is definitely an alert for all of us as to how much we all should really work to defend the last line. So, I don't want to start the talk with an impending apocalypse, but this is definitely the picture that we all have to understand, especially our junior doctors. You all really have to understand that we need to preserve antibiotics for our future generation. East or West, we are all united in antibiotics and so in resistance. West, may have MRSAs, and KPCs, we definitely have more of NTMs and OXAs. So this was somewhere in 2014 when we had, this was in an oncology institute that I worked, and we actually had PDRs, pan drug resistance at that point in time. And imagine a patient with a neutrophil count of 10 and you do not have anything to treat. So this was what it was in 2014, and you can definitely imagine what's happening now. So that's why antimicrobial stewardship becomes important. So antimicrobial stewardship is appropriate selection, dosing, route, duration of antibiotics. Basically, right drug, right time, right dose, and right duration. It's very important for us to have this rule which is called mind me when you prescribe an antimicrobial. Microbiology definitely guides therapy wherever possible. Indication should always be evidence-based. Look at the narrow spectrum that is required. Dosage your antibiotic should act at the site of infection and type of infection. You cannot just take bench to bedside. You need to know where are you using, what is the site of infection that you're using the antibiotics. Shorter the better is definitely the new mantra now. So minimize duration of therapy, ensure monotherapy in most cases. There are certain clinical indications where you do not need antibiotics. Viral pharyngitis, viral rhinitis. These are places where you can use point of care tests or multiplex PCRs that are very well available to curtail the use of antibiotics, particularly the OP setting. Yes, I completely understand the cost of them is definitely high, but I think wherever possible, you can utilize these tests. Then subcutaneous abscesses that are small do not require antibiotics. You just have to drain it and that's about it. Asymptomatic bacteria is some place where antibiotics are used in and out. This is a place where again you have to look at antibiotic stewardship. Microbial colonization, culture contamination. You can't treat anything that grows anywhere. So you just have to take the clinical situation into consideration and then decide. So always make a syndromic diagnosis. First of all, is it an infection? Is it a non-infectious mimic? How likely is this patient to have an infection? Rule out colonizers and contaminants. Like I said, in the ICU, you have a fever. There is no role for a fan culture. What you need is, first of all, what is the syndrome you're looking at? Am I looking at ventilator-associated pneumonia? Do I think this is 40 appropriate culture? So what's going to happen when you send fan cultures? You'll grow something from the TT, you'll grow something from the blood, you'll grow something from the urine. And ultimately, you will end up treating with multiple antibiotics. You will not make a syndromic diagnosis, and that's definitely going to affect the patient outcome and predispose to developing a lot of antimicrobial resistance in your local flora. Determine whether you need to start an antibiotic empirically or can you wait. For example, you have somebody coming to your outpatient with a chronic sinus. You can't just do a swab and then start an antibiotic. It can very well wait. You need to get a microbiological diagnosis, ask for a tissue culture at that point of time, or say the prosthetic joint. Unless it's in sepsis, we wait. We ask them to take the joint off, get the samples, then start antibiotics. Yield will be better. And there are chances if you give antibiotics prior to the procedure in that patient, you might not get a microbiological answer. Again, point of care tests or multiplex PCRs will help in such patients. So empirical antibiotic therapy, you can't stop in certain conditions. For example, you have somebody with febrile neutropenia, septic shock. Obviously, you can't. Bacterial meningitis, community-acquired pneumonia, necrotizing patients. Obviously, these are life-threatening conditions. You have to require an immediate action, and please mind, it is not just immediate action when I say these are patients who have developed sepsis, your timing of antibiotic, dose of antibiotic, all that matters, and all this is definitely a part of antimicrobial stewardship. So you choose an appropriate antibiotic, keeping in pattern with it. You have to know your enemy. You have to know what the local resistant pattern is. You have to know there is a tissue penetration of the antibiotic, the correct dose. Say patient is in renal failure, you have to dose adjust. Patient is obese, you have to dose adjust. One size will not fit all. Confirm the appropriateness of the. So once you get your microbiological cultures, you definitely have to give targeted therapy. Just because the patient is getting better, we cannot continue the same thing. Like I said, adjust to post comorbidities like renal and liver failure. Shorter duration of antibiotic therapy where possible. So let's go to a few cases now. I have a 75-year-old male, a known diabetic on oral medications, present with 7-day history of left lower lip pain, bullae formation leading on to pus discharge. He also had an STEMI during the admission with mild respiratory distress, gets shifted to the ICU, requires intubation, undergoes a debridement and a plantar fasciotomy on the day of admission. So what does swab do? See, a lot of times patients are taken to the theatre, debrided, but many times what is sent is inadequate tissues to the lab. So these are things where you definitely have to put your foot down and play a role. So swabs can be colonized. what you need to send is an appropriate tissue sample. So this patient, blood didn't grow, urine cultures were negative, swab was growing MRSA. So let's say that was the tissue that grew MRSA. You've already done your source reduction. What actually happened to this patient? This patient was started on pictaz and clindamycin because in a diabetic, a necrotizing fasciitis is usually polymicrobial. So he gets started on this. He also improves. He becomes afebrile. The CRP procal has come down remarkably. This patient was changed subsequently to linezolid 600 milligrams BD for 2 weeks. So can I have a show of hands amongst the postgraduates as to how many of you feel this is right? Okay, so this patient already has a source reduction, right? And the second thing is it's a swab. You cannot really give it due respect. So this, and first of all, when you've already done a source reduction and things have all settled down, there is nothing called a duration when it comes to this SSTI. It's source reduced. You might as well cut down the duration of antibiotics. So shorter is better. There have been numerous RCTs that have demonstrated that shorter regimens are clinically efficacious when it comes to cellulitis, acute bacterial sinusitis, community-acquired pneumonias, ventilator-associated pneumonias. You just have to treat them for 8 days. And complicated urinary tract infections, intra-abdominal infections, if you've done an adequate source control, the duration is definitely lesser. So this is actually, I think, a paper in JAMA. This was published in 2016, where they gave you they looked at infections where short courses have been equivalent or efficacious as compared to long therapy. For CAP, it is about 3 to 5 days. Nosocomial pneumonias, it's less than 8 days. Pyelo, the duration is 7 days. Intra-abdominal infection with a good source control is 4 to 5 days. Acute bacterial sinusitis is 5 days. Chronic osteomyelitis. In fact, I think there are quite a few trials that are coming up with discitis osteomyelitis, where shorter duration of therapy is actually recommended. So this is a trial of short course for intra-abdominal infections itself, where it says after source control, 10 days versus 4 days after adequate source control, there was no difference in 2 groups with regard to SSI, with regard to intra-abdominal infection, recurrent intra-abdominal infection, and death. So what about duration of VAC? Duration of VAC, by and large, we say we try to leave it to 8 days. Yes, they did see recurrences when it came to non-fermenting gram-negative bacilli. So this is again a duration of antibiotic treatment for acute pyelonephritis and septic UTIs. 7 days versus lesser versus the longer duration. This is a nice systematic review and meta-analysis. So you definitely have to cut down the duration of your antibiotics, and we do have adequate evidence for the same. The next thing is avoidance of redundant double coverage, gram-negative and anaerobic, which we very clearly see in a lot of patients. So this is a patient, 55-year-old, analgesic abuse, diurnal ulcer, perf, goes to the emergency for a laparotomy with a mental patch repair, gets started on meropenem, gentamicin, metrogyl. So how many of you think this is the right choice? So basically, what pathogens are we expecting? Yes, anaerobes and gram-negatives. So with anaerobes and gram-negatives, we know most of our gram-negatives are ESBL. So you need a drug which covers the ESBL. But what about metrogyl? Do we really need it here? We look at it in the subsequent slide. So this patient is taken up for a procedure, basically a source reduction, gets better. Blood didn't grow anything. The intra-pus grows an E. coli, which is sensitive to piperacillin tazobactam. So now coming to actually the spectrum of activity of the antibiotic that was chosen. So meropenem will cover gram-positives except MRSA and Enterococcus. And most gram-negatives and anaerobes. We are not looking at CRE. We have a culture here in TRO, which is showing an ESBL. So what about anaerobic activity? It definitely has a very good, it at least covers 95% of anaerobes. So this here was a redundant anaerobic coverage that actually was not required. So what I would like to show you here is how are we abusing antibiotics? So if you look at redundant coverage, it's about 10%. So we are a 44-year-old Bangalore comes to the hospital, some suture hole, undergone some procedure on the repair, has had a short-term polycatheterization, and that is when he was operated for the inguinal hernia. No known comorbidities, no history of fever, no urinary complaint. On examination, very well and fine, healthy, happy, but the urine protein shows 14%. Ultrasound normal, white count bag normal, sugars okay, parameters okay. So how many of you think you should do urine culture with this patient? Are you worried? You've just had a surgery, this patient has had. Again, this is going to be, this urine culture showed something. Is it showing next year? No, it's not showing an exam. So this patient is again growing some bumps and ended up receiving meropenem 1 gram IgQ8 for 10 days. So did she actually need this antibiotic? And what are the adverse effects? So what you need to understand is that pyuria in a Foley sample, okay, is more of a negative predictive value. You have a Foley's and you do not, if you're looking at UTI and you see pus cells in the Foley's, I mean, I don't think it will add, but if you're looking at fever with in a catheterized patient and you do not see pus cells, then one thing that it is not is it's not a UTI. So basically, the negative pus cells has more of a negative predictive value in such a setting. So this patient just had pyuria, that's all. It's totally asymptomatic. You do not have to even send a urine culture and then see the urine culture and then start on meropenem. All that we are adding is to an AMR. That's it. So treat infection, not colonization. Treat pneumonia, not the tracheal aspirator and the endo. Folate cultures, ET cultures are not really recommended. Staph aureus, whatever may apparently with Staph aureus, you have some correlation with the intra-op sample when you get some Staph aureus on a superficial sample. Otherwise, with all other isolates, you are just treating what the surface has and you're not treating the underlying infection. So obviously, it can predispose to C. diff if you're going to treat with the antibiotic in this patient who did not require it. It will predispose to C. diff. It will wipe out the wild gut flora, leaving MDRs to proliferate. It leaves this individual more prone to resistant infections. It will transmit resistant genes to the other bacteria, and ultimately, unfortunately, his pocket in this day and era, with the cost of the antibiotics going up, will drain his purse. So do not use, the next thing is do not use antibiotics which are not efficacious at the site of infection. So I have a 66-year-old male with cough, fever. So basically, what is the syndrome that I'm looking at in this? That's what is the first thing that you need to make. We're looking at a pneumonia syndrome, and patient has sputum growing MRSA. Say this patient has blood and cell growing MRSA, MRSA, okay, and he has a high white count. Now you are looking at pneumonia in a patient with MRSA. So obviously, your choice of antibiotics, although daptomycin is sensitive, is not going to be daptomycin. So that is what that you have to understand. So test tube or petri dish to bedside, matching drug to bug, one size is not going to fit all. So that's something that you have to look at. So basically what happens with daptomycin, it gets denatured by the pulmonary surfactant. So you cannot use daptomycin when it comes to MRSA pneumonias. So again, microbiology stewardship is important. You have to obtain cultures prior to starting antibiotics. Ensure cultures not just obtain cultures, ensure it reaches, you order it, plus it reaches the lab at appropriate times. You have to develop a process to ensure they are transported and processed. So, and what is also important from a clinician perspective is putting down an antibiotic timeout. So, what is the diagnosis or bacterial diagnosis for which I need a drug? Is this the right drug? Is it the right dose? Is it acting at the site that I have given? How long do I plan to give the drug? All this, if you make a documentation plan on your case sheet, then it actually reinforces you. So many a times in rounds you'll find that probably the surgeon wants to stop the antibiotic, but he would probably not know that there is an antibiotic at all. So that's where you can actually have your nurses empowered. They can always ask, do we need this or can we stop? So these remove of folies or removal of lines or antibiotic, all this should be a part of their rounds. They have to be trained to ask, do we need it today? So every day we have to review and decide what is the duration that we have planned the antibiotic for. Next thing is, yes, you have to have appropriate antisepsis when you do cultures. Like I said, avoid catheter tips. There are antibiotic failures that occur. You have a lot of factors for it. It could be a microbiological factor. It could be ineffective, like I said, daptomycin, or if you're looking at tigecycline for urinary tract infections. Again, these are places where it's not going to work. So you have to understand whether it penetrates well, what is the spectrum. I'm trying to narrow the spectrum. For example, I have somebody with ESBL, E. coli, and I'm thinking of outpatient antibiotic therapy. Just because I started with meropenem, I do not have to continue meropenem. I have to prevent collateral damage. I do not require acetato cover. I do not require pseudomonal cover. So I can always step it down to eptapenem, which is easier once a day. Look for non-infectious mimic. And whenever it is unresponsiveness in infectious diseases, it could be a problem not just with the drug, the site of action, dose, etc. It could be definitely when it comes to surgical cases, a source reduction. So always reinforce on source reduction. And yes, a sick ICU patient not really responding, it could be fungal infection. So just broadening antibiotics without using fungal diagnostics may not have a good outcome. So what about molecular tests? Whether it's perfusion or clarity, everything depends on us. So I have a 50-year-old male here who is CKD post-renal transplant, has a graft pyelonephritis, presents with fever of 4 days, no specific localizing symptoms except, so it looks very clearly, it looks like a urosepsis syndrome because the creatinine is also going up and he's present with fever and he is post-renal transplant. Urine throws a GMP and blood throws a GMP. So these are places where you can definitely use molecular tests. So this was a Carva-R and OXA48 was detected. Similarly, and this patient was started on ceftazidime-avibactam. This patient definitely got a longer course because this was a recurrent graft pyelonephritis and he improved. So basically, from what I understand, molecular tests, that is BS, especially for a BSI, when you use a BCID panel, reduces the time to effective therapy by 5 hours, which is very significant. I understand the affordability cost, but it does affect the time to effective therapy. It reduces by 5 hours. It also reduces your average length of stay by about 2.5 to 3 days, which means the room rents and etc. everything else. So this is where our molecular test stands. Yes, they do have pitfalls. You will know the ID of the organism before. You have to know the ID of organism before interpreting. It will predict resistance, but it will not necessarily predict sensitivity. For example, if you look at your BCID and you have a non-fermenter, you say the resistance genes are not detected, does not mean resistance gene does not occur. So those are the places where you have to actually look at the next step and await sensitivities and change. But when it comes to enterobacterial, I think that definitely helps. Similarly, there are some pitfalls when it comes to respiratory viral diagnostics, but in a lot of patients, it definitely helps us in initiating. We had a patient post liver transplant, just came in with the fever of a couple of days duration. We did an RVP and the RVP picked up influenza and COVID. See, we would not have just thought of influenza COVID in a season like this. I mean, we're not seeing a lot of COVID cases. So it definitely helps you in rationalizing therapy. But remember, in many of the immunosuppressed, it may not be just one single pathogen. You may have more than one pathogen, and sometimes de-escalation becomes challenging because there could be a secondary infection always possible. Similarly, what about the syndromic panel that we have for GI? So it is useful, that is the gastrointestinal panel. It is useful when it comes to norovirus, cryptosporidium diarrhea is something that we pick up on the panel, and various types of E. coli. There are certain things that you will definitely miss on the panel, which you have to look up. Isospora may not be there on the panel. So please do your traditional modified AFB stain if you're looking at some patient immunosuppressed with chronic diarrhea. Similarly, in an immunosuppressed diarrhea can be because of GUTB. It can be because of CMV. That may not get picked up on your gastrointestinal panel. You may have to do additional testing for the same. So there are certain caveats when it even comes to CNS PCR. Your crypto, you may have false negatives. So what is important is your CRAG. That is very, very important when you're looking at crypto. So it definitely, molecular tests helps you in a lot of ways, but you should know what the pitfalls are or what the caveats are. Or if you look at HSV, it can be negative. So you still have to do a singleplex PCR if your clinical suspicion of HSV is high on a multiplex PCR. And obviously, the multiplex PCR will not include your local pathogen. Somebody coming to your ICU with fever altered sensorium need not always be HSV, HHV6 crypto. You have in India, you have to think of dengue, you have to think of chikungunya, you have to think of scrub. During influenza season, you have to think of influenza encephalitis. So those are, I mean, you may not have a lot of tropical pathogens like chikungunya, scrub, dengue, etc. So it definitely requires a little more detail than just the PCR. So ultimately, molecular diagnosis provides clarity, but sometimes it definitely confuses. But provided you know your limitations. It's actually very important when it comes to hospital-acquired bacteria. They are definitely useful. And when it comes to a lot of immunosuppressed patients, GI panel, the ME panel, and the respiratory panel are important. Now, going over, I think I just have a couple of slides for the surgical team, and then we stop there. I have a 54-year-old gentleman post craniotomy, and POD3, that's the drug chart. Cefuroxime, NSAID, pantoprazole. Anybody thinks anything is abnormally, strikingly wrong? I want our PGs. This is POD drug chart, and you're seeing this. Obviously, it is. He doesn't need the cefuroxime. Surgical prophylaxis is one single dose. Okay. So this was actually a study. I mean, with all due respect, this was a study which was actually published in Itchy, which said which specialty should we target for AMS. So I have written down. I mean, I've enlisted the specialties as per the study. The surgical specialties, your physical medicine, rehab, anesthesiology, OG, pediatrics, etc. So that is where you have to know. See, always you have to measure and target, and then focus on that. That's when you can, curtail the use of antibiotics. So you have to target these specialties for antibiotic stewardship classes. So basically, antibiotics before surgery, please use the correct antibiotic and avoid wrong combinations. You don't need a carbapenem when you would like planning to give, for a cardiac surgery. And please avoid wrong combinations and avoid continuing antibiotics for 24 hours post surgery. So this is something about the duration of antibiotic prophylaxis. So this is another published study, and basically all it says is there's no difference in the rate of SSI with a single dose compared with multiple dose regimen. So for cases in which prophylaxis beyond the time of surgery is warranted in general, the duration will be definitely less than 24 hours. And this actually looked at the risk of prolonged surgical prophylaxis. So what did it say? It said that it was in this study, it was correlated with an increased risk of isolation of Enterobacteriaceae or Enterococci with acquired resistance to the administered prophylactic agent. So, I mean, you may harm the patient if you're actually prolonging surgical prophylaxis. So, yes, one dose, this is what it does to the bug and the system, and multiple doses, you know what kind of effect it has on your system, just trying to keep it light. I have another patient here, 66-year-old, goes in for a prosthetic joint surgery, white count normal, urine culture XDR. What do we do? Start on colistin. How many of you want to start this patient on colistin? You're going to put in a new joint. You want to start on colistin? First of all, we do not really require routine urine culture. If this is a UTI, then this is not the time to put in a new joint in this patient. Treat the UTI, ensure he's okay, then actually put in a new joint. So, pre-operative asymptomatic bacteria, is it a risk factor for prosthetic joint infection? So, what did they find? There was no association between pre-operative bacteriuria and post-operative surgical site infection. Based on these results, it seems that pre-operative screening and the treatment of asymptomatic bacteriuria is not required. So this is what this study says. So colistin in that patient would result in his going up, etc., etc. So the main purpose for which he came in, program will not actually get sorted. So current evidence does not support systemic antibiotic therapy prior to joint arthroplasty in patients with asymptomatic bacteria. This is again another meta-analysis that is published in International Orthopedics. Where will you treat asymptomatic bacteriuria? You will treat it in a neonate. You will treat it probably in pregnancy. You will treat it prior to a urological procedure. And sometimes in neutropenics, when we're not really finding anything and the urine is growing and it's still spiking, we probably look at treating it in that patient. So otherwise, routine treatment or screening itself will not be required in a patient where you're going to put in a new joint. Yes, so this is something that I already told you, 45-year-old necrotizing fasciitis on septal wound debrided, but all that goes to lab. Shubha will call me and be like, ma'am, this is pus swab. Sorry, this is a wound swab. Be like, I mean, I'll have half the mind to say let's not process it at all. But unfortunately, there'll be a bill base. But obviously, we look at it later and this swab is colonizer, kindly send a tissue wet debride. So these are small things that actually will add up to stewardship practices. There are some fallacies in antibiotic treatment. We have to understand that broader is better is not right. Sickness requires immediate treatment. Again, sickness depends on what it is. Okay, patient is sick. You require 4 antibiotics, 5 antibiotics. You don't have anything in the culture. No, you have to find out what is getting it there. You have to look at, you have to evaluate more at the same time. Failure to respond is not failure to cover. There may be other factors influencing. Response implies diagnosis. I gave ceftriaxone and fever is gone. Does not mean it's enteric always. Right? Probably it was a viral illness just getting better. So response does not imply diagnosis. When in doubt, changing a drug, adding drugs, a lot of newer drugs, lot of newer combination, all this is only going to add to your resistance. Again, antibiotics are not harmless. They will definitely bite back. So antibiotics are powerful medicines. They're not always the answer. Misusing now means you may not have anything to use later. You have to help keeping antibiotics working. Antimicrobial resistance is definitely an urgent public health and a patient safety concern. Know your enemy, whom you have to fight. That is definitely wise. AMS is always a teamwork, like how I see the United Microbiology Blue Warriors here. Don't give antibiotics if there is no cure. Can bite back, so please use them wisely. I mean, this comes not just from us, this comes from the national leaders. There is something called Swachh Bharat Abhiyan. So, something coming from the nation, all of us, that we can do to do the thing no harm in our hospital is definitely a strict infection control. We may be going into an antibiotic period. Together we can win the war. Doing stewardship is not easy. The only way to do great work is just love what you do. That's the only way you can do something. We have a long way to go, and I will always end my presentation with this slide. Happy birthday, Pencilin. I just hope your tribe increases. Thank you.
Morning. I think it is an excellent and clear cut informative talk on this antimicrobial stewardship towards syndromic stewardship. It is the need of the topic. I think you told all points regarding this topic. So as a clinician, initially in 2003, I heard that there is a syndromic treatment for RTA, STA. So now we moved to curb the antibiotic combinations and to avoid the antibiotic resistance. So it is a excellent talk. So what about the colonization and contamination in this multiplex PCR?
To understand that PCR is supposed to be something that is extremely sensitive. So there are chances that you will pick up colonizers effect. But if I say I have a prosthetic joint and I sent an in-drop sample for a blood, then picking whatever I see there is unlikely to be a contact. So you have to definitely take the clinical picture into account before disregarding. Or say I have another PGI and I have a prosthetic joint and the prosthetic joint panel is negative. But my culture picks up coagulase negative staph. Coagulase negative staph is a contaminant otherwise. But in this clinical setting, my PGI panel does not have cons, it's not picked up cons, but the culture has grown. Clinically significant in this. So you have to have a clinical, PCRs and everything definitely add on.
As a pediatrician, I want to know what about the application in pediatrics?
So definitely pediatrics also, sir. We use a lot of respiratory viral panels. Then BCID is something that can definitely implement in your ICUs. Like I said, time to effective therapy. Say you have a enterobacteriaceae flag. You have a gram-negative flag. You have a BCID. BCID is showing enterobacterials. You've started on meropenem, but your resistance gene is also showing an NDM and oxaprotein. Then you're immediately going to add polymyxin to that patient. Or if it is showing an oxaprotein, then you probably will look at septicemia back. So if it's an enterobacterial, if it is pseudo, obviously, or if it's an Acinetobacter, you cannot totally rely on the BCID's best mechanism. So we are reducing the time to effective therapy by so many hours, because by the time the sensitivity is going to come, it's going to come the next day. So it will definitely, we probably may miss the bus.
Madam, regarding sepsis, I have a few questions now. So invariably, all the guidelines suggest 14 days course for sepsis. Is there any shorter duration course, as you mentioned, for other syndromes?
So again, one size will not fit all. So what I want to say is 14 days for everything is not the answer. Because you have enough evidence. For example, it depends on, you have a bacteria. We always have to know, we are not going to treat the bacteria. We need to treat the source from where the bacteria is coming. For example, I have two patients. One has a bacteria, but that bacteria is coming from septic arthritis or endocarditis. My duration is going to be longer. Whereas I have another patient with bacteria, and the bacteria, the source is possibly say pyonephritis. My duration is not going to be as long as the patient that I have with infective endocarditis. So everything depends upon what the source is before defining a period of 14 days. Like a lot of RCTs have shown, respiratory-associated pneumonia, you can cut off the treatment to 8 days, cap to 5 days.
Also, when to start antibiotics in case of suspected sepsis? As per the news 2 guidelines, it suggests antibiotics should be started as early as possible within 6 hours, preferably within the first 1 hour of admission.
So yes, sir, definitely. See, if your lactates are high, patient is hypotensive, and all these indications, I don't think we just draw cultures and send. But at the same time, you have a PUO, in your ward, trophy. we don't have to rush to antibiotic unless we think it's a bacterial syndrome. For example, I have a 10-day fever, I have a normal count, I have eosinopenia. It could be enteric. I can start an antibiotic on that patient. Whereas I have a patient who's come in the PO, I don't have clinical localization except for the fever, everything else is normal. I can wait and evaluate the fever.
Thank you. Any questions from the audience?
For an asymptomatic bacteriuria patient, if at all there is radiological evidence. For an asymptomatic bacteriuria patient, if at all there is a radiological suggestion that he is having systems. What is the goal? What is the moment? What is the implementation? Again, this thing on cystitis or an ultrasound is just a radiological diagnosis. I mean, I'm sure as clinicians, a lot of you have seen this in and out. Unless you have symptoms, you have pyuria, I don't think you need to, irrespective of the colony count. It's not, these days, it's not like 10/5 is a must. I have a patient with fever and I have pyuria and I have 10/2, it is cystitis. So make the syndromic diagnosis. Radiology showing renal abscess, that's different. But this radiology showing cystitis is, I'm sure if we have radiologists here itself, they will agree to me. We see this in and out, we don't treat. Presentation of action, treating and teaching both shown and very well shown. And my only question is, you talked about the AMR profiling of molecular profiling of AMR, which reduces the effective time to treatment. But the gene is detected may not be expressed at by the bacteria. So what is your take on this? That is why it all depends upon what you're handling. For example, if you're non-fermenters, if you're handling, I will not definitely rely on, there can be other mechanism of resistance which will not pick up on the molecule. So you cannot de-escalate based on that at all. And even if I say I detect an Acinetobacter, no resistant mechanism, I know the carbonist, I know the antibiogram of my place. Say about 90% or 95% are carbapenem resistant. So I will not de-escalate till I have the ASTs the next day. Yes, they will only aid. They will definitely aid. When it comes to enterobacterials, I told you we can definitely go up. When I see an oxalate 8, I will go up. Or when I see an NDM, I definitely go up. But when it comes, it all has some limitations.
Thank you, madam.
Thank you, ma'am, for this informative session. And now I request Dr. Stalin sir and Dr. Rajasekhar sir to present the extensive aid of the Vijayalakshmi madam.
Excuse me, please.
I request Dr. Amuda ma'am, Assistant Professor of Microbiology, Government Key Park Medical College, to felicitate Chairperson Dr. Stalin sir and Dr. Rajasekhar sir. Thank you, ma'am.
Thank you all. Before chairing this session, one of my colleagues asked, as usual, are you going to tell any Tirukural for this session? So I have no idea, but after this session,
I would like to mention a Tirukural. Pilipai Sagadam, Achirum, Appandam, Salam Megatupaya. Which means even mild erage ஆனாலும் ரொம்ப அதிகமா ஒரு வண்டியில ஏறினா அந்த வண்டியோட அத்தியம் முடிஞ்சிடும். அதே மாதிரிதான் ஆன்டிபயோட்டிக்கா இருந்தாலும் ஓவரா ஒரு பேஷண்ட் கொடுத்தா அந்த பேஷண்ட்டுக்கு we are doing harm. So that is the Tirukural. Thank you.
I'd like to thank Dr. S.O.A. sir and microbiology team for this invitation and thank you, sir.
Thank you.
Thank you, sir. Moving to the next topic on ICU superbugs, plant challenges and critical care. Now I welcome Professor of Microbiology, Dr. P. Sheila Devi ma'am from Pondicherry Institute of Medical Sciences to enlighten us on this topic. I request Professor Dr. Tyagarajan Ravindra sir, Professor and HOD of Department of Microbiology, Government Key Park Medical College, and Dr. Professor of Nemalata ma'am, Professor of Omadura Government Medical College, to start the session.
We were together during our PG days. And Dr. Sheila, Professor of Microbiology, Adjunct Faculty in Medical Education from Pondicherry Institute of Medical Sciences, Pondicherry, has 24 years of UG and PG teaching experience in medical microbiology, MBBS from Bangalore Medical College, and MD from Jupma. Area of interest and specialization, bacteriology, antimicrobial resistance among enterobacterials, hospital infection prevention and control, and also the most awaited area, antimicrobial stewardship, and she is heading antimicrobial stewardship committee, and the contributions great. She was treasurer of IAMM and member of the Board of Studies, SRNCRI and RGGUHS, member secretary of Hospital Infection Control Committee and Antimicrobial Stewardship Committee, resource person for various workshops on research methodology, ethics, medical education, technologies, and scientific writing. She has guided undergraduate medical students, postgraduate students, and PhD students. She has published 50 research papers in peer-reviewed national and international journals. And now over to Dr. Sheila for enlightening us on antimicrobial stewardship, and particularly the challenges in ICU.
Thank you, thank you, Dr. Ravindra, for inviting me over here. This is my first time here. Topic that's told ICU current challenges in physical care. This is my outline of my presentation. Let's go with the case. 65-year-old male, diabetic, hypertensive, on admission, CDA on admission, was ventilated for 10 days. And at the end of 10 days, there was a clinical deterioration with fever, increased tracheal secretions, bursting, oxygenation, and new infiltrates on chest X-ray. The investigations revealed a doping count of 18,000 with procal elevated and endotracheal aspirate culture showing Helicobacter pneumoniae. With the antimicrobial susceptibility of resistant to piperacillin
tazobacter, cephalosporin, sulbacter, carbapenems and chloroquinones and sensitive only to colistin. This is something which we see day in and day out and it's labeled as ventilator associated pneumonia with CRAB, that is carbapenem resistant Acinetobacter baumannii. Now, why do these ICU superbugs matter? Because we all are aware that once superbugs got infected, especially with sepsis and VAP, the high mortality, the prolonged ICU stay, and also there is increased cost and there is a strain on the resources which is there, which leads to adds to the economic burden. And because there is a limited therapeutic options where now even colistin is losing its effectiveness. Now looking at the global toll of antimicrobial resistance, this paper was there in Lancet in 2022, where 1.27 million cases deaths were directly attributed to AMR and 4.9 million cases were attributed to AMR. And they predicted that if there is no intervention which happens effectively, then the AMR deaths could increase to 10 million per year by 2050. So if you look at the total burden of AMR in ICUs, we know it is one of the severe health burdens today, and nearly half of the ICU infections worldwide are caused by MDRs, and the mortality rates are up to 50%, especially with sepsis and VAP. Now, if you look at the global data, there are two studies from Europe. One is the Eurobac study, which in their study they have mentioned around 84.6% of carbapenem resistant Acinetobacters were there, which was alarming, and ICU clustering infections carried a mortality of 37%. In European CDC data, they have predicted that it is almost the carbapenem approaching around 70% in Acinetobacters. Now, come to our Indian data, 2.1% of the ICU clustering infections are caused by grafting, and 80% of the VAP is caused by Acinetobacter, Klebsiella, Pseudomonas. Now, among them, if you see, the carbapenem resistance in Klebsiella is around 65 to 69%, and with E. coli, it is around approximately 40%. But then now we also have the Candida auris outbreaks, which is rising in the ICUs. Now, all when we have to look at it, both some we look at the epidemiology of this ICU infection. So we have the agent, the host, and the environment. Now, if you look at the WHO priority pathogens, you have the critical, the high, and the medium. Now, we are more worried only with the critical in ICUs, where you have the Acinetobacter, Pseudomonas, and the Enterobacterians, which are there. We also have this list of the escape pathogens. Again, they are all the bugs which are there in the ICUs. Now, what are the characteristics of this ICU superbugs? They are all MDRs. They can spread resistance genes rapidly to the other bacteria. They can form biofilms. They survive in hospital environments. They are prone to cause outbreaks. They colonize patients silently. They have very limited therapeutic options and are associated with increased mortality. Now, these are the characteristics. If you put it in a coding, it survives, it undergoes rapid genetic adaptation, it versus evades antimicrobial action, it resists multiple drug classes, it has a main burden on mortality and morbidity, it causes under-recognized colonization, and it generates outbreaks. Now, if you look at the superbugs as in our setting, the one to top the list is the carbapenem resistant Acinetobacter baumannii, followed by the CREs, that is the carbapenem resistant Enterobacteriates. Then you have the MDR and the XDR Pseudomonas, MRSA, Candida auris, BREs, ESBL producing Enterobacterials, and now to the list you have the colistin resistant gram-negative bacilli. Now, I have not gone into the details of what are the other factors, the Wilkins factors, etc. of the agent, but let's see the host factors. If you look at the triad, agent, the host, and the environment. So if you look at the host factors, we all know that the patients who are there are all critically ill. So most of them are immunocompromised. Either they are elderly or they are with any comorbidities like COPD, diabetes, or renal failure, which itself is a risk factor for acquiring these infections. Then you have a lot of these invasive devices. You see all circuits are there when you enter inside with central lines, ventilators, urinary catheters. All of them increase the infection risk because definitely there is some compromise to the integrity of the skin or the mucosal membrane. Then the prolonged ICU stay. The longer the exposure, it increases colonization, and the longer the infection is likely. So if you look at the HAIs, with prolonged ICU stays, you have the HIs which keeps on adding. And of course, the patients will have with a high Apache score or the SOFA scores are more vulnerable to this ICU infections. Coming on to the environment factors, overcrowding. Now, at least in medical colleges, I see that you are supposed to show this many number of ICU beds. Even if you have a restraint, space constraint is there, but then the number of beds are increased. There is definitely overcrowding. Anti-hygiene lapses which we see with contaminated surfaces and equipment. You don't have the frequent cleaning with adequate disinfectant is not there. Water and sink reservoir are main reservoirs. Earlier we used to have this, every you should have as many sinks as possible. But now actually look at the Europeans. Now they are actually removing their sinks from the ICU. They are putting it outside the ICUs because that is forming a major source of, especially with Pseudomonas, Legionella, and Acinetobacter, and also Burkholderia cepacia, which is again from water. And then those invasive devices. Antibiotic pressure is very high in an ICU. So you have these bugs which starts mutating and surviving. Then, as I said, inadequate cleaning and disinfection. High colonization pressure is there and shortage of staff. That one-on-one for a ventilated patient in an ICU nurse is very, very difficult. And mostly they will give one ventilated patient with a non-ventilated, and then what happens, whatever is there, you carry on to the other patient also. So this is just to sum up the ICU environmental risk factors. And this is to sum up the epidemiological triad of ICU acquired infections. If you look at the number of the equipments which are there, which mostly doesn't get cleaned, it just dies there, nobody cleans it, and then the next patient comes in and then they use it. Especially if you see all these, we keep having growths from this ventilators. Once the patient is off the ventilator, by the time they would treat, there's another patient which stands up and then the ventilator is put. And within 48, 72 hours, the person is colonized with carbapenem-resistant Acinetobacter pyogenes, which we see very, very commonly, and the contents and the fluid which is there, nobody changes that. I think that is again one of the big sources where you can get these organisms, superbugs get survive. Now, if you look at what are the challenges in the critical care, the first one is about the rising antimicrobial resistance, which we have been talking, I think, since morning. And these are all the lists of organisms which forms a major threat. Now, these can lead to treatment failures, they can cause outbreaks, and they can also lead to increased mortality. Now, if you look at some of the studies in India where ICMR had done AMR surveillance networking and as well as the HI surveillance network of India, where the HI surveillance network of India included 47 hospitals with 180 ICUs, and they have reported over 7,092 ICU bloodstream infections over 7 years. So in that study, they had reported a 68.4% of all the bloodstream infections were attributed to gram-negative pathogens, and MRSA prevalence was around 70.7%. And also they found that 4 out of 5 Acinetobacter isolates in the Indian ICUs are carbapenem resistant. Now, the same National HI Surveillance Network, they have published a paper on BAP, where 13 hospitals with 40,500 533 ventilator days and 261 VAC episodes, they found that the VAC rate was 6.4 per 1,000 ventilator days. And if you look at the carbapenem resistance, it was around 98% in Acinetobacter species. And mind you, this study is mainly with, there are very few corporate hospitals which are there. This is mainly with all the government hospitals. Then enterobacterials were around 85.5, and the upcoming, the colistin resistance was reported around 6% in enterobacterials, around 3.2% in Acinetobacter species. Now, this is another where 2024 findings of an ICMR study where the bloodstream infections, they found gram negatives to be around 72.1%, gram positive 17.7%, and fungi were 10.2%. Now, the second challenge is about the emergence of new resistant mechanisms. You detect one, within a few years, you have another new mechanism which comes in, and your antibiotic which was using is no more active. So, if you look at the list of these enzymes which was there and the year which was reported, so you have the TPC when I just put up a few with the MCR. Of course, we had a big QA try about the NDX when it was reported. And to top it all, we have this Candida auris, which is again quite commonly, it causes outbreaks in the ICUs. Now, unless if you pick it, only then you will be able to control it. The third thing is about the limited therapeutic options, where now if you look at it, the cracks, where the therapeutic options left are colistin, high dose sulfactam, and cefiderocol. Now, cefiderocol is not available in India, it is not marketed, but then you have few agencies which on request they actually import it from abroad and give, but then the cost goes in lakhs. Then you have the CR, again, you are left with ceftazidime avibactam or ceftaroline with aspirin combination or cefiderocol, FDR or XDR pseudomonas, otherwise also called as carbapenem resistant Pseudomonas aeruginosa, CRPA. You are left with a combination of ceftolozone and tazobactam. MRSAs, of course, you have Vanco, Tico, linezolid. Now you have the prednisolid, which is coming. Then Candida auris. You have left only with echinocandins and liposomal amphotericin B. Now coming to the diagnostic challenges, we should actually keep so much talking about antimicrobial stewardship. We also should actually start with diagnostic stewardship. What specimen to be sent? Is it relevant to be sent there? Because sometimes what happens is so many irrelevant samples are being sent and we report, and then unnecessary patients are being started on antibiotics. So we need to have a diagnostic stewardship. Now we have this habit of, our postgraduates will come. Any patient admitted in ICU, you send all cultures. The pan culture should go away. Specifically, what you require, you said only that. So here the challenges are between colonization versus infection. It's difficult to distinguish true infection from colonization, especially in ventilated patients. So where non-clinical argument comes in, you clinically get the patient and don't get the report and treat. Then delayed culture results. Conventional cultures require 48 to 72 hours, and so there is delay in the targeted therapy. Prior antibiotic exposure is again a diagnosis, it's a challenge because this will reduce the yield and increases false negative results, especially with bloodstream infections. Then you have the biofilm associated infections where organisms are embedded in the biofilms, and this may evade the routine detection. So the emergence of resistant mechanisms. So we also need to gear up to detect new mechanisms. Like most of us are like, you start introducing these tests where you want to detect kappa, NP tests, everything. Again, cost becomes a factor where we are not, because tests are available, we are not able to introduce them. Then limited rapid diagnostics because not all hospitals or laboratories have molecular testing, especially with resource limited settings. And then there is mixed infection, presence of multiple pathogens will complicate interpretation of cultures.
like I think the previous speaker was telling about the respiratory panel which is used. You have a list of organisms which comes in positive, then to which one to treat, which one not to treat is this one where your interpretation is very, very important. Sometimes I think we keep having this problem with our pulmonary medicine people because they will all start antifungals and we keep telling them why do you start antifungals? Then lack of local epidemiological data, that is you need to update the antivirograms, then you can actually suggest. So it is if you have your own antibiotic policies, if you know what are the organisms which are there, what is the resistant pattern, you can actually suggest the empirical therapy until the culture reports are ready. Now, I think lot we have heard about the antimicrobial stewardship challenge from morning. So I will just empirical broad spectrum therapies are given, prolonged antibiotic duration, given appropriate combination, which would result in selection of MDR organism and increase healthcare costs. Coming to the infection prevention challenges, hand hygiene lapses is the main, actually one of the major poor compliance which we get. Then inadequate PPE use and environmental contamination. Again, there is also this infrastructure issue that not adequate isolation groups. It's so difficult to go and request your management to tell no, we need isolation groups because again, space is a constraint. Now coming to the others like increased cost due to prolonged ICU stay, additional investigations, expensive antibiotics, and all these again adds to your economic burden. And human resource challenges are there, staffing, low nurse to patient ratio. This again, where you need to have 1:1 for ventilated patient and nurse, then staff burnout is there and a high workload. So this would impact increase HAI rates and reduce infection control compliance. Now, if you come to the strategies, how to combat this ICU superbugs, the main thing is strengthening the infection prevention and control. That is where our role as microbiologists come in. Strict and hygiene compliance. In our institute, we have 3 ICUs and we are not able to do fully wards, so we only look at the ICUs. Even in the ICUs, to reach up to the 60 to 70 is difficult. I always tell when they know the ICU is standing there, even then you are only able to achieve a compliance of 60 to 70%, not beyond that. Sometimes we just don't bother, and then we have tried so many things. So they said, okay, you try to get carrots, so whoever is doing better among all of them, you give them some appreciation, give us smiling back. That works for some time. Then after that, they go back to the same thing, and then say, no, it's better to have a stick rather than a carrot. So then again, you go back and you start telling them repeated, but still, it is very, very difficult to achieve beyond that. In fact, now I think with our hospital nursing excellence, they have to show one of the indicators. So for that, KPIs. So one of this one was actually hand hygiene. So we have told the nurses now that those who are they go for the assistant nursing sprint. So A. So when they go A, we just tell them morning when you go for rounds, at least for half an hour you stand there and for the walls. So that we have just implemented, but then it's very, very difficult. We have tried so many things. In fact, when we have our Republic Day, we give them like the best hand hygiene awards and all that. We keep trying again and again. Then it starts from the head. That's what we keep telling the unit head when they go for rounds. At least you start. At least the juniors will follow. Or when they don't do, you point it out to them. And another thing is about. It's very easy to tell, no, we empower our nurses, but then they are in such a difficult position to tell the doctors, especially the unit heads, they will tell, Amma, you were about to go. So, there are multiple things where it comes to when actually introducing this hand hygiene compliance. In fact, we now tell them that the nurses, when you go for rounds, you carry the hand drum and go, so you give them at least they will use it. Then isolation and quarantine of MDR patients. If you do not have that many isolation groups, at least you can cohort your MDR patients. Active surveillance for high risk pathogens. This is something we found in recently. This orthopedics had a lot of post-op infections, SSIs. And then we had actually for some time we thought no, screening them for FDR, gram negatives. First we thought whether to introduce, not to introduce. Then we thought at least for some time let us see and then we will. So slowly actually the cases, the number of SSIs has come down. Then enhanced environment cleaning and disinfection. This also, it's very difficult to tell them how many times to clean in the ICUs. They will tell one per shift. We tell them no, twice you do per shift. At least when you come in and then you go, that doesn't happen. And we always have our clinicians telling, why should we remove our footwear and walk? See abroad and all, they walk with their footwear. Why are you telling us to remove? Then they had shoe covers. Now shoe cover was adding to the bulk of the waste there so much that we had stopped that. And then if you even put the ICU footwear to wear inside, then again the thing of how frequently it is cleaned. So nobody says, no, I don't want to wear that. That is already so dirty. I don't want to wear it. There are multiple challenges when it comes to this cleaning, the environmental cleaning and disinfection. The implementation of this BAP, CLAMSI and 40 bundles. Now for this, as I think Dr. Subhash showed, we also have a checklist. We ask them to go and see, at least at that point that they are doing, they find food. But then after that is a problem. Oral hygiene also, I take it from you. It's very, very difficult to introduce oral hygiene for patients who are menstruating. Continuous education and training for healthcare workers, whatever it is, we have to keep training them, and regular inspection surveillance, that is, and with feedback. Just doing a surveillance doesn't work. We need to give them feedback. So now if you see, I think the new NABH guidelines, every month you're supposed to have a infection prevention control BP. So every month we actually projected, we will see, okay, these are the audits we did, this is the problem which we have faced. Then coming to optimizing antimicrobial use, early appropriate empirical therapy based on local antibiograms. Now, this is something actually where you have to, who is available freely. If you could get personnel to enter the unit, you can analyze it, beautiful diagrams, bar diagrams, everything what you want comes in that. It's only that it needs to be entered in and it's freely, easily available. You need not have to pay anything extra. So when you analyze that, you can actually prepare your local antibiogram. Obtain cultures before initiating antibiotics whenever feasible. Timely de-escalation based on microbiology results. Now, this is something again, I have started with patient is doing fine. Why should I de-escalate? This is every time we keep getting that. You are not answerable to the patient. I am answerable to the patient. Then optimizing duration of antibiotic therapy. Again, which could be given as an infusion. Sometimes they just give it a go. How long infusion, duration, that's also very important. Prospective audit and feedback, and development of ICU specific antibiotic policies. This is something which is introduced. At least you will have what is the empirical therapy which could be introduced, and when cultures are available, reports are available, then you can de-escalate or escalate. And as it was pointed out, antimicrobial stewardship is a multidisciplinary team. Future directions, rapid diagnostics, because this is something important. Here we should remember that culture, your rapid diagnostics will not replace culture. It is complementary to it. And whenever, because it's very crucial in an ICU to start the antibiotic. So if rapid diagnostics, wherever introduced, it will definitely lead or it will improve your patient care. Whole genome sequencing for outbreak investigations could be used. AI. Everybody talks about AI and AI. So AI assisted stewardships, vaccination and preventive strategies. I think previous speaker had told about vaccination. Then now bacteriophage therapy is coming a big way. There are a lot of studies which is being done with bacteriophage therapy. Somebody I think from Kalpakam, there was one group, they presented on this diabetic foot ulcers, where they had used the bacteriophage and then very good results they had got. So that is something where you can explore in that area. Then novel antimicrobials and beta-lactam and beta-lactam inhibitor combination. And of course, we have whole country going in and talking about One Health approach. So to conclude, I see superbugs represent one of the greatest challenges in modern critical care. Success in combating them will depend not on a single intervention, but on a coordinated strategy integrating infection prevention, rapid diagnostic, antimicrobial stewardship, surveillance, and innovation. We should remember that every antibiotic prescribed today influences the effectiveness of antibiotics tomorrow. So if the ICU stewardship is not an option, it is a necessity. Thank you.
Good afternoon all. First, I thank Dr. Vinder sir and the team at for giving me this opportunity. Now coming to the presentation, madam, wonderful, insightful presentation, ma'am. Especially in this AMR era, the ICU superbugs. So here the AMR rate is especially it's very high. Like if you see 70 to 80%, it's very much alarming. So all these stewardship practices, we face many challenges, especially the infection control in the government setup. Only the microbiologist and ICN is talking about this now. No other is even bothered about that. As you said, the hand hygiene complaints, they are not worried at all. Even it is not 60 to 70 here, it is very less. So I think it is, as you said, the multidisciplinary approach from the administrator side, the manpower resources, all those, and also the clinicians, microbiologists, and pharmacologists has to lead. Now it is a high time we start to reduce this, but also the antimicrobial stewardship program. So it is not just the program or policies, we have to bring it in daily clinical practice so that we can do something to reduce this AMR and also the superbugs, because we have only few antibiotics. So it is not only to safeguard now, even the future, our next generation also should get some leftover antibiotics which we should safeguard. So I think we all can work together to bring this AMR at least to control by following strictly this infection control practices, and especially the hand hygiene we can follow, as you said. Thank you, ma'am. Thank you.
Thank you, Madam Lavila. The excellent enlightening talk on challenges in the ICU. We are facing so many challenges, and one of the most important challenges, pan drug resistance. Many times we are getting. I need to ask you to share your experience on that. When we get pan drug resistance, what answer can we give to the clinician?
In fact, currently now what is happening is even our holistic the MIC thing is not working. So we feel very bad when we keep everything is resistant, and then the clinician thought, what next? What am I supposed to do?
We're expecting micro to answer.
Microbiology to answer. So and most of the time actually if you see the higher antibiotic like Septa with the combination to that, now slowly what we can do from our end, because it's not feasible for us also, like the gene detection and if you okay, it's KPC or it is OXA, it is NTM, so you can do this. So we are actually trying to do like, because our MSc this thing was not working, then we started with this elution, holistic elution testing. Then slowly now we have got the disk and we keep doing the synergy testing. So like that we have been doing. And another thing is, if you see mostly for us, apart from the VAP which is there, we get lot of this diabetic foot ulcers will come with multi-drug resistance. So most of the time I keep telling them, first proper sample collection is what is required. You collect a proper sample, collect your tissue, or you collect any. What they do is they just open, they see the first period, you can swab, take it and send. You first clean with saline. That part I think they think that go in between all everything will go and get a no growth. That is the postgraduate this one. But then when it is colonization, then there is no need to treat. Even recently we have one case where the ortho Klebsiella to be sensitive only to pesticide, everything else is resistant. But clinically, patient has just got a serious discharge. I said ignore that. It is just colonization. You do not have to treat. Clinically, patient is fine, then leave it. So all these things like it's two-way. You have to look at the patient and then see whether it's really required or not.
Thank you, madam. We'll work for case to case. We have to discuss and go about using the antibiotic.
Thank you.
Questions from the audience?
And even the online audience, we can post the chat. Any questions from our participants? There are no questions. Thank you, madam.
Thank you.
Thank you, ma'am, for this wonderful session.
Chat. They have again asked the role of AI in antimicrobial stewardship program. AI. Now actually you have a lot of these platforms which introduces to where you can track and you will see the clustering of cases. So in those actually you can use now. Now the younger generation is a lot more with tech. So with them actually you can introduce, but as such I don't have any personal experience on using AI for. Okay, ma'am. Thank you.
Thank you, ma'am.
Thank you, madam.
Now I request Professor Dr. Tyagarajan Ravindra sir and Dr. Hemalata ma'am to felicitate Dr. Sheila Devi ma'am. Thank you, ma'am. Thank you, sir. Now I request Dr. Lavanya ma'am, Assistant Professor of Microbiology, GKMC, to felicitate the chairpersons, Dr. Tyagarajan Ravindra sir and Dr. Hemalata. Thank you, sir. Thank you, ma'am. Moving on to the next topic on the 5 R's antibiotics, the right drug, right way. Now I will welcome our Senior Assistant Professor of Microbiology, Dr. Pravina ma'am, GKMC, to enlighten us on this topic. I request Dr. Shanti ma'am, Professor of Obstetrics and Gynecology, GKMC, and Dr. Suganti ma'am, Retired Associate Professor of Microbiology, GKMC, to chair this session.
Good afternoon, everyone. On the first hand, I'd like to thank the Department of Microbiology, my mother's place, for inviting me for this session. A few words about Dr. Pradeep. Dr. Pravina, she's a dedicated microbiologist with a wide knowledge, and she's got more than 8 years of experience in this field. She's the backbone of the molecular lab of KMC. She finished her post-graduation in July 2011 in Rajiv Gandhi Government Medical Hospital. After that, she has worked in PHCs. She has worked in King Institute of Preventive Medicine, Chennai, and she's also worked in Omandura, and she's been working here in KMC from November 2019. She's got a wide clinical and lab experience in bacteriology, mycology, parasitology, virology, and immunology. She has conducted training programs in infection, hospital infection control practices, and biomedical waste management to all the hospital staff. In COVID period, she's the backbone, as I told you, she's the backbone for setting up the molecular lab for troubleshooting, data entry in ICMR and state government portals. She's a great teacher with good knowledge of microbiology. Over to you, Pravina.
Thank you, madam. Too much of words from you. We all were, still I remember this golden period during COVID times where we were setting up the lab, molecular lab, working together. So today, my topic is actually. So thank you for all of you for coming to this knowledge brimming sessions. So we were from the morning, we were just listening to all these kinds, and my topic will be just a repetition. Maybe just I'm going to reinforce whatever you have been learning from the morning. So I will be more towards antibiotics because my topic is the 5R of antibiotics. So all the resistances, as Madam had told, Madhu Madam had talked about ICU settings, everything. Sheila Madam and Vidya Madam had talked about. But I will be sticking more towards antibiotics. Next. So what is my topic? 5R fantasy deck. Okay, 5R or 5D, anything it is meant about how you choose the antibiotics for a patient. So it is not that you start the antibiotics when a person immediately comes and gets inside the ICU. It is not like that. Okay, so it's not a criteria. Getting admission in the ICU is not a criteria to start the patient on antibiotics. And right drug. We most of the time we don't know what drug to choose for the patient. So we need to have a clinical diagnosis before you put the patient on treatment. First, have a provisional diagnosis. Clinical examination history is more important than any other thing. Dose, route, duration, I will be talking on, or a little bit, I will be touching upon pharmacokinetics and dynamics. Okay, so there is the AWARE classification. We all know, we are aware of the AWARE book by the WHO. So it has the list of access, watched and reserved classes of antibiotics. So most of the time in hospital, like my hospital government setups, in where we have a lot of ICU tertiary care patients, we tend to generally release all the antibiotics. We are not able to just restrict the reserve. But during rounds, we go and check them whether the reserve category of antibiotics are being used appropriately. So that is how we try to reserve the reserve class of antibiotics. Access and watch what we do routinely, we release all the reports and it is not being monitored as it is to be, but reserve has to be reserved in a very quiet manner. So as WHO, I told you, they concentrate on all these points, like you need to have a proper diagnosis, decide upon what you're starting, which drug, dose, delivery, how it is delivered, and discuss with your team members. It is not that the patient is admitted in surgery. This is not that the patient is admitted under ICU medicine care. So I will be putting my own antibiotic. So it is not that kind of a treatment. Here it should be a teamwork. So we need to discuss with other team members whether my provisional diagnosis is correct or wrong. So what kind of antibiotic can I start with? So it's always better to access somebody other than your department, so that they will also give you inputs in deciding what antibiotics. So the same points what we were talking from the morning. So who should I treat? Whether it is a contamination, colonization, or a real infection or not. So as Madam, all madams had clearly told you, please don't treat colonizations. It should be definitely an infection. So how we will decide whether it's an infection or not? Microbiology report doesn't tell you this is an infection. It just tells you that some organism has grown in the culture. So as Madam was correctly pointing out, in a catheterized patient who has been admitted with no other symptoms, but he is coming to you with the reports. Because there a patient is admitted and he is having some other kind of presentation, but he is having 10 colonies of bacteria in his urine. So we need to really treat the patient. It is not that because the growth is there in the microbiology report, you suddenly start on antibiotics. So it does not be the case for treating an infection. You need to really look upon whether it is a colonization or it's a really an infection. So again, the same thing. So this is the paper published where it has been clearly defined or clearly analyzed. How will you differentiate between a colonization and a pathogen? So there are a lot of markers associated with this. So if you see, you should have a clinical diagnosis. First and foremost, please have a clinical diagnosis. Along with that, you can use additional representations. Like you can have procalcitonin markers, CRP, lot of markers are there, which we do in and out in the ICU settings. So these markers will just support your evidence of diagnosis. They are not going to replace anything. They are not going to replace your clinical diagnosis. You cannot use procalcitonin as a marker to start antibiotic. You have to combine it with your clinical cues. So whether this patient is really having an infection, okay, so then you see the procalcitonin level.
Then you see the culture report. Whether all these things are giving me supportive evidences for putting the patient on antibiotic. If that doesn't happen, then you are not justified in starting antibiotic for this patient. So there should be a combined approach of it is an infection or a colonization or just only the bug is present there and you're treating somebody else. So this is what I was telling you. So it's just another foreign body. The catheter is just another foreign body which is lying there. So there is an organism which is sitting on outside. MDRO, because mostly ICU setup, we start like patients will be started on ceftazidime, navibactam, and we will be like tigecycline, everything we see. But those drugs are justified only if there are associated risk factors for these patients. So what are the risk factors we will look up into before starting an antibiotic for this multi-drug resistant organism? So these factors, whether patient has been previously colonized or he was previously admitted in the hospital, or he is having any other comorbid conditions, or he was on immunosuppression, he had taken antibiotics previously. So all this history is very, very important. So you need to evaluate all these things before you put high-end antibiotics, right? Ceftazid, Mavibacter, Digicycline, Cefiderocol, whatever it is. So before you start on antibiotic coverage for multi-drug resistant organism, these things, any of these things should be there. Otherwise, there is no need to put a broad spectrum, higher end antibiotic and ICU. So this is the campaign. Mainly focused on. So these are the things which they have added upon in the surviving success guideline. So as I told you, high risk factors need to be there for starting a higher end multi-drug resistant antibiotic coverage. Similarly, there the anaerobic coverage. Most of the time we combine anything with anything, gram positive, gram negative, along with one anaerobic coverage. We don't know what is the indication. You need to have a clear cut evidence for starting an anaerobic coverage. So what is that evidence? Evidence is that there should be an association with intra-abdominal or deep-seated gynecological infections or any other kind of necrotizing tissue. So anything associated with deep-seated abscesses, so all these will clearly help you in choosing anaerobic coverage along with the gram positive and gram negative coverages. So if you don't have these criteria, please don't put the patient on anaerobic coverage. Moreover, we see patients in ICU where piperacillin tazobactam combined with metronidazole and meropenem being combined with metronidazole. There is no need because there is coverage of anaerobic coverage is already there for piperacillin tazobactam and anaerobic coverage is already there for meropenem. When you put cephalosporins don't have adequate coverage for anaerobes. So then you are justified in combining cephalosporins along with metronidazole. Otherwise, no need to have an anaerobic coverage for in ICU patients. Along with the indications, if there is a clinical condition, need to start. Otherwise, there is no need to start them on anaerobic. Similarly, for antifungal, clear-cut risk factors should be there before you put on an antifungal coverage. So this is where we don't have a proper balance in the ICU setting. So start on an empirical, just leave it on. So the balance shifts. Always you have to balance it by de-escalation. So this is where you balance, you prevent the antimicrobial resistance by narrowing the spectrum. You get the culture reports, narrow it down. You start in a broad spectrum, you get an organism which is found to be susceptible, please narrow the spectrum. The spectrum has to be narrowed. And after 10 days or depending upon whatever the clinical condition the patient has, convert it to de-escalation, convert it to an oral therapy. Most of the time, we think patient in what? Patient is admitted. Only I of course. It's not that. There are lots of trials where IV drugs are being compared with the oral therapy. And there have a lot of evidence there. Oral therapy very, very good comparative to the IV administrations. So also you should look into other factors, patient co-factors when you are administering these antibiotics. So now a little bit about the pharmacokinetics and pharmacokinetics. I will not be going into the details. So once you start administering these drugs, you need to know what will happen to the drug. The next thing is what the drug will do to the organism and to the body. Okay, so this is where you should be very careful when you're treating the patients, particularly ill patients. So you need to think like the drugs which we are administering, whether they have an increased volume of distribution. This volume of distribution is very, very important. So if in a critically ill patient, this volume of distribution will be very high. So if you give a drug where the volume of distribution is not good, he is not going to respond to your therapy. So depending upon the drug we choose, he is going to respond to your antibacterial therapy. So some drugs will have good volume of distribution. Some drugs will never cross the tissue. They will be just lying in the plasma or the serum and they will be excreted as such to the urine. So in a bacteremia patient, in a septicemia patient, you need to put them on such antibiotics which will be there in their blood for quite longer time. So if you give a drug which soon causes the tissues and goes to the intracellular compartment, there will be no effect in the bacteremia cases. So this is what is the problem was happening with digicycline. Digicycline was found to be having a lot of intracellular distribution than in the bloodstream distribution. So it was failing in treating for patients with sepsis. So one more thing is think of what kind of dynamics the drug is going to undergo. Whether it is a time dependent killing or a concentration dependent killing. So we always use what we use in the ICUs is usually beta lactam drugs. So all majority of the beta lactam drugs will have time dependent killing. So what is this meant by time dependent killing? Madam, everyone was talking about continuous infusions. So this word is very, very important. There is no role for IV bolus drug administrations in an ICU. So please start on ICU, continuous in an ICU, start on continuous infusions of antibiotics. The time duration, how much duration the antibiotic is over the MIC level is more effective in killing the bacteria than how you offer the patient, how the delivery of the drug is being offered. So there are many trials which have told, this is the chart showing the concentration dependent killing, and the another one is time dependent killing. Concentration dependent killing is where how many aminoglycosides play a very important role. They are dependent on how much dose of the drug you administer to the patient. They are not dependent on the time over killing. Whereas beta lactams like penicillin, cephalosporins, all these drugs are dependent on time dependent killing. So you need to know which kind of drug follows what kind of dynamics. Whereas vancomycin is an entirely different journal. It relies on AUC by MIC, area under the curve distribution. So there is no time. I mean, this drug is dependent on both the factors, time and time and dose. How much time it was above the MIC and how much drug was above the MIC. So this is entirely different. Vancomycin has a very entirely different type of pharmacodynamics compared to other drugs like beta lactams and other aminoglycosides. So this is what I was telling you. In a critically ill patients, if you administer just IV boluses, you will not have the sufficient duration of the drug over the MIC level. So this is very important. The time over MIC is very important for the patient to effectively come out of the bacterial infection. So there are lots and lots of trials. So all these trials will tell you, if you see the p value in all these trials, everything has a significant range. So everything tells you this p value is less than 0.001, p less 0.04. Everything is having a significant shift towards infusions, continuous infusions favoring rather than giving us IV bolus administrations. So switch over, it is time for us to switch over to intermittent infusions or continuous infusions. Better to go in for infusions than giving us an IV dose. So this is again the Blink trial which shows you the study trial findings were favoring towards continuous infusions and rather than intermittent infusions. So this is what I was talking. So therapeutic drug monitoring is very, very important. For vancomycin, you need to have therapeutic drug monitoring. So vancomycin is a drug which has a lot of toxicities, renal toxicity. We have to optimize the dosage when you administer the patients, like especially for critically ill patients having renal failure or any other kind of organ failure. You need to know whether the drug is in the steady state concentration to achieve its bactericidal efficacy. Otherwise, if you don't have a proper peak level or a trough level and there is no steady state concentration, the drug will fail. So we will be bewildered whether I had started the patient on vancomycin, it was a clear cut MRSA organism, but still the patient is not improving. Why is it? Because you have not followed the optimum steady state concentration in the patient, and so the drug will not work. So site-specific dosing is also very important. So we tend to forget meningitis cases, you need to have higher doses. Osteomyelitis cases, longer, prolonged duration. Drug has to enter into the bone and need to kill. And endocarditis is very dormant. There will be a lot of dormant bacteria in endocarditis. So you need to give prolonged high dose therapy. And the therapy should cover and longer durations need to be started in these cases of infections. So as I told you, it's not that you have to always start the patient on IV. There are drugs which are good by oral itself. Good oral bioavailability. So these drugs like linezolid, fluoroquinolones, metronidazole, doxycycline, they can act in the same way if you give them either orally or you give them as an infusion, IV. One more thing is IV to oral switch. We don't do that in critical care, but it is necessary that we convert this IV into oral drug. So this will bring down the cost effectiveness, like a lot of patient morbidity, patient will be happy to take it orally, not being admitted in the ICUs for longer duration. So everything can be brought down by this simple mechanism of IV to oral switch. This is called as IVOST. So there is an ongoing SNAP trial which has evaluated. There was a question in the morning about whether bacteremia you need to have 7 days or 14 days of treatment. So everything depends on the patient. Patient is getting better. He is becoming stable. The patient with bacteremia, then convert him to oral therapy. No need to put him on IV long durations. Okay. Similarly, patient is not okay. Just continue him with IV therapy. So you need to put the patient, convert the patient from IV to oral, depending on each individualized status of the patient. It is not a hard and fast rule that you convert them at 7 days, that you convert them at 14 days. You need to look into the patient's perspective and naturally turn this into a oral therapy. So this is again the POET trial, which has already been proved. That previous one, SNAP trial, has been ongoing, and it is telling whether bacteremia is like IV oral switch is effective or not. This POET trial has already established that in endocarditis patient, it is as effective in putting the patients after the patients are being stabilized. You can convert them into oral therapy. So this is termed as a non-inferior trial. So it was found that there is no inferiority in converting the patients into oral therapy after the patient has attained the stable nature. Madam had already talked about all these courses, how much course. So this is the 7 days, 14 days, 21 days. Now everything has come down to shorter courses. Okay. Now 5 number is the fancy number. We don't go for 7. So in all these cases, you can convert to 5-day course of therapy. This slide was already put up by Madam Vidya Madam. So the same thing I have copied it. And all these trials, the trials which I have mentioned, all of them have favored that instead of the longer duration, the shorter duration is as effective as the longer duration. So it is very important that we no need to give the olden days what we are calling, like 7 days you have to take, 14 days you have to take. No need. We have effectively we can convert these patients for a 5-day oral therapy. So I will just tell you a case and you can tell me what inputs what I have given you. So a 64-year-old male presents with fever, hypertension, altered sensorium, tachypnea, hypoxia. So already he is very critically ill. And he has some comorbid conditions like diabetes, CKD stage 3, recent hospitalization. Now my impression is I have come to a clinical diagnosis that it is septic shock. Likely healthcare associated. Why is it so? Because patient was already admitted previously. So this history is very important. If I miss this history, I will not be able to identify that it is a healthcare associated infection. So what would be most common healthcare associated infection? What we will be seeing in our hospitals: pneumonia, CLABSI, all these things, urinary source, catheterized urinary infections. So probably it could be one of them causing the problem. So so the initial management, take blood cultures. Evaluation is completed, take blood cultures, 2 sets. 2 sets is mandatory, and then you put the patient on broad spectrum coverage. So here, gram-negative, gram-positive coverage was done. Vancomycin and meropenem. So this is justified. So since patient was previously hospitalized and he is under comorbid conditions are there, so you have started them on any kind of infection could be there, gram-positive or gram-negative. So meropenem and vancomycin is started. So the right drug, the meropenem will cover all the MDR kind of infections. Maybe it's the ESBL, which is common in our hospitals, and then MRSA, which we can cover. Vancomycin can cover the MRSA. So Pseudomonas also can be taken care by the meropenem. So after this, you get you put the patient on an IV infusion, not as intermittent dosings. So continue the patient with IV infusions, and then within 1 hour, you have to start the patient, as I already told you. And the reports, after 48 hours, the patient's culture reports come back, and it clearly tells you that the patient is having the MRSA bacteria. So now, the MRSA bacteria is susceptible to vancomycin, linezolid, and daptomycin. So what should I do now? Whether I should continue with vancomycin or change it to anything else? Meropenem can be dropped upon safely. Okay, so meropenem, you can rule it out. If you can take it out once you rule out any other gram-negative infection in this patient. So once you rule out gram-negative infection, you can safely remove meropenem from this patient and continue with vancomycin. Vancomycin, you need to have therapeutic drug monitoring. This patient is already very sick. In sick patients, vancomycin is very effective, but he is having additional comorbid conditions like renal problems and diabetes. So you have to switch over to therapeutic drug monitoring. You need to optimize the dose, and then only you can expect efficacy in treating this patient with vancomycin. Otherwise, there will be either underdosing or overdosing, or you will be landing up in adverse problems. Okay. So then, after the patient becomes stable, what I can do? Can I switch over to oral therapy? What oral drug will I choose here? Linezolid. That is how we want the clinicians to think now. So just the right way, how you see the infection, how you diagnose it, what antibiotics you choose, how you taper them. Start on antibiotic therapy, justify. Convert into narrow, then de-escalate. Convert into oral once the patient is stabilized. Stop the drug when it is not necessary. So this is what we wanted to emphasize by this antimicrobial stewardship. Thank you.
Thank you for the clear crystal presentation. Thank you for the presentation. One doubt, when you're saying about continuous infusion.
Yes, ma'am.
how long it has to be?
Actually, there are trials which are telling intermittent infusion from 3 hours to 4 hours. Now there are like advanced trials which are taking 24 hours of infusion. Yes. So there are more favoring of continuous infusions, but the trials have to be more in, like larger trials have to be put in to establish this continuous infusions. Otherwise, no evidence is there for bolus administrations. Any other questions?
Very clear presentation, Torina.
Thank you, ma'am.
So as clinicians and microbiologists has to work together to find out the correct pathogen, to identify the correct drug, dosage, duration, when to de-escalate, when to change into oral drugs, everything you have said very clearly. All the speakers have told the same thing and you emphasized it.
I have just
You have emphasized.
summarized everything from the morning.
Thank you for the very nice talk.
Thank you much for this wonderful session. I request Professor Dr. Shanti ma'am and Dr. Sugati ma'am to felicitate Professor Pravina ma'am. Thank you, ma'am. I request Dr. Devi ma'am, Assistant Professor of Microbiology, Government Key Park Medical College, to felicitate chairpersons, Professor Dr. Shanti ma'am and Dr. Suganti. Thank you, ma'am. Let's move on to the next topic on AMR, antibiotic audit, strengthening stewardship, safeguarding patients. Now I welcome our Associate Professor of Microbiology, Dr. S. Ravikumar sir, to enlighten us on this topic. I request Professor Dr. K. Sendal Kumar sir, Professor of Anesthesia, and Dr. Professor Karthikeyan T. Devi ma'am, Professor of Surgery, to chair this session.
Good morning, everyone. We'd like to introduce Professor S. Ravi Kumar, sir, Associate Professor in Microbiology. He passed out microbiology in the year 2000 from Coimbatore Medical College and has been working in Coimbatore, Omandura, Tiruvarur Medical College, Chengalpattu Medical College, and right now he is with us here. He has had research experience and has published nearly 6 papers on detection of anti-HPS antibody, HPV virus, elements, mycological profile of dermatophytes, antimicrobial susceptibility of Klebsiella, and urinary cavity assessment. He will now enlighten us about antimicrobial audit. Thank you, sir.
Good morning to all. My topics regarding the antibiotic audit. So in this I will discuss about how this strengthen the stewardship and how we can safeguard the patients from the AMR and others. So from the morning we were discussing about the antimicrobial stewardship interventions like AMR, then 5 Rs, then infection control prevention, then we were discussing about the infectious syndromes. Now here comes a point how we can assess or how we can audit how we can know the success of this antibiotics stewardship. So we should know the success, right? So everything has to be implemented. So how to assess whether it's been implemented or whether it's been communicated to the clinicians. So here lies the point, we should communicate everything to the clinicians so that it can be implemented. So how we can communicate all this antibiotic intervention to the clinicians means by doing antibiotic audit, we can communicate our findings to the clinicians so that everything can be implemented. So everything depends upon implementation actually. So by this way we can measure the success of our antibiotic stewardship. This is AMR antibiotic stewardship program. So in this picture we can see this what is the antibiotic stewardship, how antibiotic audit program is being done. So in this picture it shows how we have to do the antibiotic audit. So for doing the antibiotic audit, first thing is we have to first define the scope and the objectives. Then you collect the data, then assess everything, then communicate, take the feedback and communicate with the clinicians. Now, we discuss what is antibiotic audit. So what is antibiotic audit? It's one of the very important aspect of antibiotic stewardship. Why it's very important is there are two core interventions of antimicrobial stewardship. One is called the front-end strategy and the next one is called the back-end strategy. What is this front-end strategy? Front-end strategy is a pre-authorization. The next one is the back-end strategy. So this back-end strategy is an antibiotic audit, that is the cosmetic audit and feedback. That's called the back-end strategy, and it's a passive strategy. Where it implies this includes a clinical team. So now we'll see what is antibiotic audit. Antibiotic audit is one of the most important core intervention of antibiotic stewardship program. Then it's a structured system to monitor, evaluate, and improve antibiotic use in hospital and healthcare settings as a part of antimicrobial stewardship. So it improves quality, safety, and cost effectiveness. Antibiotic audits are systematic reviews of systemic decisions, the documentation, indication, duration, and guidance adherence. That is occurred to our antibiotic policy and other things. Then they help antibiotic stewardship teams identify where antibiotics are being used appropriately, where therapy can be optimized, and where variation across services may be driving unnecessary exposure to antibiotics. So in practice, audits turn every prescribing data into actionable insight for safer, more consistent care. So now So now we know what is antibiotic audit. Now we should know why need antibiotic audit. Why we need antibiotic audit means antibiotic resides. Mathematics said there is an increase in AMR trade and it's a silent pandemic. So antibiotic resistance continues to rise globally, which resistant infections associated with longer hospital stay, higher treatment cost, and worse outcomes. The World Health Organization has identified antimicrobial resistance as one of the top global public health threats, and hospitals are a critical settings for prevention of this AMR. So by preventing the AMR, we can reduce hospital costs, hospital stay, and higher treatment levels. The regular antibiotic audits support resistant prevention by reducing avoidable broad spectrum use, improving de-escalation, and strengthening guided compliance. So antibiotic audit provides an opportunity for the clinical team to discuss antibiotic prescription practices with the AMS team, identify the priority areas for change, and to specific goals for themselves and the facility department or board levels. So the clinicians can decide what they can do, and it's an autonomy. So now coming to the audits, what are the types of audits are there for antibiotic audit? There are two types of audit are there. One is called the prospective audit and next is the retrospective audit. What is this prospective audit? Prospective audit is called real-time audit and it's very effective. What is this real-time audit? Why it's called real-time audit means here we conduct the audit along with the clinicians. We go rounds with the clinicians for this antibiotic audit where we take all the documents, everything. Then that itself will be the recommendations for the clinician. That's it's called real-time audit. And what is this prospective audit and why we should do it? When it has to be conducted. As President said, every antibiotic, once you start the antibiotics, it has to be reassessed after 48 to 70 hours. So that is called the prospective audit. So in prospective audit, after starting the antibiotic, once antibiotic is has initiated, then you have to audit. Then after within 48 to 72 hours, that's called the prospective audit. And this audit is done by the real-time audit. And it's very effective. Right? This is one of the most effective and effective method of antibiotic stewardship. Then what is the retrospective audit? This in generally you don't follow this. Only the prospective audit is recommended for this antibiotic audit. The disadvantage of this prospective audit is this is repeated after the treatment. Once the patient is discharged, and after the treatment, we are going to audit this one. So there is not much use in doing this because patient cannot be given because after the treatment, we are going to audit this. So real-time intervention will not be there. But in case of prospective audit, the real-time intervention will be there so that we can implement whatever based on the analysis and evaluation, what are the findings, based on which we can implement our findings, and we can just tell the clinicians to change the antibiotics or de-escalate from IV to oral antibiotic or to stop the antibiotics like this. So it's in the real time and we beneficial for the patients. So always prospective audit is advisable. So what is this antibiotic audit cycle and how to conduct this audit cycle? So now you know what is antibiotic audit and why it is needed. Now we will come to how can do the antibiotic audit. How to do the antibiotic audit. So it comes different cycles with different steps, and it has to all steps has to be followed to make it a very reasonable one. So what are the steps which are involved in this antibiotic audit cycle means? So it is a structured cycle is essential because it turns antibiotic audit into a repeatable. So it should be a repeatable transfer process. So for this, make it a repeatable transfer process, it should be in a structured manner. That only can be a repeatable and a transfer process. Then by following the same sequence. So this is very important. So you have to follow the same sequence in order to make it as very reasonable one. So by following the same sequence each time, the teams can identify gaps consistently, then compare results over time and make sure findings lead to meaningful actions rather than the isolated review. So here, this findings will lead to meaningful action rather than the isolated review. Each step builds on the last, forming a continuous loop of evaluation, intervention, and improvement. So this picture shows the antibiotic audit, how we can conduct the antibiotic audit. So in this chart, there are 7 steps are there, okay, by which we can conduct the antibiotic audit. So it contains 7 steps. All the steps are very important, and the steps has to be followed to make it a very reasonable one. Okay, and we touch on the same order. So first thing is so here what is the first thing is you define the objectives and the scope of the audit. So what are the goals for doing this audit? Is the first step. The next is the data collection. You have to collect all the data by using our antibiotic audit form. So while doing this antibiotic audit, you have to use this antibiotic audit form. In this antibiotic audit form, you have to collect all the data, like patient details, the what's antibiotic is given, whether there is any IV antibiotic is there, the registration IV to oral, like this, all the details and you have to collect whether mitigation is there, culture be taken, whether the antibiotics is data after the collect after the culture results. So everything has to be documented in the antibiotic form. Then comes the data analysis. Once you collect the data from the patients, then the data has to be analyzed and it has to be evaluated. Once you analyze and evaluate the data, based on the audit findings, we can give the feedback to the clinicians. This is a very, very important step here actually. So for the body we were discussing AMR, everything. But whether you are communicating this to the clinician, that's very, very important. So by doing this antibiotic audit, we always communicate the findings to the audience so that they can implement the findings. Now next comes the audit findings. Next is the feedback and communication. We should know how to communicate. What way you can communicate to the clinicians. The next comes the implement the action plan. Based on the audit finding, you should have a plan and this audit plan has to be implemented. Then after implementation, you should re-audit and monitor. So this is also very important step. Always re-audit and monitor. So now coming to the objectives and scope of antibiotic audit. So what are the goals for this antibiotic audit means? What is the to promote rational antibiotic use, then reduce antimicrobial resistance, then improve patient outcome, reduce adverse drug reactions, decrease unnecessary antibiotic costs, ensure adherence to hospital antibiotic policy and guidelines. So that is our institutional antibiotic policy or standard antibiotic policy has to be followed. Then comes the scope. What the scope? So you have to define the scope. You have to define the scope, like Madam was talking about the syndromes. So like this, we can say take the infected syndromes as a scope. Then Dr. Madam was talking about the drugs 5 was what are the drugs can be given. So we can take the drugs as one of the body. Then other things, what are the things you can take is what whether there is any clear indications there or not. Like this, you can make the scopes. Then so audit may focus on the areas. What are this area means where we can conduct the audit, like ICU, NICU, PICU, SICU, or medical ward, surgical ward. So we can just define the scope where you want to conduct the audit. So based on this, you want to define the criteria. Whether it's antibiotic, you are going to do the audit on antibiotic, the criteria will be different. So like this, first define the scope where you want to do the audit. So areas like ICU, you can define the audit or audit based on antibiotic groups. Then by infections like urinary tract infections or RTI or bloodstream infections like this. Now comes the data collection. This is very, very important. This data collection is very, 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 very important because based on the data collection only, we are going to analyze and evaluate, and we are going to give the feedback and we are going to communicate the clinicians. So when taking the data collection, you have to collect all the data. You should not miss any data. So like what are the data you have to collect with patient details? In patient details, you have to collect the details like whether the patient is male patient, female patient, because it also is very significant because some infections are very common in the males, some infections are common in the females, like this age. Then you have to the importance for the weight of the patients also, weight, height, and the renal function, everything has body because the dose depends upon the weight of the patients. So we have to mention the weight of the patients. So all details has to come in which ward, right? So this everything should documented. Then now you have to set the audit criteria. What are the things should be audited? So set the audit criteria like what is like indication, whether there is any indication for starting the antibiotic or not. There should be one criteria. Then antibiotic selection, whether the antibiotic selected is appropriate or not, right? For the site of infection, like this. Then dose, whether right dose is given, then route of administration, right dose is there, then time. Like time is very important, right? Like for any services, the antibiotic has to be started before 4 hours, like this. So time is also very important. then sample for culture. That means you have to take the samples for microbiological culture before starting the antibiotic. Whether culture be taken before starting the antibiotic or it's be taken after starting the antibiotic. So always advisable to take the culture before starting the antibiotic. Then people know that whether there's any de-escalation of antibiotic. IV to oral is there, then duration is there, then everything has to be documented. This finding has to be documented. This is the antibiotic form which we use in our college, in our hospital for this antibiotic audit. So here all details, we put enter all the details in the forms like the age, then sex, height, weight, everything. Then here there is a column for the clinical condition and clinical diagnosis. Okay, so write out the diagnosis. What's the provisional diagnosis based on the clinical findings? So based on these findings, you whether the antibiotics is started or not, then you have to find whether there is any indication to start. If there is any real infection is there, then they can start the antibiotic, or without any infection or any sepsis, they start the antibiotic, then it is not it is irrelevant. So clinical diagnosis, then supported lab evidence for antibiotic usage, like biomarkers like CRP, procalcitonin. So we can compare with the clinical findings along this because culture report takes time. It comes after 40 to 70 hours. Before that, before the 40 to 70 hours, we can look for the biomarkers and the clinical findings. Based on the findings, whether the antibody started or not, that we can note down. Then, what is the type of sample set for the culture sensitivity? Then after the report comes, the report has to be entered. Then, so now you have to fill in the feedback form like name of the antibiotic, dose, frequency, put of administration, the duration of administration, is there any overlapping with the antibiotic? Whether one antibiotic started, other 3-4 antibiotics. Because in some cases, initially they start with 3 antibiotics. Like meropenem, vancomycin, doxy, everything, acetone like this, right? They add some 3-4 antibiotics also given. But then any overlapping is there. Then any indication for starting antibiotics there, that you have to note down. Then in this, write whether any de-escalation of the antibiotic is there. If it is there, just note down. Then escalation of the antibiotic. So in antibiotic audit, we have to look for the escalation and de-escalation. Both has to be, but not only de-escalation. In some cases, there is escalation also needed. So you have to note whether escalation is there or de-escalation is there. Then switch over of IV or IV or antibiotic. Then whether the antibiotic is stopped or not. So based on our recommendation, you have to note whether it's stopped or still they are continuing. In some cases, you have to stop the antibiotic after 5 days, after 7 days, but they keep on continuing for a week or 14 days, 14 days, 15 days like that. So the loss has to be noted. So this audit will be conducted by the AMS team. Okay. So active microbial steward team members will conduct the antibiotic audit. So there are 2 types of audit. In this, one thing is real-time audit can be conducted by going rounds with the clinician. Along with the clinician, you can go for the rounds. During the rounds itself, you can just note on all the points, and based on this, you can analyze, evaluate, then you can give the feedback that time itself, so that they can implement on the same time. There's advantage of doing the rounds along with the clinician. So it is called real-time audit. It is considered one of the gold standard method of antibiotic stewardship program. Then the other way is, the antibiotic team member alone, they can go alone and they can go and do the audit. Then they can communicate your findings to the clinicians. That's another way, right? So by this both ways you can do the audit. Then after collecting all the data, all this data has to be analyzed and it has to be evaluated. So what are things to be analyzed? So in the antibiotic form, you have filled all the, you have collected all the details like age, weight, right? Then what antibiotics there is given, whether it's indicated or not indicated, antibiotic oral, right? Whether repetition of antibiotic is there. So you have to analyze all the details. So here, first thing is the indication, whether was there any, whether the antibiotic is started based on any indication, that you have to analyze. Then drug selection, whether the selection of drug is appropriate or not, then dose is correct, then group, then duration, then whether this have been documented or not, everything has to be noted. So coming to the indication. Was there a clear clinical reasons to start antibiotic therapy, like suspected sepsis or controlled infection, sepsis or the guidance supported prophylaxis? So there are two types of it. One is the empirical antibiotic therapy can start, then next is the targeted antibiotic therapy. How we are going to start this empirical antibiotic therapy? So here comes the frontline strategy. There are two strategies are there. Frontline strategy and backend strategy. Frontline strategy is the pre-authorization. There is a formulary restrictions. So based on this formulary restriction or pre-authorization, you can start the empirical therapy. Okay. Then comes the backend strategy. Backend strategy. Prospective audit. So guidelines there or any support evidence for the vaccine. Then comes the drug selection. So what's the antibiotic spectrum? The spectrum of antibiotics appropriate for the suspected organism, the suspected infections, local resistant pattern, allergy history, and treatment guidelines. So this has to be analyzed. Then comes the dose and route of antibiotic. Was the dose adjusted for age, weight, kidney or liver function, and infection severity? The most suitable oral intravenous route chosen. Then comes the duration. Was the length of treatment is evidence-based and repeat at the right time and shortened or stopped when the clinical improvement or culturism supported de-escalation. So this thing should be analyzed. Then comes the timing, right? What time the antibiotic was started. That timing is also important because in some cases of septic shock or sepsis, you have to start the antibiotic within 1 or 2 hours, right? So that's important. The timing the work started when initiated promptly when indicated or delayed until the appropriate clinical and microbial information was available. Next is the documentation. So all these things has to be documented. Where cultures, sensitivity results, indications, and treatment decision clearly recorded, so that the rationale for therapy could be audited and followed over time. So, data collection is over. Now, we have analyzed the data collected and we are going to evaluate based on the analysis and evaluation. Now we have to come for the audit findings. So what is this audit finding? So there are some positive audit findings we present, or in some places where these corrections are there. So this one has to be found out, and based on this can give the recommendations. Positive findings. So in positive findings, the percentage of appropriate prescriptions overall by the department, then guided adherence rates for the first line antibiotics, dose and duration, then high performing departments with the time to de-escalation and a good documentation. Then examples of effective stewardship such as correct prophylaxis, timing and culture guided therapy. So these are the positive findings which can know down, which can be communicated to the clinicians. Then where are the areas it needs improvement? There are some areas for improvement that we can highlight to the clinicians so that they will implement for the clinicians to know. So common errors such as incorrect empirical choice or unnecessary broad spectrum use. So if there is any error in this, then we can just tell them to correct this one or improve in these areas. Then culture compliance gaps, including missed specimens before antibiotic start. So you can advise the clinician, they have not taken any culture sensitivity before starting the antibiotic, then we can advise them to take the culture sensitivity before starting the antibiotic. Then restricted antibiotic overdose prolonged the course and delayed reviewed after 48 to 72 hours. Okay, so first review will be after 48 to 72 hours of starting the antibiotic. Right? After doing this first review after 48 to 70 hours, again you have to re-audit, or again you have to review after 4 days, then and 7 days. So it is a continuous process, not only after 48 to 70 hours. First audit will be after 48 to 70 hours, 70 hours, then next audit will be after 4 days, then after 7 days. So what is why you have to do after 4 days or 7 days? Because after when you do the audit after 4 days or 7 days, that time the antibiotics the culture results will have come, other results will be there. So based on the other results, you can give the recommendations. So then aim or trends lead to repeated use of same agents or inconsistent escalation and de-escalation. In some cases, that they use it repeatedly, they use the same antibiotic. So they can just tell them why you're using the same antibiotic due to the resistance, so that they can change the antibiotic and they will avoid using the repeat same antibiotic. The examples where documentation was incomplete, make the decision in order to review. Then, what are the outcomes that are expected? So, based on this, we can give the expected outputs. So here this it should be evidence-based recommendations with clear priority levels. Then department-wise performance data and trend comparisons over time. Then actionable improvement opportunities tied to specific scheduled behaviors. Then set visuals or summaries for leadership, office and clinician teams can be given. Then the second point is constructively to the clinician. How you can present this findings to the clinicians. So deep with shared goals, that is better patient outcomes, safer prescription, less restriction, less resistance. The framework results are system improvement. It's a system improvement, so not individual term. It's for the system improvement. So never individual thing. Okay. Then use neutral language and anonymous examples when discuss errors. Then highlight what is working well before reading the gaps, and every concerns with a practical next step or support stories. So now comes the decision point. What is the stage? Whether the antibiotic used is appropriate or not. So based on this, we can decide what to do. So when it is appropriate, when we can say it is appropriate, if it is this is appropriate, the antibiotic started is appropriate. When we can say it is appropriate, when it meets the local guidelines, indication, dose, good and duration criteria, then we can say it's antibiotic started appropriately. Then consultation supports the correct antibiotic choice. The patient is improving clinically with no new safety concerns. The renal hepatic dosing and allergy reviews are appropriate. No missed opportunities for de-escalation, IV to oral switch or stoppage of treatment. Next comes if it is not appropriate, then what you have to do. So we can do some corrective action, do some corrective actions. When it's not appropriate, means indication is unclear, then unsupported or not documented, the drug of choice is too broad, too narrow or mismatched to culture. Then those intervals, route or duration is not aligned with renal functions or guided recommendations. Patient has a documented allergy, interactions, toxicity or avoidable duplicate coverage. Then no reassessment has been done after culture results, clinical change or completion of intended use. So here I said, that's why I said reassessment should be there. That's what that means audit should be done after 4 days and 7 days to serial culture reports. Then opportunities exist to stop therapy, de-escalation, switch on the IV to oral antibiotic or narrow based on source control, but it's been not been done. So these are the things to say is not appropriate, and in this conditions, your actions are required. Corrective actions are required. Now comes the feedback and communication. So based on this, you have to give our feedback to the clinicians. So how we can communicate our feedback to the clinicians? There are many ways to give our feedback. That is by orally you can give the feedback, right? One to one, you can give the feedback, or you can give the feedback by messaging, or you can give documentation, you can document and give the document, the support can be given. So these are the ways to communicate with the clinicians. So for the clinical team, the timing is very, very important because what time you have to communicate, right? What time you have to communicate? As soon as possible. You have to communicate as soon as possible. You have to communicate your findings to the clinicians so that they can take the necessary action can be taken. So timing is very important. Deliver the feedback as soon as possible after the review, ideally within the same week or at the end of the clinical cycle. So it's better after the end of the clinical cycle, you have to give the feedback to them. What is the format you can give? Use one-to-one discussion, then secure messaging or brief case review meeting, supported by patient level data. Then what are the key messages? Focus on escaping performance, missed opportunities for de-escalation and patient-specific alterations. And what are the goals for this? Reinforce clinical judgment while linking individual decisions of the clinicians to broad stewardship standards. Now comes the implementation. So based on this, we should have an action plan, and this action plan has to be implemented. So implementation of the action plan. First thing is the update antibiotic policies and formularies within clear first line, second line, and reserve agent guidelines. Then conduct targeted educational programs for physicians, pharmacists, nurses, and residents using case-based examples. Then introduce restrictions or pre-authorization systems for broad-spectrum antibiotics and high-cost agents. Then establish IV to oral switch protocols with the daily review criteria and established pathways. Then use local antibiograms, clinical pathways, and order sets to support prescription at the point of care. Then asset stewardship champions on each ward to reinforce adherence and answer questions to in real time. So these are implementation we can do. Then comes the re-audit and monitor. So that's period all audits should be re-audited with a time frame, with time duration, then it has to be monitored. So first thing is a repeat audit at the different intervals such as 3 months after implementation. So based on the recommendation, you want to implement the action plan. So after implementation of the action plan, you have to do the re-audit after 3 months. Then every 6 to 12 months, again you have to re-audit. Then compare new results against baseline and prior cycle to identify sustained improvements or regression. Track the guidelines adherence, days of therapy, antimicrobial consumption, resistant rates, length of stay, readmission rates, adverse drug events, and cost savings. Then measure success. So this antibiotic audit should be success should be measured. How we can measure this antibiotic success? So measure success using clear targets such as higher compliance, fewer inappropriate prescriptions, reduce IV antibiotic days, and improve clinical outcomes. By which you can measure the success of this antibiotic audit. Then monitor process metrics. So you have to monitor the process metrics and outcome metrics together so that the better prescription also translates into better patient care. So both audits should be done, like process metrics and outcome metrics audits should be done together. Then sustained improvements with feedback dashboards, precious training, updated protocols, and regular leadership review. So this completes how to conduct antibiotics. So we know what is antibiotic cycle, why antibiotic audit, and why need antibiotic audit. Now we are discussing about how to conduct the antibiotic audit. So this antibiotic audit can be, as I explained, this can be conducted by defining the goals as objectives and the scope, then collect the data, then analyze and evaluate, then audit findings, then give the feedback to the clinicians, then implement the action plan, then re-audit and monitor. So this completes the method of antibiotic audit. So in our hospital, we regularly do the antibiotic audit. For the antibiotic audit, so our EMS team, antimicrobial steward team, they go for the antibiotic audit team, they collect the data, right, with the antibiotic audit forms. Then after collecting the data, they will just discuss, analyze, and they will give the feedback. So this is one of the real-time antibiotic audit which is conducted the people, pediatric intensive care units. So it's a real-time audit. So we have given all the inputs at the same time of at the time of the audit itself. So they have implemented all our recommendations. So this is the department antibiotic audit review. Every month we used to conduct the antibiotic audit review every month. So to conclude, antibiotic audit is one of the effective and gold standard intervention of the antibiotic stewardship program. Without this antibiotic audit, antibiotic stewardship is not complete. Now I just want to tell the 5 take-home messages. One is ensure appropriate antibiotic selection based on clinical indications and culture sensitive results. Then optimize dose, route, and duration to maximize efficacy and minimize toxicity. Promote de-escalation and timely review of therapy once microbial data are available. Then reduce antimicrobial resistance by avoiding unnecessary or inappropriate antibiotic use, and improve patients' outcomes and reduce healthcare costs through antimicrobial stewardship and evidence-based prescription. By following this all, this antibiotic audit strengthens the antimicrobial stewardship and it safeguards the patients from the infections and it reduces the antimicrobial AMI dose. Thank you.
Very long. Thank you, Dr. Vikwan. The presentation, you have explained clearly about the team, what has, how to conduct an AMI in detail. So as a professor of anesthesiology, I request you to conduct a audit in our PA post anesthesia intensive care unit because neglect most of the time. Yes, sir. Microbial.
Yeah, sure.
Questions from the audience?
Since there are no questions, we'll wind up the session. Thank you, sir.
Thank you, sir, for this wonderful session. I request Professor Dr. Senthil Kumar sir and Dr. Karthikeyan Sridevi ma'am to felicitate Dr. Ravi Kumar sir. Thank you, sir. Thank you, ma'am. I request Dr. Kannan sir, Assistant Professor of Microbiology, GKMC, to felicitate the chairpersons, Dr. Senthil Kumar sir and Dr. Karthikeyan Sridevi ma'am. Thank you, sir. Thank you, ma'am. Thank you all for your wonderful attention. Now we shall break for lunch break and kindly assemble at 2 p.m. Kindly assemble at 2 p.m. Lunch will be provided at second floor in pharmacology practical hall.
They have explained clearly about the need, what is, and how to conduct a Antimicrobial in detail. So, as a professor of anesthesia therapy, I request you to conduct a audit in our PA, post anesthesia intensive care unit, because neglect and most of the time. Yes, sir, microbial. Yeah, sure.
Questions from the audience? Back to me.
Test, check, test, check. Check, check, test, check.
Good afternoon, everyone. Welcome you all after the lunch break. Let's continue the session with panel discussion titled Precision Prescribing Microbiology Meets Antibiotics, a case. It's my privilege to introduce our esteemed panelists, Dr. M. Sharmila ma'am, Professor, Department of Medicine, GKFC, Dr. M. Parimala ma'am, Professor, Head of Department of Surgery, GKFC, Dr. R. Sir, Professor, Department of Pediatrics, GKFC, Dr. Tyagaraja Ravindra sir, Professor and Head of Department of Microbiology, GKMC, Dr. A.V.M. Balaji sir, Associate Professor of Microbiology, GKMC. Let's welcome our panelists now. Guiding today's discussion by our respected moderators,
Dr. Kalpana Raj ma'am, Dr. Amuda ma'am, Dr. Kapil sir, Dr. Lavanya ma'am, Senior Assistant Professors, Department of Microbiology, GKMC. Without further delay, now I invite Dr. Lavanya ma'am to take over the session and begin the case-based discussion.
Going right away with the first case study. A 11-month-old male infant is admitted to the pediatric intensive care unit with high-grade fever for 3 days, excessive crying and irritability for 2 days, refusal of feeds and poor intake for the past 48 hours. There is multiple episodes of vomiting for 12 to 24 hours. There was a history that the infant had received oral ceftriaxone and paracetamol from a local practitioner without any improvement. Birth history is a full-term normal delivery and the infant weighed 2.9 kg at birth. Development is appropriate for age and immunizations are up to date for the age. On examination, the baby was febrile with a 39.5 degrees centigrade temperature. Heart rate was 156 per minute, respiratory rate 42 per minute, and the BP was 86/54. On neurological examination, the baby was highly irritable and there was neck stiffness and there was a bulging anterior fontanelle with no focal neurological deficits. Initial management, lumbar puncture and blood investigations were taken. WBC showed a marked increase with 21,500 per cubic millimeter with a predominance of neutrophils. The platelets and hemoglobin appeared normal and the CRP was increased with 128 milligram per liter. The CSF showed that the CSF analysis revealed that the CSF was turbid with a cell count of 720 cells and a differential count of 88% of polymorpho neutrophils. The protein was increased 135 milligram per deciliter and the glucose was 18 milligram per deciliter. Gram stain from the CSF showed no pustules and organisms. The provisional diagnosis was pyogenic bacterial meningitis. Now we go on to an audience poll.
I'd like you to scan this and
only the online. People online and offline who have registered. Online participants, please do participate in the poll. Scan the QR code. Online. Have you scanned the QR code? Okay, so these are the poll results. So most of them have poll for ceftriaxone and vancomycin as the empirical treatment of choice. So the question was, what was the empirical treatment of choice for this case?
Good afternoon, all the respected professors, all the postgraduates.
So the patient was. The child was started with the treatment of empiric ceftriaxone and vancomycin. Now, sir, I would like to ask you, is the empiric treatment of vancomycin and ceftriaxone justified in this case?
Yes, this case, this acute presentation, 11 months old child. So partially immunized, not completely immunized, partially immunized, because we have to complete the booster dose also. So the risk factor is young infant, partially immunized, high grade fever, and vomiting, inconsolable cry, irritability, bulging pantanal. So all these clinical manifestations more in favor of suspecting bacterial meningitis. So in these conditions, life-threatening condition, we have to choose some antibiotics. Already the child was put on oral cephalosporin and antibiotic paracetamol. So why we have to choose antibiotic in this case? Why not we have to wait? Because the clinical proof saying that it is a case of bacterial meningitis. So as per the guidelines means there are a lot of studies would have been done, and based on that, the forum has decided the following antibiotics should be given as an empirical measure to for risk versus benefit ratio. We have to start here. That is why empirical treatment is advised. That is why, based on the studies, as per the Nelson textbook for pediatrics, vancomycin and ceftriaxone is the first line drug has to be started in this case as an empirical therapy.
What is the role of?
And we need not go one more thing, madam. We need not go back to your neutrophils and all that. That will not decide that whether there is a particular antibiotic is in favor of this kind, this elevation of neutrophils. And neutrophil is an acute phase reaction. So because of the fever, because of the systemic inflammatory response, the 70% of neutrophils are there. So that doesn't mean that because of the elevation of neutrophil, we have to choose this antibiotic.
And what is the role of dual combinations, sir? Because in the poll also some people have said like cefotaxime is in a.
Yes, any antibiotic therapy which we are selecting based on the geography and prevalence of particular community, based on that we are choosing the antibiotic. So why we have chosen this dual combination? So common cause in this age group is the pneumococcal organisms are very common. So that is why the ceftriaxone and the vancomycin, because most of the pneumococcal response have a good susceptibility to ceftriaxone. Some resistant cephalosporin resistant pneumococci also there. So to give the best response to prevent the morbidity as well as the mortality. Morbidity in the sense hearing loss and the neurological deficit to the baby, young baby. So and also death. To prevent that, we have to give the dual combination.
Can we use meropenem, sir?
Yes, we can use, but which is mainly suitable for a second line, mainly suitable for ESBL organisms. Even though it is susceptible to your pneumococci, the meropenem is the second line of choice because we have excellent penetration antibiotic like ceftriaxone is there. So though your meropenem is good enough to handle that situation, the first line we can choose the ceftriaxone.
Thank you, sir. Dr. Balaji, sir, anything to add on?
Sir already said all the points. So any disease at the age group is very, very important. So sir already said less than 1 month is a common. In neonates who have meningitis means they usually from the vaginal flora. So E. coli, is a state of group, is the common stages. So from age 1 month to 2 years, which the commonest 3 organisms. Already sir said Streptococcus pneumoniae, then Haemophilus influenzae, then your Neisseria meningitis. If you put the ceftriaxone alone, it will cover all the 3 organisms: Streptococcus pneumoniae, Haemophilus influenza, as well as your Neisseria meningitis. But some 30% of Streptococcus pneumoniae are non-susceptible to both penicillin as well as cephalosporin. So during empirical therapy, meningitis is a very serious infection, so I have to act quickly. So meningitis is the only condition. Blood sample, respective sample has to be cannot be taken before antibiotic. So all other infections, you have to take respective sample like blood, urine, then only you have to start antibiotic. So meningitis is the only condition we have to start antibiotic at the earliest, if the possible to take CSF is late. So 30% of Streptococcus pneumoniae, ceftriaxone doesn't cover. So we have to cover all the three organisms with the vancomycin as ceftriaxone. So sir already said meropenem is the second line drug. It will also cover if ceftriaxone susceptible Streptococcus pneumoniae. Meropenem also will cover the ice.
Thank you, sir. So this is a reference for this. Just take a second to have a look at it. So in case of penicillin resistant, as per Harrison, ceftriaxone plus vancomycin is the empirical drug of choice. Now, after the culture reports have arrived, the CSF culture showed no growth, but the blood culture, Streptococcus pneumoniae, was isolated. The AST data was penicillin 0.12 and was susceptible. Ceftriaxone showed an MIC of 1, susceptible. Vancomycin 0.5, susceptible. So this is the MIC result taken from the blood isolate where the Streptococcus pneumonia was grown. Now we are going to do a review of the AMSP after 48 to 72 hours after we receive the blood culture. There is a small poll for that. Kindly scan the QR code. Everyone online, kindly scan the QR code. Okay, we've got the poll results. A majority have said to continue with ceftriaxone and vancomycin. And some are saying to continue ceftriaxone alone. So in this case, now the question to the panelists, now after this AST report, since all the drugs were susceptible, penicillin is susceptible, ceftriaxone and vancomycin, what do we do next? Should vancomycin be stopped after the culture results, or should therapy of ceftriaxone be de-escalated?
As far as culture is concerned, the one issue it is only showing sensitive to ceftriaxone. But we have started empirically vancomycin also. The child would have got that both the drugs for a couple of days. After that, only we are taking CSF. That CSF report was negative. But we do not know whether the organism was responded to vancomycin or ceftriaxone. So in such condition, we have go with the clinical manifestation as well as the risk which you are expecting to the child. So technically speaking, we can stop vancomycin, but being considering the disease as well as the we have got the results little later, CSF results little later after starting this dual antibiotic. So better as a pediatrician, I would go with both the drugs as a continuous therapy.
Okay, now the next question, sir, to you, sir. The CSF has shown no growth, but the blood has grown Streptococcus pneumoniae. Can blood cultures guide a targeted therapy when CSF remains sterile?
This is again we have to observe carefully because blood cultures it is grown Streptococcus pneumoniae, but the CSF was sterile, no growth was there, and blood culture MICs can't be reflected for CSF MICs, and based on that we can't deal a case of bacterial meningitis. So breakpoints given in the CLSA we have to refer and then come back for the treatment.
Madam, as sir has said, it is very difficult to do the culture in the blood. Mostly it will be only 30% positive. The other thing we can do is in the CSF, you can do a PCR for the various organisms. Just I just want to add on to the first point. The pediatric sir is in adults about 55 years and sometimes less than 3 months because of Listeria monocytogenes also being possible. We are ampicillin even in the empirical therapy. That I wanted to say. And even in streptococcal pneumonia, they say ceftriaxone meropenem is superior to ceftriaxone action, but definitely it's inferior to vancomycin. So that's why we need to combine both.
Thank you, madam. Sir, Balaji sir, you want to add? Okay, so this is the MIC from the blood. So can you just
if you observe the MIC from the blood, you will see that penicillin is resistant. Ceftriaxone is acceptable and vancomycin is acceptable. But this MICs are for the streptopneumonia which is grown in the blood. And you see the breakpoints of the MICs in for CSF as given with the CLSA, but we can focus. You can see a higher breakpoints in CLS. Based on this blood, you can't treat for the CSF. And this case, the bacterial meningitis. It's not a sepsis case, so we have to adhere to the CLSA breakpoints given for CSF. So you can focus on the meningitis and non-meningitis. And in meningitis for penicillin, you can see the CSF, it has MIC has to be less than 0.06. So if you take this as the breakpoint, penicillin can't be given as for a treatment for case which is bacterial meningitis. Similarly, we have to work on for the ceftriaxone. So here you can see the ceftriaxone for blood or non-meningitis is less than 1. But for a meningitis case, it's less than 0.5, and our strain will be resistant for this as you look at the blood culture, but the CSF we can go for.
Thank you, sir. Balaji.
Sir said rightly. Blood culture, whether there is no growth in CSF, growth in the blood, whether it has to be taken as here. Meningitis, blood culture is positive for meningitis. Yes, we can take it. Any culture growth in the blood can be taken as a cause of meningitis because streptococcus pneumoniae comes from the lung blood through the meninges. So we have to take. So whenever this case mainly whenever you isolate your streptococcus pneumoniae in blood, you always have to report susceptibility pattern in 2 categories for 3 drugs: penicillin, ceftriaxone, and vancomycin. You have to put meningitis break, whether it is susceptible or resistant, non-meningitis break, whether it is susceptible of resistant. So then only the concerned physician, treating physician or pediatrician able to know whether we have to go for, because previous slide please, previous slide. Previous. Yeah, you look at the MIC of our ice rate, it is around 0.12, very lowest MIC. But even though it is very lowest MIC, if you interpret the breakpoint, it is acceptable. But the breakpoint for interpretation of meningitis ice rate, it is resistant. So, if you look at the MIC, it is very low. But even though it is resistant for the meningeal portion, but ceftriaxone just one, but blood interpretation, that is non-meningeal, it is susceptible, but meningeal breakpoint, it is intermediate. So whenever Streptococcus pneumoniae isolated from the blood, you have to report both non-meningitis as well as meningitis breakpoint.
Thank you, sir.
Ceftriaxone we can take it as intermediate or acceptable dose dependent. If there is a safety margin, we can increase the dose.
Thank you, sir. This is a reference from Mandels. So in our case, ceftriaxone and cefotaxime had an MIC of 1. So greater than or equal to 1. The treatment of choice is vancomycin plus ceftriaxone. So the take-home messages always start smart. So in this case, they started on the correct empirical therapy. So ceftriaxone and vancomycin was started, and cultures were taken before starting the antibiotics, before the empirical treatment. And the most important take-home message is always apply the correct breakpoints. So meningitis specific CLSI breakpoints must be applied. Never assume systemic breakpoints suffice. So it is always good to have a communication with the clinicians, so we know that what case we're dealing with. De-escalate judicially. Only narrow therapy when mycological evidence explicitly supports it, and optimize the duration. Thank
you. Please. Yeah. This is the questions for the offline as well as online viewers. You look at if it is a Staphylococcus aureus, if it is methicillin sensitive, as per Mandel's guidelines, either ampicillin or oxacillin. If it is methicillin resistant, only vancomycin was added. But if you look at the Streptococcus pneumoniae for meningeal isolate, if it is penicillin susceptible, penicillin resistant, but ceftriaxone susceptible, ceftriaxone alone. But if it is penicillin as well as ceftriaxone resistant, they put vancomycin plus ceftriaxone. Why? For Streptococcus pneumoniae, third generation cephalosporin was added to vancomycin, but not in the case of Staphylococcus aureus. One question. Second one, can we give vancomycin to the MSSA patients? Can we give? So these are the two questions for the offline as well as online viewers.
One last question, sir. Sir, how long will you continue the treatment for this child?
It is as per the guidelines, we have to go for 21 days.
And if the baby becomes hemodynamically stable, like would you switch over to any oral?
No, ma'am, because being 11 months old child, so we want know the pharmacodynamics and kinetics of the oral things, with the bioavailability also. So better, by again, this is beneficial, we have to go for both of them. Ceftriaxone as well as vancomycin, but during the course of treatment, we have to monitor the renal function test.
Thank you, sir. Thank you, madam.
My take-home message for the postgraduates for the clinical perspective. So whenever you ask for culture report, you see the MIC as well as the breakpoint. So that will guide you to choose the antibiotic. Thank you. Thanks a lot.
Thank you, ma'am. Thank you.
Now I request Dr. Tyagaraja Ravindan sir to felicitate Honorary sir. Thank you, sir. Now I invite Dr. Amuda ma'am to present the case-based discussion.
Good afternoon, sir, ma'am, and everyone. My case for discussion is a 58-year-old female. A 58-year-old female who is known diabetic and hypertensive presents to the emergency department with complaints of high-grade fever, chills, nausea, vomiting, dysuria, urgency, and back pain. Upon physical examination, costovertebral angle tenderness is noted. Provisional diagnosis, probable diagnosis will be it will be a complicated urinary tract infection, pyelonephritis, as you all will agree, ma'am. And first, what can be the empirical management? Just I wanted to ask, what can be the empirical management for this case? What you are doing in your department, ma'am?
For urinary tract infection, we classify it if we go for a syndromic approach. So we have asymptomatic bacteria where it is incidentally found without any symptoms. Next would be cystitis. Cystitis, you don't have the typical fever, but you get a lower abdominal pain with hesitancy and urine frequency and so on. Next would be pyelonephritis with the typical flank pain and renal tenderness and other systemic features also. And then you have prostate. You should think of prostatitis, especially in male, coming to you with rectal UTI. And finally, even though pyelonephritis here has been classified as complicated UTI, a word about complicated UTI is that infection is not only in the urinary tract. It can lead on to a systemic manifestation in the form of urosepsis, or you have any anatomical or physiological deformities, like say for example a vesicular reflex or a renal stone disease. All this will come. Even your foreign body will be catheter, that is your potty. All this will be complicated UTI. One point to say this is complicated is like if you have factors which delay the treatment, delay the recovery of the UTI, like diabetic, elderly, immunosuppressed status, then again it becomes complicated UTI. Generally, the common organisms, be it the regular UTI or the complicated UTI, 70 to 90% is polite, followed by other gram-negative like your Proteus. In complicated, you might have other Acinetobacter, others, even fungal infection can be present, Pseudomonas can be present. So, we need to do the urine culture at the earliest and then we start the empirical antibiotics. Having said the empirical antibiotics.
Actually, in your department, ma'am, how frequently you are getting, ma'am, pyelonephritis?
Yeah, almost every patient we get 2 or 3 cases, especially in elderly females, diabetic patient we regularly get. So take pyelonephritis with the clinical picture that you have shown. So we would like to go for a beta-lactam and theta-lactam inhibitors, the piperacillin and tazobactam, and then we will do actually ideally speaking, temperature should be ceftriaxone 1 gram daily. Then you take the sample, urine culture and blood culture, then you decide on the antibiotics. So if the patient is not a diabetic and no other risk factors, I would start with ceftriaxone 1 gram daily as per Harrison. Since the patient is a diabetic, so I would like to escalate to a beta-lactam and beta-lactam inhibitors like piperacillin, tazobactam. And then wait for the culture.
So pyelonephritis cases so frequent though. So we need to really enlighten the patients and this diabetic group about this, because since urosepsis cases are rising now.
number of cases, when they are having, when the symptoms start, they have to just approach. Otherwise, it's going to worsen. That thing is there. Okay, ma'am. So, for that patient, a complete blood count was done. It showed leukocytosis. Urine analysis shows positive for leukocyte esterase. Abundant pus cells were present. Plenty of gram-negative vessel AC. And urine albumin 1+, urine sugar 3+. Prophylaxis pyelonephritis. Urine culture showed growth of Escherichia coli more than 10.5 coliforming unit per ml. It was an ESPL. Blood culture was also sent simultaneously and it showed growth of Escherichia coli. Actually, for this case, the antibiotic sensitivity report was as follows. Here, since all these third generation cephalosporin was resistant, so it was an ESPL. Then other sensitive antibiotics were PTZ, MRP, gentamicin, nitrofurantoin, phosphomycin, and cotrimoxazole. Actually, for this patient, meropenem was started. Meropenem was started because there was piperacillin tazobactam, though it was sensitive, meropenem was started. I wanted to put a question for the panelists whether why meropenem was chosen, even though PTZ was sensitive for this case.
I think quickly, there is a controversy. Actually, carbapenem is the best drugs in terms of imipenem, celestine, or meropenem, or etapenem. These are the best drugs. But to prevent the carbapenem resistance in future, we go with the piperacillin tazobactam based on the clinical symptoms. That doesn't respond. If the fever is persistent, then we would like to escalate. But there are some studies to say previously that this piperacillin tazobactam had the mortality, increased mortality. But that was in 2018. The further studies done does not show any difference in mortality between piptas or the carbapenems. So carbapenems will be one of the best drugs. We don't want to develop resistance. So in the common practice, we do start with piperacillin tazobactam.
We want to have a carbapenem sparing thing.
Except in shock. When patient is in shock, it's better to avoid piperacillin tazobactam. We go for the carbapenems.
Ma'am, how are the results, ma'am, in your department if you are starting PTZ? And how are the results?
The results are very good, madam. Actually,
provided blood culture is negative, ma'am. Negative, but and the urine culture are positive. Like
yes, madam. The response is very good with the tazobactam and the duration of post for 2 weeks.
2 weeks. Okay. So you want to spare carbapenems? Okay. Okay. In any case, you want to choose meropenem, leaving this is that any cases you want to choose directly carbapenems.
Generally, it depends upon the patient. If the patient is having a neutropenic sepsis, and if the patient is having some other immunocompromised status with nitroviruses, then we start with the carbapenem. So,
carbapenem here, I think here only meropenem we have.
Since the patient is actually, I think it's best to be ertapenem, where we need, because of its long half-life, we only give a single dose. So it is has lesser side effects. That would be the ideal drug. But ours, in our center, we have only meropenem.
When I was seeing this case, then I was just going through that Merino trial, and I thought I'll get some insight from our panelists. College sir, if you want to give an insight into the Merino trial, it will be known to everyone, online participants also. But just as you can, if you want, you can give an insight, sir, and also about the trial.
Yes, ma'am. Before going for the Merino trial,
for national ICMR guidelines for empirical treatment. Almost 5 editions are there. Recently, 2026 also, 1 edition was there. Tamil Nadu also developed guidance. The last edition also, at least some 2 to 3 months back. If you look at the ICMR guidelines, so what are the indication for carbamazepine as a empirical therapy? Almost 5 indications are commonly there in ICMR national guidance for anti-infective therapy. The first one is complicated intra-abdominal infection. As Madam already clearly says, any sepsis with septic shock, any sepsis or sepsis with the septic shock, pneumonia, sepsis, puerperal sepsis, anything we can go for carbamazepine therapy. Then any pyelonephritis is the one of the indication given as per our national guidance. Then neonatal meningitis, carbamazepine is directly indicated. Neonatal meningitis. So sepsis, neonatal meningitis, complicated intra-abdominal infections. Then any pyelonephritis. So these are the empirical indications for carbamazepine therapy. Why?
How long, sir? How?
Pyelonephritis, it is 40 to 21 days or 10 to 50 days as per the patient's requirement. Ma'am also said they are used with the
Ma'am, it was
pictures.
ma'am 10 to 14 days, ma'am. You want to take
So again, as per medical trial, there are 3 points given in the medical trial. One is the antibiotic, that is colony forming unit. So if the colony forming unit of the organism is high, the piperacillin action will be somewhat low. So we are having both blood cultures as well as urine cultures both showed equally. So most probably colony forming unit will be very high. Second one is the OXA1 enzyme. So the ESPR producing organism. So as per our national as well as international guidelines, OXA1 is the enzyme usually commonly associated with the ESPR. So what is the significance of the OXA1? So OXA1 usually resistant to the beta-lactam inhibitor combinations. So whether it is flavulanic acid or tazobactam or sulbactam, usually resistant to this OXA1 enzyme. So we don't know with the cultural sensitivity pattern, it may shows because of the expressibility of the OXA1 is very low. We cannot be able to detect whether the cancer actually susceptible or not. So these are the things given in the medical trial. But as per a lot of ID physicians, as already ma'am said, mild to moderate infections, beta-lactam inhibitor combinations like piptas is good. Severe infections, we need to go for carbamazepine.
Depends on the regional antibiogram, and since madam's experience, she says there is result, but for severe cases they are using carbamazepine. But mostly they want to spare a carbamazepine for future. That is
what
ma'am.
this what sensitive.
Yes, okay, ma'am.
And also, there is an increase in incidence of neurosepsis, and particularly elderly age group and comorbid diabetes is there. And as Madam told, the meropenem is justified in this particular case.
Particular comorbid cases, we can use.
Meropenem is justified because of the rise in neurosepsis and comorbidity. But
So-
the trial has been done. We don't know the participants of the trial and age groups and other conditions taken. So we have to always work from case to case and then
It's a case-based approach. Sir, and also the nitrofurantoin phosphomycin, they are sensitive, sir. Will there be any use in this case?
In cases of complicated UTI, we are not going in for nitrofurantoin or phosphomycin. Only for the cystitis cases we are using.
Concentration is not good for nitrofurantoin, other drugs like phosphomycin and etc. The tissue penetration is not good, so it doesn't work in pyelonephritis. Only for cystitis, that would be course of the treatment is only 5 days.
Okay, ma'am, okay, ma'am. So, usually patients also may ask, will repeat culture should need to be done Usually, even we forget, patient will come and ask, should I give the urine culture again? In that case, what will be the advice?
They are asymptomatic after the treatment course, then we can observe and need not go for a repeat culture. If the symptoms persist, then we need to go for a repeat culture.
To be get a repeat urine culture, they have to stay for 2 more days, and it's a waste of. So once they are getting treated and they're getting ready to go home, we are sending.
Patients usually ask for a whether we need to repeat a culture, and some of the clinicians also they raise a query. But if there are no symptoms, then no need for going for repeat cultures. But if there are symptoms, then we need to think about repeat culture. Before that, the simple test of urine albumin sugar deposit, the deposit will show persons. Those tests can be done, and then we can think of color.
And as OP, we can ask the patient to come for review. No need to keep the patient for so many days IP and occupy the bed.
That's true. And our basics will only work complete blood count and urine pustules. If they are complete blood count, leukocytes are raised and pustules are there, then we can think of culture.
Now, any opinion from you? Okay. Just it is just go through the
No, sir, actually, very nice, very, very, we are seeing the color of this space. So last, both are sensitive to test, as a matter with the neonatal one to choose. Actually, as madam, no, we are straight away starting with test only. But in the patient, with the CKD patient, suppose most of the CKD patients have no substance. That time we have to reduce the test procedure. 4.5 gram TDS will not be able to give PD or OD will be adjusted. Rather than
because depending upon the glomerular filtration rate, it will
so in the case of CKD patient, both are you can straight away start more than as part of the patient specific septic shock, directly you can start lower tests, then still can start.
A fast, just a glance of the book released by DME and DME Tamil Nadu. It classifies UTI into asymptomatic, uncomplicated, and complicated. Pyelonephritis means complicated. This is the drug of choice for empirical treatment. Acute cystitis, nitrofurantoin, and phosphomycin. Alternative choice will be Cotrimoxin. Complicated UTA, Ertapenem is the drug of choice, and depending upon the availability, here available is meropenem. So here in medicine they are using meropenem. These are the other. Yes, thank you, ma'am. Thank you, sir.
Thank you, ma'am. Thank you, sir. Now I invite Dr. Kalpana Raj ma'am to present the case-based discussion. Good afternoon to everyone present in the hall. So my case is about a skin and soft tissue infection. Any infection that is due to microbial invasion of the skin, subcutaneous tissue, fascia, and muscle that constitutes the skin and soft tissue infection. They have a wide range of clinical spectrum, starting from a simple cellulitis to rapidly progressive necrotizing fasciitis. The challenge in the diagnosis is to find out the exact extent of the infection so that we can institute appropriate antibiotic therapy. Here, our case is a 25-year-old male. He presents to the emergency department with worsening pain, redness, and swelling in his right hand. He had an injury while chopping wood 3 days ago and had a splinter foreign body on the palmar aspect of the right hand in the thigh.
So the hand swelling and pain had worsened and pain had spread through the forearm and felt up to the armpit. He had chills and fever for the past 2 days. He has history of hepatitis C infection. He is a smoker, alcoholic, and there is also a history of IV drug abuse. Coming to the allergy for drugs, he is allergic to penicillin and sulfur. So on local examination, the right hand was grossly swollen with injury wound over the base of the thumb and it was covered with scab. Erythema was present over the swelling and movement of the fingers was mildly impaired to edema. Hand was tender to palpation and brain was present on active finger movements, flexion, extension, etc. Fingertip circulation was good and sensation was present over the fingers. So MRI of the right hand showed abscess in the thenar region and pus web space extending to the dorsum, possible tenosynovitis of the thumb and index finger flexure sheets, wrist joint and finger joints were normal. There was a slight increase in WBC count, 13,500 and CF was also mildly increased, 14.5 milligram per liter. Liver function and renal function tests were within normal limits. So the provisional diagnosis is abscess right hand with cellulitis. And what is the intervention required to ensure optimal management of the patient? Or to surgery part.
As per history, the patients having a following chopping of the wound, patient developed swelling and pain and restriction of the movements and blood count. The total count was 13,500 in February. So all the points favored for the abscess. And you also, I think the MRI is not necessary. Clinical examples is enough.
Okay.
Please, they are more fond of doing dispassionate, ideological and all these investigations. Moreover, the clinical diagnosis is enough. So wherever is the victim, the root is wherever the abscess, the treatment is incision and drainage. So before doing incision and drainage, we have to ensure this is an abscess or anything else. Because the abscess, the cardinal sign, we have to look for the abscess fluctuation along with the prodromal symptoms. So, because of fluctuation, the swelling may be big, the consistency may be soft. It may be the vascular swelling. So before doing incision and drainage, we have to ensure this is an incision abscess. Okay. So the drainage treatment for the abscess anywhere is incision and drainage. Okay. And patients here having more of edema and everything, I think ENT alone is enough. If there's anything is more than that, we have to do fascia. Okay.
So next also for you, ma'am. What are the precautions to be taken in HCV seropositive patients before the surgical procedure? Here incision and drainage.
So patient is already is a known case of hepatitis C. Whatever, whether the patient is known or unknown, and wherever we are doing is a minor or major procedure, we have to always adapt universal precautions. We have to protect ourselves and our patient also and also the society. Necessarily, we don't want to we have to adopt all the precautions for the universal precaution for the HCV patients. Okay.
Yes, madam, as madam told, any case is potentially infectious, we have to take it that in that way and adopt the universal precautions, and now they are calling it as standard precautions. Particularly the personal protective equipment should be donned and then we can do the procedures. Gloves is must and all the other PPE is also to be worn and then the procedures can be done. And appropriately the biomedical waste has to be disposed of as per the norms. Thanks.
Thank you, sir. Thank you, ma'am. So blood sample was sent for aerobic and anaerobic culture. Blood culture was also taken for the patient. And patient was taken up for incision and drainage after taking the standard precautions. IND of the abscess was done under anesthesia. Pus and infected tissue was sent for routine bacterial culture and sensitivity in a sterile container. Request for gram stain, acid pus stain and fungal stain was also given. Dressings were continued post-operatively. So what is the empirical antibiotic recommended for this patient? Balaji, sir.
Cellulitis and all skin and soft tissue infection, common organism with Staph aureus or Streptococcus, MRSA, these are all the common organisms. But this person being a IV drug abuser and the HCD and immunosuppressed status, we do not know he might go in for a necrotizing fasciitis with multiple polymicrobial involvement, including anaerobic, we do not know. So to start with, I would recommend a third generation cephalosporin with clindamycin. Clindamycin has a cover for both MSSA, MRSA with anaerobes it covers, the basic anaerobes and backwards. So I'd like to go for that. And we need to do the tissue evidence, the pus and the surgical specimen, and wait for the report, and based on that, we need to break through.
Thank you. So this is the antibiotic guidelines from the book that was released by DMER last year. The empirical therapy guidance for skin and soft tissue. If there is cellulitis, mostly purulent infections are caused by Staphylococcus aureus and non-purulent infection by Streptococcus species. Here, whether the causative organism is Strep pyogenes or Staph aureus, they say the empirical antibiotic to be first generation cephalosporins like cefazolin or cefalexin or amoxicillin and clavulinate with or without clindamycin. For Balaji sir, this was, why do they want to add clindamycin, sir? MS. So here we have also abscess is also there. Abscess mainly it is a virulent infection caused by Staph aureus. So they say the empirical antibiotic to be linezolid or vancomycin plus ciprofloxacin. So blood culture did not show any growth at 4 days, and gram stain showed gram-positive cocci in clusters. Pus culture and sensitivity showed Staphylococcus aureus, MRSA. So this is the antibiotic sensitivity report. That is the MIC in microgram per ml. According to this, it was sensitive to linezolid was sensitive, Cotri was sensitive, tetracycline was sensitive, and vancomycin was also sensitive. And the organism was Staph aureus, MRSA. So which of the following antibiotics will be recommended for the patient?
This MRSA, we need to add on to the drugs, either vancomycin or linezolid. Both have equal side effects, I must say. Vancomycin, they get given what you call as flushing or retinal syndrome while injecting, and is not ideal in patients with renal failure. Linezolid on the other hand has myelosuppression. So the only advantage you can add on or you can step down to a oral form also linezolid in the future days. So based on the patient's dental condition, hydration, renal parameters, you would have to add on either vancomycin or linezolid.
Thank you, ma'am.
Madam, this case, clindamycin here, we have to be very cautious because it is a MRSA and there might be inducible clindamycin resistance. So it has to be used with caution.
So this question is for Balaji sir. The blood culture was positive. In our case, the blood culture was negative. Only the pus culture showed Staphylococcus MRSA. And see, we are imagining a scenario where blood culture was positive for Staph aureus MRSA. What is the significance and what will be the further line of management, sir?
So whenever there is a abscess, the Varla Staph aureus, and then blood culture also positive, you have to think for 3 areas. First one is whether there is any metastatic infection is there or not. You have to check all other vital organisms whether it is infected with the Staph aureus, starting from the spines, and other areas whether it is infected with the Staph aureus. So blood culture positive means metastatic infections, we have to take the first point. Second one is always we have to rule out any inductive endocarditis. So we have to do transesophageal echocardiogram to rule out any hesitations. So these are the two things we have to take up. Another one is if there is isolation of Staph aureus in the blood, after 3 days of treatment, we have to go for again blood culture. The counting is cleared from the blood. If there is no infective endocarditis, no metastatic infection, 2 weeks of treatment, definitely we have to give. If there is any metastatic infection or infective endocarditis, if mild valve involvement, 2 to 6 weeks of treatment is enough. If severe valve involvement, we have to go for valve replacement. Then after that, we have to send for Staphylococcus antibiotic therapy. So blood culture, Staphylococcus aureus growth. We have to check the metastatic infection, rule out infective endocarditis. No infective endocarditis, 2 weeks. If it is infective endocarditis, at least 2 to 6 weeks.
Thank you all.
MRSA blood culture, sir, that's slightly told in IV drug abuser, they need to take up infective endocarditis. We have a modified use criteria based on that, we will register. If MRSA in a native bag, the treatment should be for 6 weeks. Good time. MRSA is the big man. This is MRSA, but that native bag, that is like, it doesn't have a prosthetic bag. In an IV drug abuser with MRSA, vancomycin is given for 6 weeks.
Thank you, ma'am. I thank all the panelists and the audience for your patience. Thank you.
Just to add one more point for the use of clindamycin in empirical therapy. Clindamycin and linezolid are two antibiotics which have antitoxic effects. Not all the other antibiotics. So it is just to reduce, it can also utilize the toxin effect which is responsible for the inflammatory damages. So that is why we also include clindamycin in the empirical therapy. Thank you, sir. Thank you, ma'am. Now I invite Dr. Kannan sir to present the case-based discussion.
Good afternoon. So my case presentation is regarding the catheter aspirator unit. This is the patient details. Mr. Raja, 62 years old male, admitted on 10th May midnight. The surgical ward, the primary diagnosis of penetrating injury at heart. Emergency laparotomy was done, gastric closure done. So second and third post-operative day, patient is stable. And fourth post-operative day, patient complains of so stay present in the patient underwent emergency laparotomy. Injection ceftriaxone and metronidazole start the pre-surgical antimicrobial prophylaxis and continuing for another 4 days. Surgical antimicrobial prophylaxis. Even though it's a party case for SAP is one of the important topics, so we added this question. So for use.
As far as for minor daycare procedures, we never use surgery prophylaxis. For major surgeries like laparotomy, whether it's an elective or emergency, we are using prophylaxis. For any abdominal surgeries, elective surgeries, we are giving as a routine. Using no, the drugs are not for the
SAP is antibiotic, any choice of antibiotic? For prophylaxis, we can
use cefazolin as a for prophylaxis. Not because it's previous generation, now availability will be a question. So that case we can better. But as per the guidelines, they are telling cefazolin. But next, whichever is acting on the gram positives can be used, as madam was telling. But trivial minor cases, we need not go for the prophylaxis. And for major cases, 1 hour before surgery, it has to be given. Then only the effect will be there. And if the surgery is prolonged in nature, above 4 hours, then the repeat dose can be given. Or if there is excess blood loss above 1.5 liters, also repeat dose can be used. Otherwise, one single dose is sufficient, and particularly for cephalosporins which are acting on the gram positive. Maybe as per the guidelines, suppose. So this is our DME the guidelines regarding the surgical antimicrobial prophylaxis. So during surgery, usually recommended is cefazolin or cefuroxime plus metronidazole, preferably 1 hour before the time of incision. So this is very important because the half-life of the drug decides the peak maximum action. So 1 hour before the surgery is very important. So in some cases they may put the antibiotic at the preferably night, and then later morning they take after 6 hours they take the case. So in that case, that surgical antimicrobial prophylaxis will not be useful. That is a important point. That's why I added this slide. And police catheter. So 4 to 4 operative days, police catheter was sorry. Mr. Percent illness. Actually, pre-operatively the police catheter was inserted for urine output monitoring. So post-operative period stable and developed fever at the regular post-operative day 4. No respiratory or wound-related symptoms. And is known diabetic for past 15 years on insulin. And no previous history of any obstructive uropathy or any recurrent urinary tract infection. So the urinary catheter insertion. So bundle care approach. Sir, please.
Whenever patient need good.
So many are thinking, many residents are thinking. So putting catheter, it's a simple procedure. Without using gloves and without any standard precaution following, it is not fault-finding, but it is usually happening because of the urgency. It is midnight they are coming, case to be taken very earliest. So in the hurry and urgency, so they are putting the catheter. So thinking that the catheter, urinary catheter is
Whatever the type may be,
it's not happening in our institution. Yes, sir. It's not happening in our.
Consent, the sterility to be maintained
Yes,
always.
yes,
So
yes.
whatever the procedure, minor, major,
So-
should be done under sterile aseptic precaution always.
Yes, sir. It's only reinforcing the importance of standard precaution. Catheter is entering a sterile area, utmost aseptic precautions to be followed, and both the
We
bundles.
follow sterile aseptic precautions and the surgery will be done in a good manner.
Yes.
The disease person will be cured, sir.
Yes.
Whatever the antibiotics for the comorbids.
Yes. So the bundle can.
So, as I already said, so always whenever you going for urinary catheter, so it is a critical item. Critical item means critical equipment as per the spalding classification. So critical item means whenever the sterile cavity touches the equipment or skin, that called as a critical item. So we have to do a utmost care when you insert urinary catheter or care equal to the cardiac catheterization. So it's one of the critical equipment. So insertion bundle, so as far as said, so aseptically, so all the sterile gloves as well as the clinic, the reactors with the sterile wraps, then lubricant. So the sugar tax people of the police catheter. So we have to clear insert it. Then we have to connect sterile with the Eurobag. The Eurobag should not put on the floor. It should be just above the level of the floor. Then the catheter should not be in a tingling mode. The catheter should be at least it should be fixed in the thigh portion to avoid dragging of the catheter with the Eurobag. The Eurobag should be tied with any rope tied between the two legs of your cot. So with the top way, we have to tie the Eurobag. So all these sterile precautions, close drainage system should be maintained. Daily maintenance also very important. So cleaning the neighbors with this sterile traps is the easiest method. Do not go for antiseptic solution to clean the meanders daily. So always check for any leak with the catheter drainage system. Eurobag should be cleared every once in 3 hours. At least we have to decant the Eurobag at least once in 3 hours. So this bundle care approach have to be followed at very cautious in equal to the cardiac crisis.
As sir rightly pointed out, it is the urinary catheter is equal to cardiac catheter. So it is coming under the critical device. So on 4th POD, fever temperature 38.8, pulse rate is 86, BP normal, and surgical wound is clean and dry. Catheter institute in the cloudy urine system examination normal. So provisionally diagnosed as catheter associated inadequate infection. The surgeon asked to send the urine sample for cultures and sensitivity and further investigation done. Removal of the police catheter done, supportive management and self-providing is encouraged. So urine sample collection in a suspected cardiac case. So actually, everyone knows how to collect, but the sample collection is usually done by the staff nurse. So repeated training and repeated reinforcing is needed. So it has to be collected meticulously and preferably before giving antibiotics. But if there are the patient is on antibiotics, can be stopped for a day and then collected, or in the tough period we have to collect. And in this case, it is the indwelling catheter. If there is a catheter port, we have to aseptically clean the port opening and we can collect the urine sample. Definitely not from the bag. Anytime it should not be collected from the bag. If it has a port, it can be collected from the port. Otherwise, they have to clamp the catheter. Even for the port, we have to clamp the catheter, and approximately you have to aseptically clean with the surgical spirit, and then use a syringe and it to aspirate the urine from the tube. All aseptic precautions to be followed. Then it has to be sent to the lab for culture and never from the urinary bag.
Time of removal, the tip of the catheter has to be sent for the culture.
Yes, madam. That also can be used now. Unnecessarily, without indication, catheter should not be prolonged. Period it should not be in situ. As early as possible, catheter has be removed. Yes, sir. As sir correctly pointed out, so readiness to removal of the catheter every day. So that is actually every day we should assist to remove the catheter. The chances of removal of the catheter should be assessed every day. And the initial empirical therapy was changed to injection fibrosing vasoconstrictor by the surgeon. And this is the initial result show the leukocytosis, awaiting the urine culture report. Gram stain cells of the urine, so many persons and many GNB. So empirical antibiotic is started in this case with the piperacillin tazobactam. Sir.
Break, already patient was surgical prophylaxis antibiotics was given. Here, piperacillin tazobactam can be used, but the removal of catheter and the biofilm disruption is important. Only if symptoms are there, we can continue the antibiotic, otherwise it can be de-escalate. Yes. Ma'am.
With the background of African abdomen, here the coffee, I think, was raised from 15,000. If the patient is doing well, we can continue with the test. Otherwise, if the patient is developing symptoms, we have to escalate to the tapping of the
So this is the culture result. And third surgeon reviewed the culture result. So the growth of Pseudomonas aeruginosa 10 to the power 5 colony-forming unit per ml, sensitive to amikacin and verapamil, resistant to ceftriaxone, ceftriaxone, piperacillin tazobactam, and cefepime norepinephrine. So antibiotic change by to amikacin and renal functions are monitored. Renal parameters monitored. Patients systematically improve and strict glycemic control and monitoring for sepsis and renal impairment. Then, so in this case, which antibiotic is preferable in this case? Because amikacin, verapamil, both are sensitive. So the main this question is related because the AMSP, one of the important is cost effective without compromising the quality of treatment. So that is the main goal of the AMSP. That is why this question.
If patient is already on the third generation, that was good to give this add on with the application. And
Yes.
just watch for the signs.
Sir.
As Madam told, we can add on amicus because patient is already in the cover of piperacillin and tazobactam, and mostly the aminoglycosides like gentamicin, amikacin, they should not be given alone. Along with the beta-lactam antibiotic, the cell wall disrupting antibiotic, they have given because this acts inside the cell.
Yes. So monotherapy is usually not indicated, particularly when using the aminoglycosides, except in rare, if it is uncomplicated UTA, we can use monotherapy. But other cases, as I said, monotherapy with aminoglycoside is not advisable. This is some key points. Of course, the main diagnostic laboratory stewardship. So for the audience, so culture identification and antimicrobial sensitivity by automated system. In this case, we are following a conventional system. So we 11 millimeters. They are not followed MIC and all these things. So we follow the automated system to improve the AMSP program. And rapid non-culture tests like CRP that may be helpful whether the patient is having bacterial infection or not. And improve the reporting and communication. That's the main important thing. So improve in the specimen collections using appropriate rapid diagnostic test and use of local antibiogram. So the local antibiogram is the main cornerstone of the AMSP program. So before starting any antibiotic, what is our local antibiogram? That will be helpful in deciding which antibiotic will be continued. And reporting in hospital, so 24 hours availability and the early start of the report. So the reporting is very communication and reporting communication is very important. So already making facilities to communicate to the clinician directly through the phone. We are following this. Particularly important cases, ID culture positivity. Sir is specifically instructed to give a communication to the concerned department assistant professor regarding the organism and also this specific sensitivity report. So this is our step that is very important. So the implementation of the reporting and communication is a cornerstone to make the MSP program successful. And infection control measures, of course, should be taken as standard precautions to be followed in this case quality. So, average TAT, location specific antibiogram, sample collection technique, and all these things to be reinforced and regular training should be done to minimize the antimicrobial resistance. And thank you.
Antibiogram, they are assessing and every year antibiotic policy is being released. Based on that, we are choosing the antibiotics. In DMER also, every year we are releasing the antibiotic treatment guidelines. Thank you, sir.
Sir, student man, we have received the culture, culture and censorship method only. If provisional diagnosis is provided, even previously, Namda members, we reported plasmation as well as microbial. If the presumed to be primary practice, the diagnosis is the provisional diagnosis, we try to avoid reporting microbial and plasmation. In this case also, we put the R-fluxes, even though we are resistant, we put us in R-fluxes in a complicated youth infections. EPCA unit, we try to avoid reporting or fluxing from typhoid. So this is what request from our bank. Thanks.
One
Write a request that it has to be correlated with the clinical features. And repeated candida isolated from urine also has significant value.
Suppressed candidate, immunosuppressed patients with the other clinical features. So for raising total count and with persistent fever, you need to give importance for that, and we might have to ask fluconazole 150 or 200 maybe for the 2 weeks. Even if that doesn't is not enough, then we might have to escape even to so it all depends. As clinician, we cannot go with the only key reports. As I said, the standard reports are commented. So we need to be very careful in deciding whether that's the positive or cancer.
Yes. Thank you, sir. Thank you, ma'am. Thank you.
Thank you, sir, ma'am, for the wonderful session. We are grateful for the knowledge and experience you have shared with us today. Now it's time for felicitation. I request Dr. Balaji, sir, Associate Professor of Microbiology, to felicitate Dr. Parmala, ma'am, Professor, Head of the Department Surgery, GKMC. Thank you, sir. Thank you, ma'am.
Okay, Dr. A.
About the topic, which is a one
Yeah. So,
After one and a half, there is a small announcement.
audio மட்டும்
Yeah, after the
So first of all, why perform antimicrobial stewardship? This slide or this statistics, I don't know how many of you saw from today morning. The organisms, and also the less number of antibiotics in the pipeline, antibiotics developed in the environment, and also ineffective sanitation, infection control and measures. Most importantly, the lack of enforcement of legislation and lack of awareness and education. So these are the important factors that contributes to the different infection. And incidentally, in our country, First one is the prevention of infection. And second is that stewardship. So it is not infected process.
So this is the kind of dream where we thought in the public institution we should have no automation. We have been trying very hard for many years. Ravindran sir knows about this. So this 5 years.
அவர் சார்ஜ் மாத்தினாரு இல்ல இப்போதைக்கு போன்ல இருக்க சொல்லிட்டேன் நிறைய எதுவும் மாத்தி விட்டாரு போல
from this side. So,
நான் பாக்குறேன்
so this is
ஆப்ஷன் தான்
most important So one of the solutions are somewhere we have very sanitary solutions which is allowed. First, so it's not means that we made how much they have increased the resistance. These are patients. We always challenges them not increasing symptoms. And another information is so complex what
அவர் பேங்க் மாத்தினாரு கட் ஆயிடுச்சு
and also the microbiology and the training. This primarily such campaign which they want to this because of the language and secondly is the question the country but when the stage of antibiotics. So recently 2 or 3 years ago we have also very along with that. So
இது வருதா இல்லையா அவன்
processing of the results before we see the results of treating that. So these are the aspects which we need to take. This is a snapshot of the various guidelines what we have from the world. So this says that how the blood culture should be done. So they say that all the guidelines, all the committees says that you have to collect at least 3 sets of the blood culture that includes aerobic and anaerobic. And the volume of blood culture should be 140 we will be able to achieve this volume 40 to 60. And the patient within 2 hours has to get into the system. And whenever there is a delay in the transport, it should be incubated in the room temperature. The examination of phosphorus goes without saying that it should be as early as possible. Graphic should be incubated to that. And length of incubation can be of Friday. Next we move to vital. As we all know, it's a fully automated identification and antibiotic substitution. These are some statistics like we have about 15,750 combinations and around 197 antibiotics, different antibiotics can be tested. And we have around 3,180 resistant mechanisms can be detected in Lipoca. So the main objective in our day is to detect the resistant mechanism. Which also finally reduces some antibodies which has not been. So what do I do? This whole machine. So what do I do? So MIC there is common use like interrogation. You can use a regular MIC does for the comfortable. So what is by the green pitch? That is not natural system in the brain. So the waiting system is there. So higher in top, we have for example, or so this case, I think it's the extension to William's largely present. So this example is also similar. So the organization is 60. So the big the MIC value is 1.5 microgram per test. The vaccination goes of 1.5 gram per army is needed to achieve the target of 600. 600 by 1.5 away, you are achieving certain target. But what if MIC is there? So this is 1 point. What if MIC is really there? For example, 0.5. In that case, should I do the same? No, the reduce the glucose. For example, point assuming it to points like I or like that because here the target is 200. 200 divided by 0.5 is 800. So we are the nephrotoxic is costly and
So next we move to the syndromic approach, the biomass system. So the syndromic testing significantly reduces the time to because normally the conventional you take day 3 to start the targeted antibiotic. In case of syndromic testing, you are able to reduce the time significantly by day 1 or day in 1 step. Because it is done on the specimen, you will be able to reduce the time. So there are some 6 panels which we have, of course, respiratory panel, blood culture, PCID2 panel, TI panel, meningitis and encephalitis panel, pneumonia plus panel and the biofire joint infections panel. So these are the biofire panels here. I am not going into the detail. So how does it test? Especially for example, the blood culture positives, once the bottle becomes positive, it can be done on the biofire. 1 hour, the runtime is 1.5 minutes. So roughly in 2 hours, you will be able to know what is the positive organism. And also you get to know the AMR. So which will help you in tailoring the antibiotics which you have started already as a so there are n number of studies where they compare the liquidity of the BCAB2 panel. So this is one important study where actually we talk, they compare. They have 3 arms. So one is the control arm, and the second arm is the biofire BCAB panel, and the third is the biofire BCAB panel with antimicrobial stewardship intervention. So what they found out was interesting. The traditional method, no, everything was normal. Like, you get the ID 24 hours and you get the AST in 48 hours. In BCAD, they were getting the ID early and they were able to estimate fast based on the identification. But when it is worked with antimicrobial stewardship, what happens is that de-escalation has reduced from 36 to around 12 to 14 hours. So this makes a very clear distinction or advantage where you can de-escalate the antibiotics with the help of BCAD2 microbiology blood culture when it is worked only with the antibiotics. Otherwise, it doesn't make any sense. So next we go to the battery talk. So battery talk, all of you know that the Vitec MS file is there. We have the Vitec MS system. So which will give the identification very fast. So, how many of you think here that once you get an identification from Mali should be reported fast? Should be reported or should be sent it along with the culture, comprehensive culture? Once the ID is ready, it should be reported, right? We can. We have to. Different guidelines they can follow. Okay. Based on the identification, people can make changes in the antibiotic therapy. Somehow I think that this goes through this manually, but somehow people with Vitec, they don't report identification because in Vitec also you get the identification early compared to the sensitivity. So the same follow-up principle can be done in the Vitec 2 system. So Vitec will include our so wherever there is awareness, education, awareness is that people are asking for it. So there is validated protocol for easy and fast micromanipulation. And also you can prioritize the site which should be done first. And it allows the slides to be loaded and continuous load of. So this is the advantage of Vitec first. So here also similar to the syndromic approach where we saw very much with the antimicrobial stewardship program. So there is a significant difference. Here also they were able to reduce the length of stay. They were able to reduce the length of inpatients antimicrobial therapy. The number of days they were able to reduce. So this is something new, Vitec reveal. It is not yet launched in our country. So we are shortly going to launch. This is for Vitec reveal. This is mainly for currently available for gram negatives and blood culture positives. Because what we are doing is you do the identification in a biofire. Okay, you get to know the AMR genes in the biofire, but you don't get to know the sensitivity. You have to wait for some more time. But this Vitec reveal system. It's a sensor-based testing where you see the plate and you get the color changes. Based on the color changes, it tells you whether the MIC, how much is the MIC. And the time to result is in 5.5 to 6 hours. So when it is plugged with biofire and the Vitec reveal, you will be able to do a lot of stewardship activities because it reduces the time significantly. You don't have to wait for 48 hours for it to get it. Once the blood culture is possible, side by side you can run the biofire system along with the Vitec reveal, which will give the MIC in 6 hours. So there are some interesting studies where the Vital reveal has reduced the time around 16 hours, time to result and time to AST, and the time to adapted antibiotic also reduced by 24 hours. So this can significantly change the way how the patients are managed and it will help you in the antimicrobial stewardship activities. Without biomarkers, we cannot end this talk. I'm also discussed about the role of biomarkers. There are n number of biomarkers, but there are some significant biomarkers like procalcitonin, which is kind of which is very important when in comparison to the other biomarkers. For example, CRP and lactate. This is the area under the curve. You can see the PCT area under the curve. It is more than almost close to 1 in comparison to CRP and lactate. So I'm not saying that lactate and CRP is a bad marker. Okay, because at what point of patient's diagnosis pathway we are using based on that it gains importance. The biomarker gains the importance. So because lactate is very important, the first line I include in the surveillance sepsis guideline. First thing is to measure. Biomarker is more important. So PCT now it is considered not for diagnosis, more for prognosis. So, but in that case, we really cannot be helpful. You will do the serial testing, then only we will be able to do. Why? Based on that, if there is a significant drop in the PCT level, you will be able to discontinue, let's say discontinue maybe everything, but de-escalate from 3 antibiotics to 2 antibiotics to 1 antibiotic. So based on this, it can be done. So, so we are generating so much of data, whether it is manual or automated systems we generate. But if we don't make use of those data, it is going to be useless. Okay. So can it help in making that informed decision, taking informed decision? So we have the software. Previously it was called Myla, now we are calling it as MySphere, which will help in understand the epidemiology and also the fighting the antimicrobial resistance. So there are some 16 statistical modules in the MySphere software. So we includes like what is the positivity rate, how much, what is the antibiotic, okay, and what is the MDR, that is multi-drug resistant organisms per patient. What is blood culture contamination, micro detection, cumulative MIC. So many statistical modules are available. So if this software is connected to the biomenu solution, with the click of the button, you will be able to get this thing. One example I can show is the antibiotic, because that is where most of the human time is spent in preparing the antibiotic. So with the help of this MySQL software, we will be able to get the antibiotic with the click of a button like this. So this tells you how much is the percentage of susceptibility for a particular organism in a particular ward or particular institution. So that you can devise your antibiotic policy and also decide on the empirical. Waiting there to be loaded into the system, and how many are positive waiting for the labs need to be done. So it gives a real time information on what is happening inside this, also in the lab, so that you can guide the people to know what needs to be done at the lab. And it helps in the quality issue and areas of improvement, because it tells you what needs to be done based on the data driven decisions. And as I told you about the antimicrobial stewardship, monitor trends in organization occurrence and resistant patterns, and also improve the work of empirical. So this principles of antimicrobial prescribing, I will just share this. This was already shared by Dr. Vidya in the talk. So it is an acronym called MIND-ME. So I am not going to repeat again. The microbiology guides therapy indicated to be evidence-based, wherever possible, dosage appropriate to site and psychoactive. Again, minimize dosage and duration, and ensure monotherapy most of the cases. So standing here, I cannot say that please follow this.
Okay, because you are the people who are treating the patients, you know, but wherever appropriate, if this principle can be applied, we can reduce the antimicrobial resistance because we can only reduce the antimicrobial resistance. We cannot protect into it because it's a natural process. So this mind me is something like the antibiotic is telling us, please mind me. If you mind me, I will take care of you. Otherwise, we are good. And this is a very interesting statistics which I came across. It says that the interventions of the mortality. Okay. So we all know from the morning today's talk, we all know that it's a antimicrobial stewardship is a behavioral change. Okay, that is the change in the behavior. So here the interesting fact, how much percentage of people accepted the intervention, how much people rejected the intervention. So whenever they accepted, the percentage of mortality was less. Or whenever they rejected it, the percentage of mortality is high. So which means that there should be a behavioral change in the all the stakeholders, including the clinicians and people who are involved in the treatment of the patients. If the acceptance of the intervention based on the antimicrobial stewardship program that has been designed for that particular institution, if you can make the changes, then only you will be able to see the reduction in the mortality rate or better clinical outcome. So this clearly shows, for example, discontinue antibiotic. How many of them have accepted or how many of them have rejected? So whenever they have accepted, the mortality rate is less. Wherever they have rejected, it has grown increasing. So overall, the acceptance level, there is a reduced mortality, but when there is a rejection, there is an increased mortality. So this is very important for us to know. Someone has studied this to tell us that how is the difference it is making to the patient management of the mortality. So overall, I just compared this AMR drivers and biomanipulations. Overuse of antibiotics, diagnostic gap is there is no rapid diagnosis. So if you have help of biofire or syndromic testing, you can avoid unnecessary antibiotics. And broad spectrum usage is another AMR driver. Slow organism ID, which means if you are doing the manual method, with the help of malady talks or biofire, you can have a targeted therapy. Inappropriate drug, do not have a delayed antibiotics. Again, with vital 2 or vital 3, you will be used to the right antibiotic. Prolonged therapy or late to the diagnostic gap of late optimization, which means rapid workflow integration. So it's very important that you integrate the identification and the sensitivity report, and whichever is ready first, it should be reported to the treating physician. So based on that, they can do the AD de-escalation or escalation. And last is lack of oversight, which means there is no data entry. So with the help of software like Maestro, you can do the data-driven antimicrobial stewardship. So some facts I thought I will present for considering. So today the most of the world is fighting AMR without access to diagnosis. So this is very important. Okay. And second is even if they have access to the diagnostics, if it is multi-drug resistant, do they have access to the costlier antibiotics? So that is another aspect. So people say that without diagnosis, we are not just under review but blind. And create conditions for further drug development. So when is the last time you heard a new antibiotic coming? So when is the last time? Last week there was a new FDA drug by Wockhardt. It's an Indian drug called certified enmetazobactam. So it's by Wockhardt. They have launched this. So, but not very often we hear this good news, like a new drug is coming. So there is not much incentive for the pharma industry to go in for a development newer. And there is a Lancet paper which says that across low middle income countries, less than 7% of drug resistant bacterial infections could access the antibiotics they need. So this is what I was mentioning. If they have a drug resistant, how many people have the access to the antibiotics that can be the cure? Increase the investment in innovation and strengthen the fragile antimicrobial pipeline. New antimicrobials are needed to meet the global demand and unmet needs. And antibiotic research is slow, costly, and there is a high risk involved. This is very interesting. Only 1 in 30 candidates, antimicrobial molecules, will reach the patients. So 1 in 30 reaches the patients. Last but not the least, it should be backed up by the national. I saw many of the case studies that have been referring to our Indian national treatment or the guidelines, national treatment guidelines. So it's a very good thing. It should be backed up by this national. So last slide, the diagnostics and antimicrobial stewardship. We have this metro map. The metro map says there are three different zones. One is the antibiotic initiation zone, antibiotic optimization zone. The last is antibiotic discontinuation. So in each zone, we have solutions for us to implement. For example, the initiation zone, we have the biofire panel. We also have the Vidas trans PCT. So with the help of the PCT, you will be able to choose which whether to start an antibiotic. In the optimization therapy, we have bacterial, white type, E test, etc. And lastly, in the discontinuation zone, we have the PCT, trans PCT, which will help you to discontinue or de-escalate the antibiotics. So this is my last slide. So accurate and rapid diagnosis, both phenotypic and genotypic, helps to manage infections with the right treatment at the right time. Precision medicine based on the knowledge of resistant mechanisms becoming increasingly important. Nowadays, automation is not optional, but it's a mandatory thing. See, now all the public institutions have got this automated system. So now it is no more a breed. All of these institutions have this. It is up to us how to optimize this. So the best result can be achieved at the impact of rapid diagnostics when that is integrated into the work. For example, the biofire, the blood culture bottle becoming possible. If we wait for the next day to get you the ID, okay, and do the antibiotics and treatment, instead of that, if you integrate this biofire into the regular workflow, you can do the results fast. So this is a kind of reflex testing many of the hospitals are following. Second is when we communicated on time. So there is always a question: how many times we have reported a blood culture positive in the night? 3 a.m. Very rarely we do that. And another important aspect is how many times we have acted upon the result that has been told. Okay. So we inform the treating physicians, but how many of the time it has been acted on? And last is the topic today. When it is integrated into the antimicrobial stewardship program only, it can have some otherwise it becomes just a piece of. So thank you very much for your patient listening. There are any questions? I'm happy to. Let me talk more of the bio. Give the idea and then so you need to collect the panel as we have 6 panels that come here. So one common panel that is being handled as very basically the VCAD2 panel. So this VCAD2 panel is once the blood pressure bottle becomes 80, you cannot do directly on the 80 to once the bottle becomes positive, you do it. So it tells you what is the complex organism that could be causing the investigation. It has got 10 AMR genes. It includes gram negative and gram positive AMR. It's like midway, Indians, oxide, everything we have. So it tells you with the gene that has been developed. So in that case, it has also got MCR. So if you are using an MCR, no policing, MCR only detected, there is no conflict continuing. So you can change the treatment based on the direction of these particular genes. But it cannot be done in isolation because next day we have to get the phenotype. But 24 hours time is very crucial. We can make changes within 24 hours so that we can make. Similarly, we have a delineated panels. We have a GA panel, also pneumonia panel. So all of them have those it's the kind of AMR linked along with this. And second, the VCD panel has the atlas including the voice. It's also the kind of 90% of the time we take the Thank you, sir.
One question. I would also MIDA software. We find actually it's difficult for us to interpret the reports from the system from the MIDA software.
He's been through the RHMIS. He just manually typing the reports. Is there possible to convert it or directly integrate it into the HMI system? We don't have a final.
You don't need that, you just have analyze. Analyze that is more than sufficient.
Okay.
Either will kind of consolidate all the data from different variables. For example, Vitec.
Now currently we are entering a couple of manually. Is there possible?
Yes. Purpose of automation is to reduce the manual work, manual intervention. But if you continue to do that, you will not be optimizing the.
It would be better, like Madam is telling, what FoodNet can be integrated with Vitec. Because most of the things we enter into the FoodNet and we get the data for antibiotic policy making and the.
There is a function for you to extract the file from Vitec, then Excel, and then load it in the FoodNet. So let's
Maybe you have to give us a training for that also.
Yeah.
Because we find it difficult to enter and present
very
as
simple. Already there. There is no point in reinventing the wheel. It's already there. Just extract the Excel file, load it into the Excel. That's the easiest.
Thank you.
Thank you.
I request our HOD sir, Dr. Priyanka Thakur, to facilitate some and Siddharth by the next for this wonderful session about the automation.
Thank you.
Thank
you. Sir, thank you, sir.
Thank you, sir. Thank you so much.
Insections. So
now we will move on to our quiz, which is going to be conducted in online. So we will share the link for quiz. As soon as the link is shared, the quiz time starts. And you should give your responses rapidly and accurately. So I think you would have all read the instructions already posted in the group. So based on that, winners will be announced shortly. So we will share the link now.
No, the cat that way. அது அவர் பண்ணணும் நான் பண்ண நினைச்சுக்கணும் லிங்க் குரூப்ல ஷேர் பண்ணிட்டேன் hence by 4 so you get there
Any difficulty in joining or some other issues? Contacts.
அது இங்க எடுத்துக்கலாம் இங்க எடுத்துக்கலாம் என்ன முடிக்கல
Entrance. Oh, it's not bad.
First time has ended now. So after this, the conference will not be taken. You can respond to the open of the.
Okay, okay, I can cut them. Operator, you will not intend that. Sir, video RR. Post பண்ணுவாங்க சார் பண்ணணும்
பண்ணிடுங்கப்பா.
சார் ஒரு நிமிஷம் சார் சார் ஒரு நிமிஷம் அப்படியே இரு. நான் இது பண்ணி எக்ஸல்ல மாத்திடுறேன் என்ன சொல்லுவோம் ஒரு நிமிஷம்
இதுக்கப்புறம் ஆன்சர்ஸும் ஸ்ப்ளிட் பண்ணிடுவாங்க.
டிஸ்பிளே ஆன்சர்
ஏய் என்ன
சொல்றேன் டைப்பை கிரியேட் பண்ணுவேன்
The second place is goes to Mohammed Farah, who has scored 60. And he also scored so quickly within 8 minutes. And then the third place goes to 50 marks, SK. I'd like to highlight SK's. SK pride is only pride, which is the professor, only speech for qualified from the pride.
Next one, next Dr. M. Nishanti.
Dr. M. Nishanti, in place of Professor Srinivas, we are announcing Dr. Nishanti, third prize winner. Thank you for your participation.
Sorry.
Thank you for the feedback forms.
Answers
With the patients, we can address what is
நீங்க
the
வச்சிடலாம்
instructed for the group.
நம்ம வெயிட் பண்ணி சரி வாட்ஸ்அப்ல அனுப்ப
சரி அனுப்பி
இரு அது
Thank you.
The maximum time for your participants. Yeah, those answers are posted in the room.
Okay. What's up?